manage the uses of social media. So implement screen time limits, use apps to monitor and limit social media, because there are many apps which are there, particularly in iOS there is a screen time, particularly in Android there is a number of other apps like digital well-being. So such apps are there which give you daily charting of your screen time use. So if you really want to manage such things, we can use those screen time limits and we can use according to them. Then create tech-free zones. Designated areas like dining room, bedrooms and the sleeping rooms, they must be no screen zone. And if we can practice these kind of activities, these kind of approaches, then probably we can manage the use of social media. Then promote the purposeful use of purposeful use with the good contents, because we can communicate with the similar community. We can have an open discussion about that, how to give a periodical break from the digital device to promote mental well-being. So such kind of things can also be good to manage uses of social media. And then we can also encourage various kind of the offline activities, which also helps us. Offline activities like nurturing those hobbies which you love, sports activities, face-to-face communications. So these are the few things which can also be helpful in an approach to manage media, to manage the uses of social media. And the one thing which is also very important here is be a role model, because we talk about that. We are discussing about the negative impact of social media. We quite often scold our children, our kids about this. But simultaneously, we are doing it while we are busy with our own social media app. So be a role model about that. If you really want to limit that use, then probably you must first become a role model, then approach further. So these are the few things: establish clear guidelines and encourage offline activities, open communication, model healthy habits. So these are few tips which has been created by which has been created. The tips for parents: manage your child's screen time, agree on the clear set of rules in your home about the screen time, follow the rules, be a role model, as you say, know when to unplug and curb your own bad digital habits. And there must be a free, we have already discussed about that, the phone-free zones, restrict the use of mobile phones and computers in bedroom and dining rooms. So these are the few. Use an alarm clock in your child's bedroom and do not charge mobile in your child's bedroom. Because this is one thing which frequently expose them to phone and mobile phone, which further promote them to use such things quite often. Unplug every weekend, set few hours to unplug the internet, enjoy family games and activities, and explore and discover the online world with your child. And we must discuss the impact of these things with our children. How the Facebook is there, how it is acting, what are the benefit of this, and why people are posting quite often such kind of specific type of pictures, why they are again making again and again stories, what is the aim of doing this. So if we can discuss about these things, then probably we can make an insight about the effect of social media on our health. Challenges of social media on mental health: it increases the risk of mental health disorder. Excessive use of social media is strongly correlated with the development of anxiety, depression, insomnia, stress, decreased subjective happiness, and sense of mental deprivation. Negative impact on self-esteem are also there. The social media platforms, they negatively affect our self-esteem through unhealthy comparison, social media burnout, different kind of stresses which is being generated by the social media, lack of emotional regulation due to the social media preoccupation, and development of the social anxiety. So such things are there which are impacting on our mental health. Similarly, social media act as a coping mechanism also. Many times, if a person is suffering from depression, anxiety, or isolation, then they use social media and use is given by the pre-existing anxiety. So they are using it as a coping strategy for their own problems. Similarly, preference for online communication. The emerging research shows that the people with moderate to severe depression, they prefer communicating on social media rather than in person. So this is again, many times it can be indicator. It can be indicator for some underlying psychiatric problems or for underlying some mental health issues. So we can also think of it when we are evaluating somebody who is having social media addictions or social media excessive use of social media. Then reduce face-to-face interaction. The social media may overcome the deficit in the social interaction due to the psychotic symptoms that are typically adversely affect face-to-face conversations. So we see in our day-to-day OPD practice also. Many times the children and the younger kids, they are being brought by their family members, and they complain that they use social media quite often. So when we inquire about that, then the patient says कि सर और सब मेरे को वैसे बात करने में बड़ी झिझक होती है, मेरे को पल्पिटेशन हो जाता है, मेरे को घबराहट हो जाती है, तो मैं तो मेरे दोस्तों से या किसी से भी जो है ना वो सोशल मीडिया के थ्रू बात कर लेता हूँ, तो उसमें मुझे ऐसा फील नहीं होता. तो sometimes they are also indicative of underlying psychopathology, some underlying mental health issues. As far as the diagnostic criteria related to social media are concerned, the DSM-5 though does not formally recognize social media disorder, but it includes the several related categories. It includes the internet gaming disorders, like which is under further evaluation. Other specific and unspecified behavioral disorders, major depressive disorders, anxiety disorders, body dysmorphic disorders. So these are the few other categories which are related with this, and they are under evaluation and they are under more studies for the DSM-5 category. There are again ongoing development in ICD-10, which is released in ICD-11, which is released by WHO, now includes the gaming disorder under addictive behaviors and may evolve to include broader digital addiction category, including social media. So the few studies are going on regarding that, and hopefully the way things are moving, the way things are there, then probably such things will be in ICD-11 or DSM-5 soon, and they have to incorporate this looking at the extent of problem. Now come to the role of psychiatrists. Educating patients is one. Psychiatrists should educate patients and families about the potential risk and benefit of social media uses, raise awareness about the sign of problematic use, promoting safe and informed uses and its effect on sleep, anxiety and attention deficit. Whenever we see any person suffering from excessive use of social media or approaching you for some other comorbid conditions but having this problem, so we can always educate parents, patients and their caregivers or their family. Then assessment and diagnosis, identify the social media addiction if it is there or it is just overuse. Then also evaluate comorbid conditions. Because I have already discussed about this, how the comorbid conditions, they also predispose them for the most use of social media. So we must be aware of this fact also. Then come to the treatment and management. Definitely the psychotherapy, psychoeducation one, then psychotherapy if the condition is there, if it is leading such interventions. Then CBT, motivational interview, mindfulness-based interventions, they can be helpful for such patients. Pharmacological support may require if the patient is needing treatment for anxiety, depression or OCD. Digital detox plan can also be planned. They can also be part of your management to reduce and regulate the screen time and to improve the digital So this is the condition which we are seeing right now, and I think the way every year we are seeing by studies, the use is increasing, the use of internet is increasing, the use of the social media is increasing, and the impact of such excessive use on your mental health and even on the physical health is also in life now. So it has. So we need to look into this condition, and we need to think about that. And I think for the newer psychiatrists, social media has sparked a new era of psychological crises, demanding sharper, swifter responses from the modern psychiatrist. Because the way things are moving on, we need more training, more discussion, and more interventions related to this problem. So this is all about my presentation, and these are few references which I used for making this presentation, and with these things I am going to stop my presentation, and thank you all for the patient listening, and simultaneously I am also would like to thank my residents, Dr. Anushri and Dr. Vitesh, for helping me out in making this presentation. Thank you all.
Thank you, Dr. Lalit Batra, sir. Thank you for this wonderful presentation. Indeed, this is very significant, pertinent and crucial topic to listen and to implement. And you wonderfully described everything in a balanced way, with all figures and facts and prevalences and incidences all. So, congratulations, big congratulations for this wonderful presentation. Now we can invite few questions if anybody wants to have, anybody want to ask anything in the form of questions, or I think Dr. Batra has already explained a lot of things, but if somebody has got some query, please go on. Any questions?
Question exactly. It's a comment that management of every such person who has got involved with excess media use, specifically an adolescent, it requires a team of workers to manage an individual. We come across many children who are actually not presenting to the psychiatrist. It's a suffering parents who are presenting to the psychiatrist, and to make an approach to such an uncooperative patient, probably we do require a psychiatric social worker who can make a domestic approach, and there might also be to think in terms of role of a teacher, a person who is teaching the sufferer patient, or I am specifically talking about adolescent patients who are problem in such cases. So maybe a few comments more for that. Thank you.
You are absolutely right. You are absolutely right about this. Because we need a combined approach for managing such type of problems, because they are basically psychosocial problems also. So primarily they are psychosocial problems right now, and they are and these problems, they are impacting on your mental health as well as physical health. So whenever such patients come and such clients come for any help, we need psychologists, we need social workers, we need even the family members, we need regular psychoeducation, and then the intervention by psychiatrists is required. So no doubt about this, we need a combined approach to manage it.
It's always a pleasure to listen from Professor Lalit Batra, the way he takes us from very basics and then to depths of differential processes. Sir, you might be also aware that now the European consortium led by Denmark group, they have started identifying how close are we able to reach out to define where the margin of addiction and not being addicted to social media comes upon. And now they have come out with a figure of touching the smartphones or the phones or whatever devices you are using for 900 times a day. Because that figure apparently reaches to a point of conclusion that you are going to cross more than 7 hours, which defines the minimum amount of time for which you need to rest your body. And there the actual panorama of shifting the neurobiological processes happens. Do you think, because you have seen so many patients, so many scenarios as such, is this advocated that certain impulse controlling medication should be advised for the screening programs or those who are actually doing it on a larger scale basis, and the parents are really worried about them and then they bring it out? So as a psychiatrist, how do you actually advocate the kind of treatments to do so? Thank you. Professor Praveen Kherkar from Pacific Institute of Medical Sciences, and I'm also visiting faculty for Apollo Hospitals, Hyderabad and Chennai.
I think we need to evaluate the patient first in such type of cases. Because if there is a impulse control kind of things, then probably we can think of using such drugs. Otherwise, the behavioral modifications and the psychoeducations and the behavioral therapies, different kind of the behavioral therapies, probably if we can start practicing those things from the early, then probably it can help us in managing such things at the initial level. But yes, if there is a impulse control disorder, if there is an increase in impulses, and we think that this is irresistible impulse and probably cannot be cured with the psychological management and psychological interventions, then probably we can think of using drugs.
There is another kind of a technique, I'm sorry to be a little mouthful, another kind of a technique that's called neurobiofeedback. It's a program where specific biomarkers can be used to identify how actually more guilt or problem or anxiety you are getting out of whatever devices are you using. Are you happy? If you are happy with whatever you are doing, perhaps there is no need. But how do you know that somebody is actually happy or somebody is actually not? So there is a parameter called GSR, Scheme Galvanic Resistance Program. You can add that with the neurobiofeedback systems. The levels, any levels above 1400, 1500, where we are actually trying to figure it out, where the biomarkers can actually change the outcome process, and whom are we required to. We do believe that this kind of technologies, it can be used as biomarker. It will give the clear demarcation that the biological process of the addiction is actually more important than the vagaries or the non-specificities as such. Thank you so much for your comments. Thank you once again.
I think this is a wonderful comment. At least objectively, we will be able to see the parameters or the abnormality in some certain figures, so that we can explain to the patient or person who is suffering from severe mobile addiction that you are suffering from this problem and this is your levels. Kindly correct it. So I think this is one of the very good objective assessment technique. I wonder if Dr. Batra could a little bit tell us about the sleep reversal process by using the excessive mobile use, mobile addiction, and the disturbance in circadian rhythm and biological clock.
No doubt it is there, and we are we see every day having this problem in our routine outdoors as well as in routine conversation. People are sleeping at 3:30, 4:30, and they are getting up around 11 in the morning, 12:31. So the sleep cycle is changing, and the impact of changing sleep cycle on our health is also, they are well-known facts. So it is there, and whenever such patients come to us, then we also always advise them to first correct your sleep cycle, because it allows you to uninterrupted use of social media. Because when you are doing it in the night time for a longer duration, probably in daytime you will be busy with a lot of other activities, and then you will also see the people around you who can directly or indirectly inhibit you in using social media. But when you are in night time and your cycle is changed, then probably there will be uninterrupted time. So by correcting this sleep cycle, it can also further reduce the use of excessive internet or social media. So
topic. So we are advising. The COVID impacted the indirect way by penetration of the mobile and internet to the primary school children, and they are unable to handle the situation and information they get from it. And nowadays the cases are very much increasing in the teens and pre-teenage of the mobile addiction, and this is very dangerous situation. I think we, as a mental health ambassador, we should handle and we have to be careful about it. Thank you very much.
Thank you, sir, for such an eye-opening session on digital dilemmas affecting our youth. It was insightful and deeply relevant. With due respect, I would like to invite our chairpersons to felicitate our speaker. And may I now invite our coordinator, Dr. Lalit Batra, sir, Professor and Head, Department of Psychiatry, Savai Mansingh Medical College, Jaipur, to come on stage and felicitate our chairpersons. Request the following chairpersons to join us on the stage. Dr. T. Mahatma, sir, Professor and Head of Psychiatry Department, Internal Heart Care Center, Jaipur. Dr. Lalit Batra, sir, Professor and Head Psychiatry Department of Savai Mansingh Medical College, Jaipur. Dr. Ajmer, sir, Senior Consultant Psychiatrist, Kota. Now we invite Dr. Parth and Meena, sir, Professor, Department of Psychiatry at Jawaharlal Nehru Medical College, Ajmer, to share his insights on gender differences in symptom presentation and treatment of psychiatric disorders.
So Dr. Parth Singh Meena is Professor Psychiatry here in Medical College Ajmer, and did his MBBS from AIMS Delhi, MD Psychiatry from Jaipur, working as Professor in Department of Psychiatry here in Medical College Ajmer. His total academic experience is almost 19 years, and he is the editor of the Indian Psychiatric Society National Center for 3 years. Started Annals of Psychiatric Research, the official journal of Indian Psychiatric Society, Rajasthan chapter, as editor-in-chief. Currently holding office of the Vice President cum President-elect, IPS Rajasthan chapter. Many research and publications, more than 30 peer-reviewed original research papers, and published a book on treatment emergent metabolic syndrome, co-author of IPS treatment guidelines. We invite Dr. Parth Singh, please deliver his lecture. Thank you.
Thank you, sir. Good morning to all of you. And it's indeed a pleasure and honor to be here to deliver a health talk with such an esteemed audience. And initially, when I proposed the lecture, it was on gender differences and sexual objectification. But the organizers, Dr. Batra ma'am, told me that it would be more relevant if you could deliver a lecture on symptom presentation and treatment of psychiatric disorders. So, and when I was presenting, when I was trying to make the lecture, it was already 390 slides and I was just halfway. So I need to prune it up and had to delete many of the details. So in case you find it inadequate or it's too lengthy, blame Dr. Batra ma'am. So I'll let you begin. Thank you. This is a book that most of you might have heard or at least have read by John Gray, Men Are From Mars and Women Are From Venus. It's a bestseller book that tells why men and women differently behave and they react differently, they perceive differently, and to the same situations and to the same stimulus, why they take it so differently. The same factors that are involved why women and men behave differently normally are actually the same factors which, if we take into consideration into the signs symptoms of psychiatric disorders, they come into the interplay. And the treatment behavior and the treatment seeking behavior is also determined how both men and women are different. So the lurging objective will be to examine gender-based differences in prevalence and presentation of psychiatric disorders, understand the difference of biological, psychosocial and social factors, and to identify gender-specific treatment strategies. So these are the various factors that actually make a man and a woman in a social setting. A set of biological, psychosocial and social factors which include genetic predisposition, sex hormone fluctuations and the neurobiological differences, as well as their cognitive styles, emotional regulation strategies, social cultural expectation and reactivity to stress, as well as how they are the social in the society, how the gender role socialization occur, and the various patterns of trauma and how they react to the different type of traumatic and social stressors. It is generally general view of prevalence between different psychiatric disorders. The big ones are the disorders in which there is a female preponderance, and the blue ones are those in which the prevalence of psychiatric disorders is more in male. So major depressive disorder, anxiety spectrum disorders, post-traumatic stress disorders, and borderline personality disorders are the disorders where there is a female preponderance. On the other hand, substance-induced disorders, ADHD, and antisocial personality disorders, the prevalence is higher in male. We have noticed that those disorders in which the main emotional feelings are suppressed or they are internalized by female, those disorders are more common in females like anxiety and depression and PTSD. While men as such, they tend to externalize their feelings and their emotions in the form of irritability, aggression and substance abuse. So such disorders are more commonly found in males, and because of the socialization, gender socialization, men tend to seek help after a certain delay, and they also tend not to express their emotions in the clinical as early as females do. Coming to the biological aspect, the hormones have certain effects on the way male and female psyche is shaped. For example, estrogen have a neuroprotective shield which actually helps them from psychosis, particularly late, from early ages. And we have seen that the second peak, there is this, in the psychotic disorders, there is also a second peak which actually collaborates with the decrease in estrogen levels. Progesterones are more important to the cyclical fluctuations like that happens in premenstrual disorder or prenatal depression, perimenopausal disorders, and menopausal mood shifts and changes, and the changes in the severity of mood disorders. Testosterone, on the other hand, is related to aggression and impulsivity, and it has been related to antisocial behaviors and risk-taking behaviors like substance abuse, unprotected sexual activities, and gambling, etc. So there is a high prevalence of externalizing disorders in men because of this effect of testosterone. Coming to the neurodevelopmental disorders, usually females have higher amygdala activation and higher prefrontal cortex, which results in enhanced emotional processing. And on the other hand, there is a larger volume and larger activation of parietal cortex in males, which results into more visuospatial and motor skills. Their left hemisphere is also more stronger, which lead to more of analytical skills in males, while the limbic cortical connectivity is more strong in females, that result in better emotional expression, better emotional awareness, and emotional integration. When we compare boys and girls in the teenage or at early age, we have often observed that females tend to have early cognitive maturation, as well as their emotional regulation is also developed earlier than in males. And in males, the analytic mind and the motor skills develop earlier than in females. One of the most important factors how male and females behave normally and in psychopathological states is their gender socialization. From a very early age, the girls and the boys are told what is acceptable and what is expected from them. Girls are supposed to be soft, they are supposed to be nurturing and emotionally expressive, while boys are supposed to be strong. They are not supposed to express their pain, they are not supposed to express the stress, and are supposed to be independent and assertive. There are common idioms like boys don't cry or mard ko dard nahi hota, and often in the Western culture it's said that don't act like a pussy. So these are the idioms which actually they are often used as a motivation for young boys to be strong and emotionally not expressive. So the primary emotional status of women is internalizing, and that's why they tend to have more of depression and anxiety, while in men it is more of externalizing behavior that results in anger and irritability. Women on the other hand are emotionally more expressive, while men on the other hand are aggressive and a bit considered to be antisocial. And it is problematic when male are often classified, misclassified and misdiagnosed, even if they are behaving in a normal way as conduct disorder in males or having antisocial traits in adults because of their externalizing behavior. On the other hand, women tend to express their emotions freely, they are more emotionally aware, so they are misinterpreted as more histrionic or having borderline traits. There are also gender-specific stressors which play important role in the development of psychopathology as well as the symptomatology. For example, 1/3 of women, they experience sexual violence and that they are more prone to develop PTSD. Although the amount of trauma suffered is often more in males, but the effect of sexual trauma is such high that eventually 3 times more PTSD symptoms are found in females. They also have chronic stressors like caregiving roles and persistently from the early childhood until they become mother and become the housemakers. So it's kind of an unpaid caregiving role that they carry over their age that make it a chronic stressor. On the other hand, the stressors over males are more related to job, employment, and as a breadwinner stress, which is 2.5 times more related to work-related suicide that we find in men. And because of their tendency not to express their emotions freely, alexithymia is found in almost 20% of normal males. The behavioral outcome is that males tend to use substance abuse as a coping mechanism to deal with the stress, and they die of overdose 2 to 4 times more than females. And they tend not to seek help, professional help earlier, and tend to delay, and it results in almost 60% of the depression cases remain undiagnosed in males despite having psychiatric help. Gender and esteem is also very important, particularly in a culture because males are supposed to be tough and they are not supposed to express their trauma and stress as a sign of weakness. On the other hand, because females are more expressive, they are supposed to be or dismissed as hysterical, and their normal emotional expressiveness is sometimes considered to be histrionic or an effect of hormone or a hormonal issue. Coming to the individual disorders, first we will discuss the depression. Male to female ratio, it is always higher in females, and it emerges early in females on an average around 3 to 5 years earlier than males, and it peaks around in reproductive years, which is very important in the treatment implications, and it tends to attenuate after post-menopause when both estrogens and progesterone they tend to decrease. A great source of insight and knowledge about the gender differences in men and female in depression comes from the STAR-D study. Most of us consider STAR-D study as a treatment trial and how we compare the efficacy of different drugs. But apart from that, the differences in the presentation of symptoms were also compared in STAR-D study. First 1500 samples were taken, and then again 2541 samples are again analyzed. So they were analyzed 1 year apart. So it tells us that women have earlier onset of depression, the overall severity of depression is higher, more years are spent in depression, and the intense episodes are also longer in females. Females have more atypical symptoms like hypersomnia, and they tend to gain more weight, the appetite is more, and somatic complaints are also more in females. Emotionally, they have a higher interpersonal sensitivity and rejection hypersensitivity. Thought ruminations are more in females because they tend to internalize the symptoms, and they have more of comorbid eating disorders and anxiety. The symptoms that are more prevalent in male are irritability or anger attacks. Even during the depression phase, the irritability is more. So the diagnosis is misinterpreted and just merely as anger issues among men. Even during the depression phase, men tend to have risk-taking behaviors like unprotected sex and reckless driving. So again, the diagnosis is dismissed. Substance abuse is far more common in males. Aside from the second sample, more of information is almost the same, just like that females have more weight gain, they have more GI symptoms, interpersonal sensitivity is more. One important thing that emerged from the interpretation of the second sample is that there is higher suicidality tendency in men. The suicidal ideation is more in men as compared to female, but generally we have learned that female attempt more suicide and the rate conclusion of suicide is higher in males. But it has been found that because males tend to suppress their symptoms or their symptoms are dismissed as anger issues because of their externalization, so probably males might have more suicidal ideations, but actually the rate of attempts is lesser. Female attempts more suicide because they have not only the methods they use to harm themselves is less lethal, so there might be repeated attempts to harm themselves using non-fatal methods. So the prevalence of suicidal attempts is more in females. But it's also important that although the intent is less, but because of comorbid anxiety is more in females, so the help-seeking behavior among females is higher because of comorbid anxiety. So they come to the clinicians' attention more common than males. Males, on the other hand, although they use higher lethal methods to kill themselves, and thereby the completion rate of suicide is more, but the help-seeking behavior is less. So the suicidal ideations come to us in a far lesser than females. So the overall difference that studies found between men and female is that there is a higher prevalence of female depressed patient, the onset of age is earlier, the current episode is longer, number of episodes is more, overall symptom severity is higher, suicidal ideation according to the study is lower, relatively. Past suicide attempts are more, substance use disorders are more common in males, comorbid anxiety is more in females, somatic complaints, atypical depression, anxious depression, and interpersonal sensitivity is higher in females, and also the functional impairment. So the specific psychosocial intervention that should be tailored for women, because we are not really discussing the common treatment modalities, the common symptomatology, the common prognostic factors. Here we will be specifically discussing only the differences in the symptomatology and management. So I will be pointing out only the differences here. So the specific tailored intervention for women that include CBT, because it is highly effective in anxiety and it reduces the depressive ruminations. Interpersonal therapy is very important for women because the relationship issues and relationship stresses play a pivotal role in the genesis as well as the maintenance of depressive symptoms among females. Mindfulness and dialectical behavior therapy is also important for females because in cases of particularly mixed type of symptoms, it is usually associated with borderline traits and mood dysregulations and mood swings. So mindfulness and dialectical behavior therapy helps women in mood regulations. Psychosocial intervention tailored for men are a bit different. They prefer talk therapy less than men. They prefer CBT less than women. The rate of engagement is a little bit lesser because they tend not to express these emotional vulnerabilities as a sign of weakness. So behavioral activation is important for them, which increases the engagement in rewarding activities. We can just start by telling the males that just start as simple as tasks like making your own bed, going for a morning walk, or calling at least 2 relatives a day. Such type of behavioral activation breaks the cycle between withdrawal and depressive symptoms, because males tend to have more withdrawal symptoms in depression rather than females. And males often prefer action-based therapies to deal with the real-life problems, the now and their problems, the current difficulties they are facing. So problem-solving strategies are more helpful in males compared to females. Similarly, motivational interviewing, it is more acceptable to males, which resolve their ambivalence about changing their behavior and breaking the inertia. And we use usually non-judgmental empathic dialogue, and we ask the patient to come with their own reasons why they should break the inertia and come out of this withdrawal. Targeting symptoms in females is specifically important because of it not only complicate the picture but also it leads to higher rate of suicidal attempts in women. So both SSRI and SSRI, although they are equally good for male and female, but because they reduce the comorbid anxiety, though they are drug of choice in females. Similarly, cognitive behavior therapy and exposure therapy for anxiety symptoms are very effective, as well as the mindfulness-based therapy. In addition, because of that, it increases this suicidal risk in women, as well as it worsens the depressive symptoms and the duration of symptoms as well. One important issue while we deal with women, particularly with pharmacotherapy, is the issue of weight gain, which is largely neglected in our clinical settings because self-image and self-esteem is affected a lot by weight gain, and often the weight gain caused by SSRIs is almost resistant to changes. So what we can do is that the reasons for why females have more weight gain than male is that because of the atypical symptoms which make them more prone to eating more than usual, or the hypersomnia which reduces their activity. Also the level of cortisol is higher in women, and SSRI which play an important role in appetite and satiety is modulated by estrogen. So the effect overall is that they tend to have higher weight gain than men when given the same sort of treatment. So the strategies which can mitigate the weight gain in women is when we combine CBT with medication, which should be targeted at their food intake behavior. The cognitive distortions related to food, for example, women might think that because of they are feeling weak and lethargic and depression, they should eat more, or as a comfort food, they tend to eat more. So it's better for women to make a dietary log so that keep track on their food and calorie intake. Exercise anyway is very important, and It not only helpful in reducing the weight gain, but also it improves mood and works synergistically with antidepressants. We always should screen for eating disorders, where that we usually do not, because depression in women can be often associated with binge eating and bulimia that might result indirectly in weight gain. Additional consideration is that they should be evaluated for PTSD and trauma, because they might be comorbid, and traumatic events may lead to depression as well as PTSD, which can be a comorbid conditions. We need to address the societal pressure, particularly when a person, the woman, is a homemaker and is taking care of the family as a mother or wife, so that caregiving stress, which is largely neglected and we often resort to the pharmacotherapy, it is very important to address the social pressure as well as their role as a caregiver in the family. Hormonal influences should also be taken care, particularly while giving medication, because the hormonal shift in the cycles like menstrual cycle or after during pregnancy, postpartum period, perimenopausal period, and after menopause, the mood swings as well as the variety in the symptoms, it changes, so they should also be taken care of. Clinical consideration while treating depressed men, because men tend not to present with the classical depressive symptoms, they may present with externalizing behavior like irritability, anger outburst, and behavioral withdrawal. So these symptoms to be taken care and should be, we should take care that these are not merely anger issues but can be a sign of depression. Men, because they tend not to engage in therapies as common as females, and they tend not to share their emotion, and because of the social withdrawal, they tend to ground themselves in work as an escape method to avoid from social engagement and personal relationships. So excessive working can also be a symptom that should be taken care of while we screening for depression. Treatment alert for men, SSRI, SNRI work well for both men and women, but bupropion, which is considered to be an activating drug, is useful for men because it is said to increase the energy level and activation, and also it causes minimal sexual dysfunction. Adjunctive testosterone can be used if clinically found that it is lower than 300 nanogram per deciliter. It is important to think about testosterone therapy because the signs and symptoms of low testosterone like fatigue, debility, low energy, low libido also coincides with the symptoms of depression. Among exercise, the weight training exercise are very important for men because they reduce symptoms by 30%. Stigma reduction is specifically for men because they do not seek treatment as early as women because they don't want to be labeled as weak. So the treatment can be given in disguise, or it can be framed as performance enhancer. They tend not to engage face-to-face with the therapist. So the digital platforms, they have shown a higher treatment adherence rate. And workplace integration, because the biggest concern of depressed male is that they might lose their job. So employee assistance program have also improved their treatment adherence by up to 40%. Comorbidity management among males, they are high risk of substance abuse. So we may consider a dual diagnosis, and the treatment should be started for both for depression as well as for substance abuse. Hypogonadism is seen almost in 20% of depressed men, and we have discussed that the symptoms of hypogonadism, they are almost like that of a depression for like irritability, low libido and fatigue. So it should be screened. One important disorder is obstructive sleep apnea. The symptoms like daytime sleepiness, lethargy also corresponds to the symptoms of depression. So in such cases, obstructive sleep apnea should also be screened for if person is overweight or obese. Suicide risk monitor is important in both men and women, and but as PGP said that women have most of the events and they have completion rates. So what we can do is that suicide risk assessment should be an integral part of screening when we see a depressed patient in OPD. And the anxiety symptoms, particularly in women, should be actively and proactively addressed because it increases suicidal ideation. In case of men, the mean distraction counseling should be done, and lethal objects like licensed firearm or sharp objects in the home, that should be removed from the vicinity of the patient. Coming to psychosis, the males usually have, in our clinical practice, that we have seen that the onset of psychotic episodes or schizophrenia is earlier in male, and on an average, the difference between males and females is almost 5 years on an average. Females might have bimodal onset, which is the second peak occur at around 40-50 years age, which again reflect the protective role of estrogen. When the levels of estrogen are declining, it makes women more prone to have a second peak around 40-50 years of age. Females having later age of onset have fewer negative symptoms, but more mood-related symptoms, and that is why we tend to misdiagnose females in 40s or 50s as mood disorders or as agitated depression or a depression with psychotic features because of preponderance of mood-related symptoms. Males, on the other hand, before the age of 30, they have a little bit of more prevalence before age of 30, and in the later age they might have more negative symptoms. And the possible underdiagnosis in women that I've said is because of the artificial presentation, that means preponderance of affective symptoms in females. And it is said that estrogen is supposed to have a protective role against earlier psychosis, and that is why the mean age of onset in females is later in females rather than in males. Male also have an earlier brain structural changes, suggesting that neurodevelopmental changes related to psychosis might have occurred earlier in males. And because of the comorbid or associated affective symptoms, female may be misdiagnosed as mood disorders. And the duration of untreated psychosis, it is almost same in initial studies. It was said that it is more in males, but recent studies suggest that there is no difference between the duration of untreated psychosis in male and females. Regarding the symptoms, positive symptoms, there is no significant difference. Hallucination, delusion, and disorganized thinking is equally prevalent in both males and females, while affective symptoms are more in females and negative symptoms like bloating, affective social withdrawal is more in males. Behavioral factors and trauma exposures, usually male patients are more violent than females. They have more comorbid substance abuse, but childhood and sexual trauma are highly reported in females. And that is also the reason why females might commit more suicide or have more suicidal attempts compared to males. Although there are very few longitudinal studies which has observed the long-term outcome of psychosis, most of them are either cross-sectional or have insufficient monitoring, but still the evidence we have, women show better outcome, they have high recovery rates, better medical adherence, and fewer and shorter hospitalization rates as compared to males. Women throughout the early age, from the prodromal age to the later age, they have a better social and occupational functioning, and they are more likely to maintain their professional activity despite having full-blown psychosis. And the rates of being married and having a children and a family is also better in females. The potential explanation again is that estrogens might have a protective role against psychosis. Women usually have a better premorbid function than males. And because of the comorbid affective symptoms, they come to the clinician's attention earlier than males. They also tend to have greater social support networking system, and the treatment, the adherence is better because of less stigma, because male always tend to avoid treatment because of the effect that cause them to lose their job and make them more inefficient for working. Because of low body weight and higher body fat portion in females, as well as the slower rate of metabolism in females, we should give lower dosage to female and should increase the doses slower than males. Also, because the modulatory effect on both dopamine and serotonin of estrogen, the antipsychotic activity is said to be better in females. So the treatment response is better in premenopausal women where the level of estrogens are relatively higher. Males, on the other hand, before giving any antipsychotic to the female, you should be very careful about hyperprolactinemia, which we usually don't consider much in males because the sexual dysfunction is higher in females as compared to males. Rate of infertility and amenorrhea can be very dreadful for females. It also increases the rates of depression and anxiety among females. Females usually are also more sensitive to the sedative effects of antipsychotics, weight gain, metabolic syndrome, and EPS and tardive dyskinesia, although dystonia, acute dystonia is common in males. Males are required a higher dose of antipsychotics because of certain reasons, because they have a higher body weight, low body weight, they present with more violent behavior, and because sometimes when they present with negative symptoms, they seem to be resistant to treatment, so there's tendency to give a higher dosage to male. Although females are more prone to metabolic syndrome as such, but because of substance abuse and poor dieting habits, males tend to develop metabolic syndrome quite a bit more. But the prolactin-related side effects, like sexual side effects, are relatively less common in male as compared to female. So the reasons for male non-adherence are usually work-related problem, emotional blunting, and sexual side effects that should be taken care of. The psychosocial programs, which are tailored for women, are supportive psychotherapy, family-based intervention, group therapy, and these therapies particularly should address their role as a parent or as a homemaker, and special care should be taken for their reproductive health because it causes some drugs cause severe problems in that. Interpersonal relationships are very big stressors in case of women, so they also need to be taken care of by creating some social programs for women. For males, because of their comorbid substance abuse disorders, it should be given priority and open dual diagnosis approaches are made for both diagnosis and treatment. Male, just like depression, they prefer an action-oriented and task-oriented psychosocial interventions like supportive employment program, problem solving, and motivation and joining, which improves not only the drug adherence but also improves their insight into the illness. And peer support groups are important for them because of their negative symptoms and their social control. Coming to the bipolar disorders, age of onset, it is later than in women. Average is around 3 to 5 years later in women. They tend to have more episodes of bipolar after the age of 40 or 50. Usually men have earlier onset of bipolar in men. Relatively, the manic episodes are higher in men as compared to female. Although bipolar 1 type disorder is equally prevalent in both males and females, but bipolar 2 disorder is more prevalent in women. Also, the rapid cycling type of bipolar disorder is more common in females. Men usually have more manic symptoms present with aggression and substance abuse, while women often present with mixed episodes and there is a preponderance of depressive symptoms. The comorbidity more common found in women are thyroid dysfunction and comorbid anxiety disorders. The reproductive phase, just like and the cyclical changes in hormones that occurs during menstruation, pregnancy, postpartum, and menopause make them more vulnerable to mood swings as well as increase in the cyclicity of mood disorders. And because of their specific needs in the reproductive health, both mood stabilizers and antipsychotics should be tailored, specifically keeping the age and the reproductive health of women. Because in the initial presentations, women are more likely to present with depressive episodes, so there are high chances that bipolar depression can be misinterpreted and misdiagnosed as unipolar depression, that not only delay the treatment but also leads to increased cyclicity and switch to mania, because when they are considered to be unipolar depression patients, usually antidepressants are given without any mood stabilizers. So initially, women are presented 60% as a major depressive episode, and 20% induced mania is 2 times more in women, and average diagnostic delay because of this misdiagnosis is almost 7.5 years as compared to 5 years in men. Symptom presentation, depressive episodes are more frequently seen in women. As an initial presentation, there are more atypical depression, which includes fatigue and hypersomnia. They have higher rates of mixed episode versus median in men, and mixed episodes are also having preponderance of depressive symptoms. And because females suffer more from bipolar type 2 disorder, and the hypomanic episodes are overlooked, so again they are diagnosed as unipolar depression, leading to problems in their management. While giving antidepressant, they are given without mood stabilizer because of their the symptoms are predominantly depressive. So the chances of rapid cycling as well as meningitis is higher in females. As compared to a man, females tend to show more seasonal variations, have more depressive diagnosis, just like we have discussed that they have initially present with depression, they have more of a bipolar disorder which is predominantly depressed, and the index episode of depression in women is also longer in men. Also, the treatment resistance is a little bit higher in women as compared to men, and more time is spent in the depressive phase on an average around 2 to 5 times more than in men in women. Because of the hormonal influence during the different reproductive phases of women, they have almost 30% increase in depressive episodes during the perimenopause period, and more than 100% surge in mania and hypomania once they have reached menopause, when the effect of both estrogen and progesterone is reduced. In the pregnancy, there are almost 20 to 25 relapse rate, and postpartum psychosis. If a woman is already suffering from bipolar disorder, there are almost 50 times higher risk of having postpartum psychosis than general population. And if a woman is having bipolar disorder, the chances of having postpartum psychosis is almost 25%. In the late perimenopausal period, for the first time, there are 15% chances of new onset in women, which is much higher than in women, in men. Regarding men, more and more episodes are seen in more manic episodes are seen in women, and more which are more severe, and they also have more psychotic and more aggressive episodes as compared to women. The ratio is almost 2:1 as compared to women, and that because of the psychotic symptoms and aggression symptoms and more manic symptoms, the rate of hospitalization is always higher in men as compared to females. Rapid cycling disorder, bipolar disorder, is more common in females, and it is more common in bipolar disorder, which itself by default is more common in females. The chances of drug-induced cycling or switching to mania is also much higher in women. Comorbid anxiety disorder, thyroid dysfunctions are more in women, as well as particularly in rapid cycling and in mixed episode, the borderline traits are more common in females. So certain type of therapies that should be targeted for borderline personality traits, and sometimes they are misdiagnosed as borderline personality disorders. Mixed episode in men, on the contrary, have a different picture. They show more aggression, impulsiveness, and substance abuse. And because of the overactivity, they tend to mask the depressive part of that mixed episode. And they always have more of this externalizing behavior like reckless driving, frequent brawls, and fights. So the main depressive syndrome, which consists of irritability, anger, and somatic complaints, it replaces the classical sadness, which is a hallmark of a depressive episode. So mixed episodes in men are often missed and misdiagnosed as pure manic symptoms. So here is a table comparing the different comorbidities in bipolar disorder. Anxiety disorders and eating disorders are more common in females, while borderline and emotional dysregulation is more common in females, while antisocial traits and impulsivity is more common in males. Somatic symptoms, thyroid dysfunctions are more common in females, while substance use disorders, particularly alcohol abuse, is higher in men. Externalizing behavior like ADHD and conduct disorders are higher in men. Overall suicidality is higher in females, but the number of complete suicide is more in women. And that's why we need to take care of the comorbid borderline personality disorders, and we need to address the anxiety disorders in women. And we should take special care while they are in peripartum and postpartum periods where there are high chances of high likelihood of relapse. We have already discussed suicidality. Okay, coming to the psychosocial and higher psychotherapeutic needs tailored specifically for men and women. Women benefit from therapies which address the emotional regulation, interpersonal stress, trauma, and comorbid eating and personality disorder like borderline traits, while men respond better to action-oriented, problem-solving methods. Intervention for substance abuse is more important in men, and strategies which address stigma and impulse control, they found it more effective. There is not much difference between the efficacy of mood stabilizers and antipsychotics among men and women, but because as a rule, valproate should not be given to women in a childbearing age. So even in case of rapid cycler women, it is preferable to give either lithium or butadiene. And we have to be very careful about hypothyroidism and weight gain. Even we are giving lithium because lithium is considered not to cause much weight gain, but it causes relatively more weight gain in women. Valproate, it is better suited to women, should not be given to women, and because of the soothing and calming effect, and it reduces the aggression, it is more preferred to male patients. But because it carries a high therapeutic risk and the risk of virality and PCOS syndrome, it should be avoided in female. Among the atypical antipsychotics that can also be used as mood stabilizers, butadiene covers all the four arms of bipolar disorder. Olanzapine is equally good in mania, as is aripiprazole, and they also have a good role in maintenance. But for women which have more of mixed episode, butadiene and lurasidone can be given for the depressive arm of the bipolar disorder. And in male, aripiprazole and olanzapine have been found to be more robust than other antipsychotics in the manic and aggressive phase. And because of the sedating effect, olanzapine is preferred so that it can reduce the actualizing behavior like frequent agitation and fights. क्या हुआ? टाइम हो गया? सर जल्दी समेटना पड़ेगा थोड़ा. कितना टाइम मिल सकता है सर? टॉपिक बड़ा वास्ट है. Women should be, when we prescribe antipsychotics, hypoprolactinemia is a big cause of concern. So it should be antipsychotics like risperidone and amisulpride that should be avoided, or we should take care of their sexual function by giving them to women. Comparing the side effects, weight gain is more common in women when we give olanzapine. Metabolic syndrome, the chances of metabolic syndrome is higher in women. Prolactin level, all the problems associated with prolactin level is higher in women, and QT prolongation is also higher in women as compared to men when we give medicines like ziprasidone. In the depressive phase of bipolar disorders, most of the mood stabilizers have a relatively weaker effect as compared to manic episodes, but lithium is still preferred because of their anti-suicidal effects. And here comes the role of lamotrazine, which have a good mood stabilizing property and antidepressant property in the depressive arm of bipolar disorder. It is better tolerated. The side effects, although are severe but are very rare, and it should be given. It's preferable to women because it usually has not much of a teratogenic effect while given during the pregnancy. The reason for treatment discontinuation in women are weight gain, hormonal effects, and teratogenic concern regarding the medication. While in case of men, substance abuse and lower insight and reduce help-seeking behavior. It is the reason why men tend to stop medication or are treatment non-adherent. Bipolar mixed symptoms, there is no difference in treatment response, but still in typical antipsychotics like urasidol, butapine, and cariprazine are preferred for women. And because of they having borderline traits, therapies which are used in mood regulation should be offered in addition to pharmacological methods in case of bipolar mixed symptoms in women. Relapse rate, it is higher in case of postpartum or hormonal transition in women, and it is higher in case of substance abuse and medical non-adherence in case of women. So these are different cases for the frequent hospital relapse, but it is usually more common in men. That we already discussed. Coming to the anxiety disorders, overall the anxiety disorders are more prevalent in female. For example, panic disorder is 2 times, generalized anxiety is 2.5 times, social anxiety 1.5 times, and later on it can be related to the estrogen and progesterone disbalance in females, but usually they have a more prevalence in all of the anxiety spectrum disorders. Although men have a more traumatic experience overall due to combat, accident, frequent brawls and fights, but because the impact of sexual trauma is more higher than it, so overall the rate of PTSD is higher in women. Anxiety वाले को तो कल बच्चा तो eating disorder भी है, पर इसके बाद कर लेते हैं. The fear conditioning is higher in women because of the role of estrogen, and it may explain why while the same magnitude of trauma when is subjected to men and women are more prone to develop PTSD. Also, the heritability is higher in women, and because of the heightened activation of HPA axis as well as the cortisol response is higher in women. So the three things that are higher affect the reactivity, the HPA axis, and because of the higher genetic susceptibility to women, they tend to have more of anxiety disorders in women. Because of their emotional expressiveness, the symptoms sometimes are more in women, and they actually are increased reporting of the symptoms. And before, because due to the masculine norms, they are not supposed to show their vulnerability and weakness, so the symptom disclosure is lesser in men. That might also contribute to the lesser prevalence of anxiety disorders in men. They tend not to take treatment because of the toughness ideas in the society, and women tend to seek earlier help. But at the same time, for the normal symptoms like palpitation or shortness of breath and the mild bodily symptoms, women are often overdiagnosed as suffering from severe anxiety disorders, while males suffering from the same types of symptoms are undiagnosed. Coming to the specific disorder, we will cover it in a very short time. In GAD, women are 2 times more likely to have generalized anxiety disorder than males are more likely to have substance abuse. And somatic symptoms, gastrointestinal symptoms, headache, dizziness, such symptoms are more common in females. And thought rumination, as such, is more common in female as compared to males. The gender presentation of anxiety disorder is a bit different because proper anxiety, the classical anxiety is often replaced by anger and irritability in men that might mask the anxiety, as well as the somatic symptoms. Usually men do not tend to convey that they are feeling dreadful or anxious. They tend to project their symptoms as work stress or burnout. So it leads to delayed diagnosis of men. Another thing is that when men suffer from anxiety symptoms, they tend to self-medicate using substances like alcohol abuse or benzodiazepines. So this is a thing that should be taken care of. Gender differences in management. First, if we talk about the psychosocial management, CBT equally works well for both male and female, but again the motivation interviewing, solution-focused therapy and behavioral activation that works better in men, and they prefer less of talk therapies. And it is while giving psychotherapy to both male and female, we should always take care that men have avoidance behavior and they tend not to engage and adhere in the psychotherapy programs for a longer period of time, while women, they tend to seek excessive reassurance, so the therapist should avoid it. As such, the coping mechanism, the inherent coping mechanism in women are relaxing techniques. They tend to journal their thoughts more often than men, while distraction by using work and exercise. It is.
We have to summarize further.
Okay, sir, after that. So, let's come into the summary then. Okay, sir. Psychiatry masala बहुत ज़्यादा था, समय बहुत कम था.
Thank you.
Summary पे आता हूँ.
Yeah.
Okay, to summarize this presentation, because I had OCD and eating disorder as well after that. Despite testing still, that women usually have more of internalizing symptoms like depression, anxiety, and somatic complaints for the same type of disorders, and men to have more externalizing symptoms like irritability, anger outburst, and substance abuse. The type of stigma is different for women. For example, in case of PTSD and anxiety disorder, women tend not to seek help because of the risk of victimization, and men are often undiagnosed because of the social norms of being strong, so they don't tend to seek support. The hormonal influences of estrogen and progesterone, women tend to have more seasonal variation in mood disorders, more of mood swings, while testosterone is involved in risk-taking behavior, impulsivity, and antisocial traits, even in the phase of depression. So, women, while treating the female patients, we should focus on trauma-informed care in case of anxiety disorders, emotional regulation in depression, and in men, we should emphasize more on structured, goal-oriented, solution-based, action-based therapies. And gender-sensitive treatment can always consider the effect of hormonal roles as well as the reproductive cycle of the female. And while addressing men, we should always take care that men tend not to seek behavior because of being labeled as a weak person. These things has to be taken care when designing the treatment and intervention for both men and women. Thank you for patiently listening. Thank you all.
Thank you, Professor Meena. I am afraid there is no time left for question and answers here. And the interested audience, they would have a time outside the hall later on to make questions. Thank you. And for my co-chair, Professor Alok.
Thank you, Dr. Parth. Dr. Parth, Professor Parth is well known for his meticulous and extensive works, and he has covered this topic fully. One of the things I would like to mention, boys, Dr. Parth has mentioned, I would go into details of biological, psychological, and the receptor area. He has mentioned boys do not have, but perhaps they should.
They should, sir.
They should, definitely. And suicide rates around the world show us what would happen if boys shared what they are going through. Man may come up to 80% of suicide in the US. While in India it is 2.6% more as compared to females. So, implication of man not expressing themselves, they themselves know it, and it is also part of the responsibility. Because why man doesn't express themselves? Could be because one of the factors was they are considered as there is a traditional belief that males are strong and expressing their emotion in population is considered as a big group. But they make that will make them susceptible towards abuse. So Dr. Parth has picked up this topic very kindly, and I am honored to be chairing this lecture. Thank you so much.
I think we should end the session now because we are running short of time. Thank you, Parth. Thank you.
Thanks.
Thank you, sir, for your thoughtful take on gender nuances in clinical presentation. Your expertise has added a layer of clarity and significant depth to our theme. Now, I would like to request the chairpersons to felicitate our speaker. I would request Dr. I.T. Gupta, sir, to kindly felicitate Dr. D.M. Mathur, sir. Would request Dr. Lalit Batra, sir, to felicitate Bhavuk Garg, sir. Would request Dr. DTE.GHS, sir, to felicitate Dr. Ajmer, sir. Now, as we move to the third part of the lecture, may I invite the following chairpersons on the stage. Dr. Paramjeet Singh, sir, ex-professor and head of Psychiatry Department of Savai Mansi Medical College, Jaipur. Dr. Vinod Daya, sir, President of Indian Psychiatric Society Rajasthan Chapter and Professor of Psychiatry Department of Government Medical College, Kota. And Dr. Praveen Kherkar, sir, Professor and Head of Psychiatry Department of Pacific Medical College and Hospital, Udaipur. Now, I would like to call upon Dr. Akhilesh Sharma, sir, Additional Professor, Department of Psychiatry, PGI Chandigarh, to speak on the psychiatric aspects of assessment and management of gender dysphoria in children and adolescents. Sir, with over 14 years of teaching experience and over 100 publications, has been a guiding voice in child psychiatry and is a WHO task force member on autism in Southeast Asia region. Thank you.
Good morning, everyone. Good morning, everyone. I wonder, there are certain topics in psychiatry which always creates questions for his existence, for his approval, for within the family, within local and regional places, at national and international levels. My friends, in the span of about 12 years, when I finished my MD Psychiatry, I had hardly seen, 10 or 12 patients of gender dysphoria or gender identity disorders. But when in 2017 I was in Australia, by returning back, I stayed there only for a couple of months. And there, lots of patients, friends, and the folklores were coming forth. Now, 2017 has a very distinct history for rising the awakening of gender dysphoria disorders. There was a meta-regression analysis study in the United States, and my friend, our esteemed speaker, is going to shed lots of lights and shades about this particular topic. Half of the amount of schizophrenic individuals are gender dysphoria in United States. Imagine. There was bathroom use right movement in US. There was a continuous everyday write-up of newspapers in the month of October in 2017 in United Kingdom. And not only that, it was the first time when India also witnessed first transgender to have High Court judge to be selected. So lots of controversy was there in acceptance. So my friends, when it comes to giving the cares for these kinds of individuals, the real transcendence comes out of humanity, and the role of psychiatrists actually evolves. Sometimes it is said that transcendence is not only a point of focus of your core concentration, but it's the fountain of compassion for what we can have for the society. My dear audience, I will request Dr. Vinod Daria sir to introduce our esteemed speaker, Dr. Akhilesh.
Dr. Akhilesh Sharma is additional professor at DTE Chandigarh. He is former faculty at MGUMST, Delhi. He has completed 14 research projects. His area of interest is child psychiatry. He has research publication more than 100, and he is member of WHO task force for Asia for the autism spectrum. Now, I go to Dr. Parth Singh sir.
Shall we start with
Thank you, sir. First of all, I thank Dr. Bhaskar for inviting us, and I pay my respect to all my teachers at SMS Medical College, Dr. I.D. Gupta, Dr. Batra, Paramjeet sir, and my senior LFS at PGI, Kareem Khelkar sir, and few of my colleagues at MOHFW, Dr. Parth is there. We will try to finish our presentation within stipulated time. I have two of my younger colleagues with me. Dr. Mirza Sarwar Beg, would you come up? Dr. Mirza Sarwar Beg is doing DM in our department. We have divided our presentation in three parts. First part will be presented by Dr. Beg, where he will present the contemporary view of those societies, Western societies, where gender affirming view have been taken. And then I will present a critique in between, and then our younger colleague Dr. Satvinder Singh, who is child psychologist with us, he will present what care we offer in our setting. In our presentation, we have tried to include case vignettes because we thought that our colleagues, younger colleagues, would be more interested in knowing that what we should do when we face with such a case, especially in our setting. So I request Dr. Dave to start the presentation.
Thank you, sir. Good morning to everybody gathered here. My name is Dr. Sarwar, and I'm here to present an overview of the psychiatric aspects of assessment and management of gender dysphoria in the pediatric population. So, the gender identity, it's a fundamental developmental domain which is shaped by various factors which are biological, psychological, and socio-cultural. While gender non-conformity is common in children, there's only a particular subset which experiences persistent and distressing incongruence, which is termed gender dysphoria. The challenge lies in recognizing one such incongruence is a fleeting phenomenon and when it is a stable identity and when it may shift or evolve with time. So psychiatrists are often called upon to assess and support these children and adolescents at pivotal junctures, which might be when their distress peaks, when parental concerns rise, when there are medical interventions which are being contemplated. The role of psychiatrists in such cases tends to be multifaceted. They formulate complex developmental narratives, they delineate the psychiatric comorbidities, they guide families, and they collaborate with the multidisciplinary teams. So this bar chart basically shows us how there was a great proliferation of literature related to the term gender dysphoria since the 1970s. And language and culture do have a bearing on gender diversity. So language shapes gender diversity. There are some languages which use the same word for sex and gender, which blurs the distinction between the two, and grammar matters. In gendered languages such as Hindi and Spanish, pronouns become key transition milestones. There are binary traditions which basically predominate. So most cultures historically align language and identity with anatomical sex. And diversity has also simultaneously always existed. Terms such as Hijra in India and Mukhannath in Islamic cultures allude to the same. But recognition does not always equal acceptance. There are many gender diverse individuals who face social or spiritual marginalization despite their visibility. However, legal process has progress has also emerged. In Iran, post the Islamic Revolution in 1979, gender transition was permitted. India has its own act passed in 2019, the Transgender Persons Protection of Rights Act from 2019, which guarantees identity and anti-discrimination protections. Under President Barack Obama, who served two consecutive terms from 2008 to 2016, legislative attempts were made to promote inclusiveness in access to the bathrooms and locker rooms. However, under President Trump, these were rolled back and done away with. And when we talk about the prevalence, worldwide studies mostly indicate that about 1 to 3% of adolescents around the world identify as transgender or gender diverse. When we look at India's own census from 2011, it becomes clear that around 4.8 lakh individuals they identify as transgender. However, this was across all age groups, so there was no specific age-related data about the prevalence in India. So these findings, they basically tell us that a significant minority of young people from around the world are navigating gender diversity challenges. So how we diagnostically frame it also influences our own perspective and approach to this. So the terminology pertaining to gender dysphoria has significantly evolved. What was initially referred to as gender identity disorder was then changed to the term gender dysphoria in the DSM-5, and now in the ICD-11 it is alluded to as gender incongruence. So by redefining and recasting the term gender identity disorder to gender dysphoria, the attempt that was made was to emphasize distress over the concept of identity. This has reflected a shift towards affirmative care. And this is a terminology chart. Basically, it's very easy to get lost in a myriad of ever-evolving terminology. So when we use the term gender assigned at birth, natal sex or birth sex, what we're basically talking about is the gender assigned to the infant at birth, which is based on the observable anatomical characteristics such as the external genitalia. When we use the term experienced gender or gender identity, what we're talking about is the individual's psychological understanding of their own gender. Affirmed gender refers to the individual's psychological understanding, which typically refers to how they live socially as their understood gender. Sexuality and sexual orientation refer to the individual towards whom one is romantically or sexually inclined. And gender incongruence basically refers to individuals whose gender identity at birth and gender assigned at birth and rather the gender identity are not matching, are at odds with each other. So we're all familiar with the childhood fable, the gingerbread man. And this tool, the genderbread person, was conceived of by Sam Killerman, and it basically differentiates the term gender identity from gender expression, from the biological sex and the sexual orientation. So psychiatrists have a unique position where we need to formulate gender-related distress, we need to rule out and to manage the psychiatric comorbidities, we need to assess the psychological readiness for a medical or a social transition, we need to guide families through uncertainty and grief, and we need to collaborate with various other specialists such as pediatricians, endocrinologists, as well as the school system. And the presentations of gender dysphoria will vary as per their developmental age. Pre-pubertal children may have more of exploratory behaviors, whereas adolescents, they have more concrete statements of identity, they have distress over the secondary sexual characteristics, and they make requests for a medical transition. So what matters then is the timing and the persistence and the insistence, and so does the psychological context for the same. So we look at the vignette. This was a boy we referred to here as Aryan. He was aged 7. He was assigned male at birth. His parents sought psychiatric help because of a strong preference for feminine clothes and feminine toys and his own self-identification as a girl. So while his mother was anxious but accepting of the same, his father viewed his behavior as misguided. The school teachers, they gave a history of bullying and social isolation of the child. So the assessment revealed that there was a consistent cross-gender identification over the past 2 years. There was no history of any trauma or any neurodevelopmental traits. There were, however, anxiety symptoms which were related to the rejection and bullying he faced at school. So therapeutic play and projected tasks were carried out, and it was revealed that Aryan's depiction of a self-image was repetitive in nature. And the family formulation sessions, they basically revealed that there was ongoing marital conflict and the parents had divergent views on the parenting practices and in their approach to the child's issues. So the formulation that was done emphasized that there was a secure attachment to the mother, that however the paternal disapproval was a secondary stressor, and the protective factors as they were identified were the early presentation in this case and the active involvement of the family, especially the mother. So the interventions that were planned and carried out were parental psychoeducation, collaboration with the school with a view to prevent bullying, and no immediate social transition was recommended in this case. However, ongoing continued psychological support was emphasized upon. And the assessment that we carry out isn't just developmental, it is also systemic and exploratory rather than confirmatory. So the key components of an assessment would be the gender narrative, which would include how the child describes themselves, what language are they opting to use, what is their history of their own gender expression, where did the and when did the gender incongruence begin, is it consistent, is it consistent in nature, what the family context factors are the caregivers basically supporting, are they validating or are they rejecting, is there any history of marital discord among the parents. And the psychiatric status also matters because we need to look at the possibility of any coexisting comorbid psychiatric symptoms such as depressive symptoms or anxiety or OCD or any traumatic history or any neurodevelopmental conditions possibly. Social functioning also needs to be assessed. We look at the school climate, the acceptance from the peers of the child, whether there is any bullying or any social withdrawal. So the tools that can aid us in the assessment for us that can be helpful are gender identity interview for children, CBCL with its gender variance subscales, that is a child behavior checklist. There are parental questionnaires. Simultaneously, narrative drawings and play-based observations can be carried out. The psychological evaluation will also inform the readiness for transition, especially for puberty suppression or hormone initiation. Now the WPAS, that is the World Professional Association of Transgender Health, came up with the Standards of Care version 8 guideline in the year 2022, which basically emphasizes psychological readiness and doesn't just emphasize the chronological age. So we need to differentiate the presentation of gender dysphoria from certain other conditions. This is vital and crucial. So autism might present with rigid thinking on special interest resembling gender identity. This needs to be differentiated. In trauma, there might be sexual abuse which goes on to disrupt the individual's bodily image. If there's OCD, there might be intrusive thoughts around the gender confusion. And in BDD, that is bodily disorder, there might be body-related distress. So resistance, where there's a resolution of the symptoms of GD over time, it tends to be more common in pre-pubertal children rather than in adolescents who have more of a persistence of these symptomatology. So the factors which predict persistence would indicate early onset would indicate this. If there's a strong cross-gender identification, that is an indicator. And if the gender dysphoria intensifies at the time of puberty, that is also predictive of persistence. And psychiatrists need to allow exploration without pressuring the child or the adolescents towards either permanence or neutrality. So this is the second clinical vignette. In this, there was a girl we referred to here as Ria. She was aged 12, assigned female at birth. She presented with distress which escalated over the development of her breast and the onset of her menstruation. She would wear binders around her chest, she would shave off her head, and she was increasingly withdrawn at school. The mother was supported, however, her father refused to become involved. So the evaluation revealed that over the preceding 2 years, that there had been a history of male-identified behavior and language. There had been marked dysphoria over the bodily changes which had happened. However, there was an absence of depression or trauma or any ASD. There was good insight in this particular adolescence. There was a cooperative attitude and a stable mood. So the psychological readiness assessment was carried out for the purpose of carrying out pubertal suppression, and a multidisciplinary consensus was reached between the psychiatrist, the psychologist, and the endocrinologist, which supported the initiation of GnRH analogs. The intervention that was carried out included puberty suppression initiation, family therapy to support the dyad of the mother and the child, and to address the paternal absence. Ongoing psychotherapy was established to explore the identity and the peer relationships, And this case is basically illustrative of how early adolescence, particularly the onset of secondary sexual characteristics, can precipitate crisis, can precipitate acute dysphoria in a youth who was previously stable. And this is basically a diagram which depicts how endocrine treatment in transgender adolescents carried out. So between the ages of 11 and 12 years, that is the Tanner stage 2 and 3, pubertal suppression is, if it's opted, it's carried out by using GnRH analogs. If the adolescent has reached the ages of 15 and 16, then gender-affirming hormones can be used and sex steroids will be employed. And there are various assessments including DEXA scanning and metabolic profiling, which is done at various stages. So psychotherapy and psychosocial support are also critically and vitally important. Psychotherapy hinges upon identity exploration while simultaneously addressing the distress, anxiety, and any relation dynamics. Goals would include supporting emotional expression and addressing any internalized stigma that the child or the adolescent may have. We also need to mediate the family conflicts. We need to do school advocacy, and we also need to help the parents process any grief or ambivalence that they might have. So the therapeutic modalities that can be employed for the same are affirmative therapy, narrative therapy, systemic family therapy. Trauma-informed care is also of the essence, particularly in dealing with youth who have a history of facing bullying or abuse or any disruptions in their attachment. CBT elements are also used to manage the anxiety, any body-related distress or social fears. Peer support groups, whether in person or online, they are protective factor against isolation. So affirming school environments, including pronoun use, which basically refers to the use of preferred pronouns, and bathroom access and anti-bullying policies are also important in psychosocial stabilization of the patient. So medical management, while medical transition is not primarily a psychiatric intervention, a psychiatrist does play a vital gatekeeping role. So puberty suppression, when it's carried out, is typically initiated at Tanner stage 2 with GnRH analogs. It's thought of as a reversible intervention which hits the pause button on puberty and reduces the experienced distress. It allows time for identity consolidation without causing irreversible changes. And the SOC 8 readiness criteria, that is the WPAS 2022 version, it basically necessitates that the GD must be long-standing and consistent, that there must be an absence of any severe psychiatric instability. Psychological capacity must exist to understand the implications of any considered treatment. Parental support is also looked upon, and psychiatrists need to provide assessments of readiness, and we need to guide families through the decision-making process, and we need to advocate within the framework and ambit of multidisciplinary teams. So the cross-sex hormones, as they are initiated, would be around the age of 14 to 16 years, would be contextual, and they do induce irreversible changes. They are often thought of as not causing irreversible changes, but that is not necessarily true. A deepening of the voice might be permanent, any breast development might be permanent in nature, and it requires careful assessment of capacity, which is not simply age-based. And fertility is also an important consideration here. And we need to ensure that the youth understands the long-term effects, that the comorbid conditions are stabilized, that there is a space for an evolution of identity, that the family is actively involved. And this is the third clinical vignette, which basically looks at an individual named Zayan, age 16, assigned male at birth. So this individual had socially transitioned at age 14 and now presents with symptoms of depression and self-harm. She self-identifies as female, uses female pronouns, and is dressed in a feminine attire. Her parents were inconsistent in their support towards her. She, however, seeks estrogen therapy. So the psychiatric involvement that went on over 12 months included risk management, crisis planning, and a diagnosis and a treatment of the comorbid depression, and a psychological readiness assessment for hormone therapy initiation. Multiple family sessions were also carried out. And after the psychiatric stabilization and the multidisciplinary team review, cross-sex hormones were then initiated. So the academic engagement of the adolescent improved, the self-harming behaviors came down, and the family support became strengthened. So this particular case, it illustrates the need for psychiatric presence across the whole arc of care, not just as a gatekeeper, but rather as a therapeutic ally at every step of the process. And we've also heard the term DST, and the distinction needs to be made between gender dysphoria and DST. So children with disorders of sexual development, that is DST, they represent a distinct yet an overlapping clinical population. DST cases often involve atypical genitalia or chromosomal patterns. There's early sex assignment decisions, which are sometimes surgically enforced. There's secrecy that's involved, parental guilt, and a delayed disclosure. And there's also a risk of later gender dysphoria if assigned gender is not aligning with their identity. So So the psychiatric considerations that would exist here would need to be respect for their autonomy. We need to process their secrecy and any identity confusion. Trauma-informed care needs to be provided, especially in the aftermath of any surgical procedures. We need to liaise with neurologists and endocrinologists. Management of DST would require balancing the considerations of medical urgency, ethical prudence, and psychological safeguarding. And psychiatry would be at the center of all of this. So this is the cover page of the WPAS Standards of Care Version 8 guideline, which provides tailored pathways for children and adolescents. It basically looks at patients of all age groups. Chapter number 6 and 7 deal with children and adolescents, and they emphasize affirming care, psychological readiness, informed consent assessment, and flexible timelines, as opposed to rigid age-based decision making. So the gentleman in this picture, now deceased, is Harry Benjamin. He was an endocrinologist who thought of gender identity as existing on a continuum, and it was in 1970s that he formed an association which later became the World Professional Association for Transgender Health, that is the WPATH. So this is a summary of treatment for transgender youth, which is divided as per developmental ages. If we get a pre-pubertal youth, there's no particular need for any hormonal intervention. The focus needs to be on regular psychotherapy. If the child is in the period of early puberty, puberty blockers, GnRH analogs can be used to pause the secondary sexual characteristics development. This would buy us time to provide psychological support and decision making. If the adolescent has reached the ages of 14 or 16, then based on what center they have gone to, cross-sex hormones in the form of estrogen and testosterone therapy might be initiated. And after the age of 18, in several centers, gender-affirming surgeries may be offered. So there are ethical considerations at play here. Ethical complexity is intrinsic to the care for gender dysphoria. The key dilemmas would be when one particular parent opposes the transition, when the child is confident himself or herself but young, and when there's social pressures in the form of peer influences that are raising concerns, and when the access to treatment is delayed due to systemic barriers. So what are the principles to uphold here? Always, first and foremost, the best interests of the child, whether it is medically or socially or emotionally. We need to preserve future options, especially with a view to preserving their fertility. We need to respect their evolving capacity and autonomy. Obviously, it's a time of flux, and we need to prevent harm either through action or inaction. So there is no singular path. And in conclusion, our role isn't merely diagnostic. It is relational, it is ethical, and it is developmental. And the goal is not to know who the child will become, but to ensure that they are supported, safe, and seen throughout the process of becoming. We now call upon Dr. Akhilesh to talk about the clinical complexities.
Thank you, Dr. K. Now I will present my point of view, and when we discuss this talk, we are mainly talking about the children and adolescents. So in children and adolescents, basically we see that the prevalence, whatever limited literature is available for adults, the prevalence is 3 times more in children and adolescents. So this means that 2/3 of children, they don't persist as adults as having gender dysphoria, and that is very important for us when we face a child or an adolescent. And though the quality of studies is poor, but whatever consensus is there, it is there. Now the second issue is that most of the literature that has come is from Netherlands, Holland. Dr. Benjamin used to work there, and he had 2 psychology or psychiatrists colleagues, Dr. Cohen Candice and Dr. T. Price, and he involved them first for the research and then for safeguarding himself, that they should first do the assessment and do all the work, hard work for him, and he would do this. He had his own vested interest. His own sister was having gender identity issues, so he started that, and at that time endocrinology was active doing these things. So it was basically a medical intervention, but psychiatrists and other mental health professions came into the picture to provide them a safeguard. Then comes the role of social transition. Social transition means माँ बाप आपके आगे आगे पूछते हैं कि अभी तो ये बच्चा 2 साल का है, हम असी की करिए, हम क्या करेंगे, इसको करने से जैसा ये कर रहा है या हम इसको थोड़ा रोकें, क्योंकि आप ही you are telling that we are not going to start any puberty blocker. So this is very important practically, and you are also saying that 2/3 of them will resolve on their own. So here what they talk about the approach of watchful waiting. But I will talk about some active watchful waiting. Means that you should tell the parents that you should try to encourage child in a manner that they should try to explore both their own sex-assigned identity as well as their perceived identity, gender identity, psychology. Second is that you should not be very lenient with them. You should set a limit for them because there is a risk of they may be abused, they may be bullied. So you should set a limit for them that you do most of these things in one setting or in a limited environment. But they should be made clear that life, not every fantasy can be fulfilled. So you have to fulfill these things in a limited way. We cannot fulfill all your wishes. And third is the risk of adverse childhood experiences. These children, there is lot of literature that they go through all sorts of abuses, physical, sexual abuses, other discriminations, bullying, and it puts them at a risk. That is why social transition of a proactive nature is advocated. Now the family is confused, and it is confused throughout the world. And if you see that in the recent 5 years, there have been commission reviews by the UK government, by Dr. Parth, who is a pediatrician, and recently 4 days back a review came. And it is one of the most comprehensive reviews. That in the past, in the Dutch or in the American clinics, which were not regulated that much by the government, they would actually say to parents that, oh, if you are not going to go for the gender affirming thing, your child is going to commit suicide. And in that culture, there were family planning, few children were there. Like we get worried when our child asks for mobile and we don't feel that he is going to commit suicide, they would yield to the endocrinologist's demand that we should, as early as possible, we should go for the gender affirming. So families are confused. Now the crisis at puberty. What the endocrinologist thought from a physiological point of view that it is very difficult to go for the conversion in an adult because they did most of the works in the adult. And physiologically, if you stop at puberty, you will give them the best possible cosmetic results. Their point of view was that. But what really happens at puberty, like in a pubertal child, we say that you should explore for your identity more. Puberty also gives you a second chance for your incongruence to be explored more. Because at this time also the hormones, which your biological sex is, they are going to work upon you, and there are chances that you may still desist from going to a transgender. So if we stop puberty at this point, then we are biologically denying any chance. And other point of view is that if we start puberty blocker, which my colleague said that the literature says they are fully reversible. No. Now the research has found they are not fully reversible. If you have started them for 2-3 years, then they are going to stop puberty. By the time you are going to lose your musculature, your bone health, and all those things, and the brain development also. So it is not right to say that they are fully reversible. Similarly, the sex reversal hormones, the testosterone for females, and for males, these estrogens and a combination of testosterone, they say they are partially reversible. No, they are not partially reversible. Once they have undergone the change, and if they have issue of regret, which their guidelines don't highlight, because not many people do have a regret that we have gone for the change, now we find it difficult. So they cannot opt for the reversal, complete reversal, and they are in attack. Similarly, the issue of marriage and fertility. Marriage is very difficult for these people even after they go for SRS. And it is a scientific fact that they are not going to have as good a sexual desire, as good an experience of orgasm for them. Similarly, fertility will be gone. So, the risks are more and benefits are less, according to the recent reviews. But what these groups, which are proponent for these surgeries and hormone therapies early at puberty, they don't highlight that much. And if we look at from the point of view of evidence-based medicine, then we are providing them with a limited data. And now recently what has happened, that in the Western countries, lot of adolescents, rather than with a history of childhood onset incongruence, they are coming in adolescence. that we are having gender dysphoria, we are having incongruence. And what has been found in the preliminary investigations is that it is more of a social phenomenon related to social sites which these transgender groups have created and the influence of social media. And now such things due to globalization, these things are also coming as the tip of iceberg in our country also. So, and here it is more represented by females, not by males. Otherwise, males are more prevalent as a presentation in gender dysphoria. But in this rapid onset gender dysphoria, females predominate. And now the Scandinavian countries, they have done also extensive reviews for these, and they have found that these guidelines of WPATH and some American Academy guidelines, they are merely equivalent to expert concession or expert opinions. They are not really rigorous guidelines. Now, if we look at the Indian setting, I used to work with Bhavuk with the Honorable Chief Justice of Punjab and Haryana High Court, for all the DERAs, some sort of only which has been provided after this law in India, and there used to be thousands of transgenders. And they would say our psychological health is more important for us, even in open forums. And we stress that our own families are abandoning us. And we are finding it very difficult to go for all these treatments because in India, in government setting, it is not provided. And there are only a few places to name in India which are doing this, and which is very costly. I don't think that any medical association or professional guideline or body endorses this. And these are very few, and these are very costly. They had to go for flash rate and other things to manage their finances, and at times they stop their treatment in between. So it is becoming more deceiving or more psychological distressing. And now the ethical issues, especially for us. I will give you an example that TSD is most studied, and TSD children by the in India, most of them they will go for some sort of corrective surgeries. But at times they do also develop gender dysphoria. And one such case was there in the Madras High Court, where a child who underwent a surgery, he sued in the court of law that I was not competent enough to take the decision why this surgery was performed on me. Then this guideline was issued recently by the Psychiatric Society regarding the TSD children. And now we are, as a gatekeeper for this, every surgery will require a clearance as a member board from us. And so we have to be very cautious on an ethical ground. This is my take. Now I will discuss some of the case minutes which we have seen in the last 1 month only. A 4-year-old child with DSD, secondary to congenital adrenal hyperplasia, was referred from our pediatric endocrinology unit. And family had not received any treatment yet. So they were disclosed on the birth, and it is a social and familial emergency. DSD and PGD. It is an emergency for the family. And they took the child away in the disguise कि नहीं ये तो लड़का है, फेमस बड़ा हो रहा है, डॉक्टर को ऐसे ही बता रहे. After few years, they realized that there is partial fusion of labial folds. He is not urinating like a male, and there is a clitoridectomy. Then someone advised them to visit again. Now, luckily in this child, the assigned sex was ambiguous, neither male nor female. But he was a very young. His gender identity was fluid. He was talking like God, and his gender role was of God. And he had not developed gender incongruence. Now, what did we do in such a case? Because in DSD there are Indian guidelines, and we have to go for the corrective surgery if the family agrees. So here we agreed for that, we prepared the child, and the surgery was done. But in the past, there have been many cases where such cases of CH, they are genetically females, their uterus and ovaries were removed, and they had to undergo for a SRS follow. But luckily this is not happening nowadays. Now the second case being and I will highlight the issue of social transition with it. A 10-year-old male boy from rural Haryana of an agrarian community, he was brought by his parents after referral from a pediatrician. For not showing interest in playing with boys, mostly he used to prefer with his 5 elder sisters. He was the only boy, and they used to live at a 2 well away from the village. Not much access to other children to play with. He was described to it as by his father. He was an ex-army person. He prefers to participate in artistic activities with girls in the school. Sometimes he wears scarves and clothes of his sisters and shoes. Now here the assigned sex is male, gender identity is male, gender role was of both. He had developed some sort of gender incongruence. Now what is the role of mental health? Here I will propose the approach of this social transition, that we should do active watchful waiting, like some limit setting, some encouragement for both the roles, some encouragement for playing with the children of both the sexes, and he may turn out to be a disaster or a persistent. Now the third case, a 13-year-old female was admitted in our unit with a diagnosis of anorexia of last 1 year. She had been very competitive in school, in academics as well as in sports. She was muscular, she used to wrestle with boys. Other than school uniform, she would prefer male clothes, nails and haircut. Mother neglected her in preference to very late born brother of hers. She had a mannerism of boys. She recently had menarche 1 year back. After few cycles, she had secondary amenorrhea due to development of anorexia. We treated her, we stabilized her, we discharged her. But amenorrhea persisted. Her father was emotionally unstable and litigious personality. The family was going through a legal and financial crisis. Now, she requested her parents that they should let her join a sports academy or muscular competitive sports. Now the family was worried, and now on the phone of this, they expressed their concern for her boy-like behavior. Now, this girl has had puberty. She has assigned sex of male, but her gender identity is of male. She had a significant incongruence also, dysphoria also. But luckily, because of her anorexia, the amenorrhea is there. But once she gains weight, by whatever means, then she is going to have a menarche, and then again her crisis will worsen. Now here is the point, what approach we should take. We should take the gender affirming approach or the watchful waiting approach. I leave this question to you for the discussion. Now this boy, 15-year-old adolescent, he was brought from Snehalya, a home for abandoned children, by social welfare service. Father was an alcoholic, he died. Mother had intellectual disability, she too died. Her other siblings were with her. Her uncle, she ran away from home 2 years back. She used to work at a saloon and stayed independently in the outskirts of Chandigarh. Had some adverse experience of severe nature, was caught by police due to some conflict with law, and Metropolitan Magistrate assessed her, and she was having a tomboy-like appearance, and she was sent to the boys' dormitory. There the boys discovered that she is a female. Again produced before MN, and she requested that she should be treated like a male. Now, what should be our role when she is sent for the examination? Now we found out that her assigned sex is female. She had a strong gender dysphoria. Her identity has evolved to a significant extent to a male. And now I think she is going to persist with this transgender identity. And in this case, what should be our role? In this case, I don't think that we can stop us. But in our society, there is not much facility for her from such a socio-economic poor background, and she's abandoned her home, that how will she go for SRS? Probably she might end up in the net of these eras of transgender people, and she will suffer from all this. Otherwise, if care is available, she is one candidate where puberty blockers and hormone therapy and SRS can be advised. Last case, a nearly 18-year-old male from foothills of Himachal was brought by father in the OPD. He recently disclosed to his sister and one of the colleagues in the college that he is not comfortable with assigned sex. He used to play with younger girls and toys for the girls. Communication style, all those things were like that for girls. His friends spread the news in all of the college, and he was bullied, he was outcasted, and when he was brought, he was having adjustment reaction. After assessment, it was found that he has explored on the social media platforms regarding the various communities. He has joined them. He is well aware of the procedures of SRS. And I think after assessment with family, we started counseling them in a gender affirming approach because now he is going through crisis. So with this, I stop. We can take questions in the discussion. I request Dr. Satvinder Singh to present his part.
Thank you, sir. Now, in this presentation, I would like to discuss the role of psychotherapy and the role of family education in managing the gender dysphoria in children and adolescents. What is the clinical justification for this? Due to uncertainties in the natural progression of gender dysphoria in youth and lack of predictive tools for persistence into adulthood, psychotherapy is internationally recognized as the safest and most prudent first-line treatment. It helps in avoiding the premature medicalization of the treatment. And the therapeutic goals, now I will discuss about the therapeutic goals for children and adolescents. Psychotherapy helps us in managing the emotional distress and it facilitates the developmental milestones. And therapists help the children maintain academic, social and family engagement while allowing exploration of identity in age-appropriate ways. So there are three models that we take into account while doing the psychotherapy of such children. The oldest model was given by Traeger in 2009. This model seeks to reduce the cross-gender identification, and we use two types of strategies. One is direct methods in which parents are guided how to deal with these children in daily life, and indirect methods are the psychodynamic psychotherapy, which deals with the underlying causes of such issues. And another approach, which is already discussed by Dr. Akhilesh, that allows the gender-variant behavior without encouraging the transition. And our role is to wait and watch. And no efforts are done to prohibit the expression. And parents are advised to keep future identity options open. And we should avoid early social transition at this stage. And third approach was given by Ehrenfest in 2012, and in this approach we view all the gender identities as valid and healthy, and this approach supports child's expressed identity and allows social transition when desired. So these are the basically the psychotherapeutic interventions we take into account while dealing with such children. One is cognitive behavior therapy approach, another is exploratory psychotherapy. It is a kind of non-directive psychotherapy that supports open-ended inquiry into identity and distress without pre-committing to any transition pathway. And during the psychotherapy, we should also take into account the coexisting mental health conditions. Basically, when a child presents with gender dysphoria, there are other co-occurring psychiatric conditions also we should take care of, like ASD, autism spectrum disorder, ADHD. And treating underlying psychopathology often alleviates gender-related distress without the need for hormonal or surgical intervention. And there are also misconceptions about psychotherapy. Now I will discuss about psychotherapy versus conversion therapy. Exploratory therapy is distinct from conversion therapy. It respects client's autonomy and refrains from coercive identity change. And there is no evidence that psychotherapy is harmful in any way in youth with gender dysphoria. Rather, it is developmentally appropriate and a reversible approach. So, we should take developmental consideration into account while doing gender dysphoria therapy. Younger children benefit usually from play therapy and family-based sessions, while adolescents require autonomy respecting engagement. And therapists are trained to support fluctuating expressions without pathologizing exploration or prematurely solidifying identities. So there is a very vital role of family education. So these are the core principles of family psychoeducation. We should use family as a therapeutic agent while doing the psychotherapy. Engaging parents and caregivers reduces youth isolation and reinforces adaptive coping. And it also improves the understanding of gender dysphoria and corrects misinformation about gender dysphoria and promotes acceptance without bypassing the critical discussions of concern. So the major content areas are of family psychoeducation. We should focus on the psychological and social struggles of youth, and structure modules help us in doing this, in which we teach empathetic listening and validation techniques which are critical to youth resilience. So during psychotherapy, parents cares about safety, social acceptance, or permanence are addressed with data and empathy, and they are told that they are not the passive observers but active partners in guiding identity development and mitigating the risk. So the format of such therapies is in multi-family therapy groups, and in group settings typically include structured psychoeducation, facilitated dialogue, and peer mentoring. And all the interventions are evaluated based on developmental needs and safety and reversibility. And decisions about social and medical transitions must be informed, cautious, and preceded by thorough assessment. So, clinicians should not jump their guns to only one decision. Clinicians should assess the identity development over months, not hours, to ensure informed decisions. And it should be multi-dimensional evaluation. It should include psychological testing, psychiatric interviews, family dynamics, and social functioning. And there is now international trend towards psychotherapeutic first-line care. Countries like Sweden, Finland, and UK now recommend psychotherapy as the first-line treatment for youth with gender dysphoria. And stable mental health is prerequisite before considering the irreversible interventions. And risk mitigation strategies are also very important. Evidence-based practices such as safety planning, family monitoring, and crisis resources are implemented early. Therapists should maintain awareness about the factors predicting later regret and reinforce reversible approaches. So in this case unit I will present, for example, a 9-year-old boy or girl comes to you with expressing intense distress over gender roles and insisting on opposite sex pronouns. So here play-based therapy, parent psychoeducation should be our approach. Usually in such cases gender dysphoria resolves on its own after some time. Another case is a 14-year-old with ASD and depression reports new onset gender intolerance. CBT and family therapy approach should be prioritized here, and there should be no immediate social transition. And usually the symptoms improvement leads to resistance. And there is a very vital role of school and community resources. So family psychoeducation should also extend to the teachers and counselors. We should collaborate with schools to promote safety, respect, and emotional well-being. And families are also taught during the family education sessions that there are various online resources available, and they should look for them. And clinicians should clarify between the evidence-based care and ideological narratives. And every therapy which is given to gender dysphoric children should be based on the principle of do no harm. And it should be a collaborative decision. And now I would discuss about the future directions. Although psychotherapy is well established, but there is also a high need for long-term research into this and its efficacy. And clinical guidelines should center on developmental appropriateness, evidence strength, and family engagement. Now I would conclude my presentation saying that psychotherapy is ethical, safe, and evidence aligned, and we should empower families as partners.
Presentation by Dr. Akhilesh on gender dysphoria. You know, in our clinical setting, especially at the medical college level, they always seek your opinion if anybody comes for sex screen and he is a grown-up adult. You can see the plight of the family, the parents, and you can very well foresee the future of such a person and the legal implications. So, I would request Dr. Akhilesh how to report about such patient, how a psychiatrist should evaluate and report if anybody is adamant on going for a sex change and he is a grown-up guy.
Thank you, sir. I will share some of my experiences. When I was at Bihar, there was a referral from the Delhi Police Headquarters that a constable or SI with them, she was assigned, at birth she was a female and she wanted to go for SIs. She had all the gender dysphoria, incongruence, and for that she required a clearance from the psychiatry board, and thereafter she will go for the SIs with whatever facilities were available there. So in that case a medical board was constituted, and based upon whatever expert opinions were available, we found out that at birth she was a female and gender identity was consolidated into a male. All her behaviors and expressions were of a male, and she had a sexual orientation of homosexuality for the same biological sex and whom she wanted to marry. And the board mentioned all the facts that whatever literature is available internationally, and we don't have any guidelines, and these are the facts. Based upon that, generally this is done in the foreign countries where such issues are discussed, that we allow for the informed choice of hormonal therapy and sex inversion therapy, and the court can take a decision based upon this. And I think in that case, the court decided that she should go for the sex inversion surgery, and she went for it. And generally for the adults also, in government setup, as Praveen sir has also said, that we see very few cases. But most of the cases, we generally work with children and adolescents, we get a referral from pediatricians for those cases who biologically had an ambiguous genitalia at the birth. And they are, because in our culture they come late because of the bare stigmas and myths and misinformations, and there few of them also had developed dysphorias also. So in those cases we have extensively worked, I think, with more than 100 cases, and they are, depending upon the stage when they come, some get affirming surgery for their biological sexes because to preserve fertility if they come early. For some of them, unluckily, they already had undergone some surgeries for removal of their internal organs. There we had to consent for this sex inversion surgeries also. So this is our experience.
I think now on a lighter scale, 2017, Trump funnily decided to stop the entry of this transgender into the military. The society went to the court and the Trump was lost. So friends, there is lots of opportunity to ask the questions. I will open this forum for at least few questions which we would be happy to interact with this expert team led by Dr. Akhilesh. Please introduce yourself and ask.
Thank you, Akhilesh sir, for a scientific presentation on different topics. I'm Dr. Bhavuk Garg, Professor Psychiatry at DTE Medical College. No questions per se, but just 2 or 3 additions and comments to add on to the presentation. So, for disorders of sexual differentiation or intersex as was earlier called, in addition to the Indian Academy of Pediatrics and Pediatric Surgery Association guidelines, the government has also come out with the guidelines, and those guidelines are now available. It was prepared by experts of pediatric surgery, endocrinology, urology, and mental health psychiatry. Part of the guidelines. So, government guidelines are also there now. I share those for your reference. The second point, for management of adults, specifically for gender affirmation surgery, earlier it was called as sex reversal or sex reassignment surgery, the now preferred term is gender affirming surgery. So again, standard operating procedures have been brought out. So, and the Ministry of Social Justice and Empowerment, which is an order ministry for implementing the Transgender Act, they are in the process of incorporating gender affirming procedures, both medical as well as surgical, into the Ayushman Bharat PMJY, a up to 5 lakhs for persons who are interested. So that part may be taken care of, but you're right that in most of the government sectors, the competent surgeries and skills are not available to take care of this part. So just wanted to add to it.
Thank you, Dr. Rao. Dr. Bhavuk, I think they will come up soon, I think in the next 5 years or so, and facilities will be made available in the government.
Thank you for an excellent presentation by the team, Akhilesh and juniors from Midyear. It's a very illuminating and learning experience. But at the level of attitude for the gender dysphoria or gender identity disorders or gender incongruence, we have a long way to go to train our medical colleagues and our paramedical professionals. When even anybody with a transgender or sexual disorientation or gender identity disorder, if they come for any other problem, anxiety, depression or some other issues, the response from the paramedical staff is still very stigmatizing. And being in a private practice, as a team leader, I feel really bad. And what is the state of affairs in large medical colleges and where there is a multidisciplinary, and these people have to go there and get their treatment for themselves, or if they go as an attendant, the stigmatizing attitude of the staff is very painful. And in still this era, we get patients. I remember 2-3 patients who are well qualified MBA working in a multinational was brought after marriage for sexual issues of impotence. When in the second meeting he came out that he is gay, and he did not disclose to the family because of the pressure. And there are many of these cases which are pressurized by the family to accept the biological sex and give away the. So we have to educate public and our medical colleagues in a very big way. Even our PG students need to be sensitized and educated about these issues. Thank you.
Thank you, sir. I will agree with you. And still we have a long way to go ahead. In our Chandigarh experience, the Department of Endocrinology has started a clinic for them, separate clinic, and it has picked up, but that has been done after a lot of advocacy by the transgender people. And one particular judge was very interested, so it could take place, otherwise it was very difficult. And I agree that familial pressure and this social emergency thing is very important in our community, and in the most of the adult cases, they disclose themselves around the point of marriage or just after the marriage when the crisis occurs and the divorce occurs.
Yeah, I think, friends, the kind of divisions they have made, 3 guys came forward, like 3 genders coming forward. They have prepared, all of them have presented the case studies based on whatever way they could do, and they have also finished this presentation on time. They do need a great kind of an applause from all of us. Before we round up and it's a final remark, I'll take you maybe 10 or 20 years down the line. Professor Lalit Batra from Stanford and his colleagues from the Harvard, they have come out to identify where does actually this gender origin. जब हम पैदा होते हैं तो माता पिता, दादा दादी, नाना नानी सबसे पहले पूछते हैं बेटा हुआ या बेटी हुई. तो जेंडर जो है वो शायद बिहेवियर से आता हो, जेंडर जो है वो शायद इपिजेनेटिक चेंजेस से आता हो. तो इन्होंने एक बहुत बढ़िया एनालिसिस करना शुरू किया है. प्रोजेक्ट माइट टेक अनदर 5 और 10 years डाउन द लाइन. कुछ स्पेसिफिक डीएनए पर होल्डिंग्स क्रिएट हो जाती हैं जब आप अपने आप से हैट्रेट करते हो, अपने आप को जो नेचर ने आपको दिया है उससे लड़ते हो और आप उसको बदलने की कोशिश करते हो. तो ये जो फोल्डेड डीएनए है, इन लोगों का डीएनए बहुत अलग हो जाता है. अभी एक एआई वाला बहुत इंटीग्रेटेड प्रोग्राम आ रहा है, तो हो सकता है मेमोरी, थॉट्स और रीबाइंडिंग प्रोसेस शुरू हो जाए और आने वाले समय में एआई भी हमें इसमें जरूर मदद करे। थैंक यू सो मच लेडीज एंड जेंटलमैन, थैंक यू सो मच।
I would also request Dr. Vinod Daria sir to kindly felicitate Dr. Mirza Dave sir. And also Dr. Praveen Kekar sir to felicitate Mr. Superintendent Singh. Now I would like to call Dr. Roop Sirana sir to kindly felicitate Dr. Parinjit Singh sir. I would like to request Dr. Sunil Sharma sir to kindly come on the stage and felicitate Dr. Vinod Daria sir. I would also like to request Dr. Vikas Gaur sir to kindly come on the stage and felicitate Dr. Praveen Kekar sir.
Lecture before the inauguration, we invite the chairperson, Dr. Roop Sirana sir, Senior Consultant Psychiatrist at Tekchand Sidana Memorial Hospital, Sri Ganganagar. Dr. Gajanan Verma sir, Consultant Psychiatrist and De-Addiction Specialist at Psychiatric Center, Savai Mansingh Medical College, Jaipur. Member of Executive Committee of Indian Psychiatric Society, Rajasthan Chapter. Dr. Manu Sharma sir, Editor-in-Chief of the Annals of Psychiatric Research and Professor of Psychiatry in Gandhi Medical College, Jaipur. Now let us welcome Dr. Bhavuk Garg sir, Associate Professor at Lady Hardinge Medical College and Consultant to the Ministry of Health to speak on gender affirmation approaches in mental health care. Sir is a respected academician with exceptional contributions to community and child psychiatry and a proud member of various national policy committees.
Good afternoon, ladies and gentlemen. In the evolving landscape of mental health care, it is becoming increasingly clear that the traditional binaries, that is male and female, simply don't capture the full spectrum of human identity. As mental health professionals, we are called not upon to just diagnose, but to affirm. That is, to create spaces where every person feels respected, seen, and safe to be their authentic self. It is not about political correctness, but clinical correctness. If our patient identifies as non-binary, it is not a riddle to be solved, but it is a clinical reality. This lecture, beyond binaries, Gender Affirmation Approaches in Mental Health Care, invites us to move past outdated constructs and step into a more inclusive, compassionate, and evidence-informed approach to care. With this, I invite our speaker for this particular session, Dr. Bhavuk Garg. Dr. Garg is Associate Professor of Psychiatry at the prestigious Lady Hardinge College in New Delhi, and we yield the floor to him to share his wisdom and expertise with all of us. My co-chairperson would also like to say.
Bhavuk Garg, apart from 7 minutes working in the Medical College at Delhi, he is also representing our mental health into policy making at the Directorate of Ministry of Health and Family Welfare, Government of India, Delhi. And he will be talking about the topic and sharing his expertise as well as the policies and the programs of the government. Dr. Bhavuk.
Good afternoon, everyone, and thank you so much to the organizers for inviting me to deliver this session. Special thanks to Manju Bhaskar ma'am and Shri Prasad sir, Head of Department, Lady Hardinge Medical College, for encouraging me to be a part of this wonderful conference in Jaipur. So, as very nicely introduced by the speaker, by the chairpersons and the chairpersons, for about the concept of moving beyond binaries, and that's the title of my talk, Beyond Binaries, Gender Affirmation Approaches in Mental Health. In the beginning, the master ceremonies made a very good point that this particular topic in this particular field needs us to unlearn and relearn a few things, and that's the most essential part of my talk. That I want that each one of us becomes aware of the various concepts related to the LGBT community and how we can deliver gender affirming care. My work has been made much easier by the previous talk by Akhilesh, which covered many of the aspects that I'm going to talk about. So while I'm just a disclaimer before I start the presentation, I'm also in the Ministry of Health and Family Welfare, Government of India. The views I share today are in my personal capacity and as a faculty at Medical College. I do not represent the official position of the Ministry. So I think many of us must have seen a few of these movies. Shubh Mangal, Zada Saavdhan, Aligarh, then My Brother Nikhil from Bollywood, which gave very good portrayals of the LGBT community. And far off in Hollywood, we had movies like Dallas Buyers Club, Brokeback Mountain, which was one of the first mainstream movies to look at the LGBT community, Imitation Game, and a very good movie by Sean Penn, Milk, which covered the aspects of the LGBT community. So, if you have not seen, I would request you to go back and see these movies. That will definitely give you a new perspective towards LGBT. The outline of my talk would be mainly divided into three major sections. The first section would cover why we need to talk about this particular topic. Then I would cover certain important concepts towards LGBTQ health, specifically mental health. And lastly, the gender affirmative care, the concepts and the practical tips how we can offer gender affirmative care as mental health professionals or as psychiatrists. So why should we discuss this? There are mental disparities in the LGBT community. There are significant barriers to access mental health care, as Siddhana sir was mentioning as part of comments in the previous session, that the healthcare professionals, especially our paramedical staff, receptionists, they have significant judgmental views towards the LGBT community, because of which the community members, they feel the difficulty in accessing healthcare services. Attitude of professionals is not usually affirming in nature and is stigmatizing. There is discrimination at healthcare facilities, and there are lack of treatment protocols for various mental health issues and other concerns in the LGBT community. There are major three scenarios for which persons belonging to the LGBTQIA+. I have used the term, the expanded term, not just LGBTQ, LGBTQIA, which includes intersex and asexual as well, to seek mental health services. They may come for first mental health issues that they may be having, like we have other patients not identifying as LGBTQ coming to mental health services for depression, anxiety, psychosis, insomnia, substance disorder, and so on and so forth. They may be coming to us for planning gender affirming surgeries or other procedures, either directly or being referred from other fields like endocrinology, pediatrics, or the surgical specialties or urology. or they may be brought by the family for conversion treatment. बच्चा हमारा ठीक नहीं है, ये लड़का होगा लड़की की तरफ बिहेव करता है, इसको डॉक्टर साहब ठीक करने की कोशिश करिए. Please correct his gayness or LGBTQness or queerness as it is said. What about conversion therapy? Conversion therapy, also known as reparative therapy or sexual orientation change efforts, it refers to practices aimed at changing an individual's sexual orientation or gender identity from LGBTQ to heterosexual and cisgender, identifying as the anatomical gender and attracted towards the opposite sex. So, I'll ask this question to the audience, maybe a raise of hands. Is it recommended? How many of you feel that it's recommended? It should be done. Okay. How many of you feel it's not recommended, it's unethical and should not be done? Okay, what about others who have not raised hands for either? Okay, so it's not recommended, and Indian Psychiatric Society also has a position statement on it which says that conversion therapy in any form is not to be done, is not recommended, and Indian Psychiatric Society does not prescribe it. How many of you know, now you must be knowing because of the previous presentations, that we have a separate act for transgender? Any ideas about medical curriculum, the NMC's curriculum, both for undergraduate and postgraduate? Does it cover the aspects related to LGBTQ or gender affirming care? Does it? Okay, so I can hear some hushed up yes. Okay, so we have the Transgender Persons Protection of Rights Act 2019. As part of becoming gender affirming practitioners, I would urge those who are interested to go through this act. We give you certain good insights. And there are certain aspects related to healthcare facilities, section 15 of the act, which says that specifically for mental health, it mentions before and after sex reassignment surgery and hormone therapy counseling is an integral part. And as gender professionals, we are the ones who will deliver this. So we need to be acquainted with this act to deliver these services. There are other healthcare aspect related things, review of medical curriculum, facilitate access of transgender persons in hospitals and other healthcare institutions, health manual related to sex reassignment surgery in accordance with the WPATH guidelines. Following that, we had the rules which came out in 2020. Sensitization of healthcare professionals, again, as Siddhartha was mentioning, that it's something that the act, the rules also say that healthcare professionals in all sectors need to be sensitized about the needs and how to deal with communities in long identifying themselves as LGBTQ. There are other suggested measures in the rules which mention that at least one government hospital in every state shall be equipped to offer safe and free gender affirming surgery, counseling, and hormone replacement therapy made to female as well as female procedures. Medical insurance should cover these aspects, and separate wards for transgender persons. These were some suggestions which were made as part of the rules in 2020. The National Medical Commission, as part of the competency-based medical education curriculum, which is now being implemented, the ADCOM modules, it did talk about certain issues related to LGBTQ, but more in a indirect or tangential manner, not very overt mention and addressing of these concerns. Lots of issues in Madras High Court. Akhilesh was mentioning in the previous session related to DST, that also emanated from a case which was filed in Madras High Court. Similarly, the same petitioner was there for the cases. There was a case in Madras High Court related to NMC to remove pathologizing content about homosexuality and revise medical textbooks. NMC had issued a circular, or did not make changes, but she issued a circular that take necessary steps to modify the undergraduate medical curriculum and textbooks to remove unscientific and discriminatory content about LGBTQ plus individuals. But we all know that there are significant back and forth issues there. So NMC in 2024 recently brought out a revised curriculum which again stigmatized the LGBT community. I guess we all must have read about it in the newspaper and showed it. Sparked controversy, and then in 2024 September NMC withdrew that curriculum because of the controversy led towards lesbianism as a natural sexual practice. So after this background, I'll touch upon very briefly about the concept of sex and gender, which was highlighted in the previous session also. Sex is something which is biological, related to the anatomy, physiology, genetics, and hormones. The chromosome that a person has, the hormonal profile, the physiology, and the anatomy. Gender is which is referred to the identity that the person has part of the society the roles and the norms, and the relationships and power structures that we have in the society. Basic difference between sex and gender. Gender-bred person, again, alluded to in the previous session. Famous gingerbread man that's famous for Christmas across the world. So based on that, the gender-bred person. Four major concepts: identity, how a person identifies himself or herself as, which is the womanness or the manness. Gender expression as feminine or masculine. Again, identity and expression can vary. A person may identify as a male, but may prefer to dress as a female, and may have anatomical sex as a male. So biological sex is the femaleness and maleness. And the attraction can be towards nobody, towards men, towards women, towards both. So these are the four major concepts that mentioned. Similar gender unicorn by Transsexual Education Initiative again talks about identity, expression, sex assigned at birth, physical attraction, and the dimension of emotional attraction as well. So it's a very heterogeneous field, and I read somewhere there are around 84 to 90 categories which come under LGBTQ. So at least you should be aware of the common ones. Queer, again a very common term which is being used to describe individuals whose sexual orientation, gender identity or expression deviates from traditional societal norms. It can be used as an umbrella term for LGBTQ individuals. Earlier it was considered a derogatory term, but now even the LGBT community is referring this term and is celebrating this term within their community. I'll touch few concepts related to which contribute towards the mental health issues and highlight the mental health needs of LGBT communities. An important concept is minority stress. It's common towards all the minority, which refers to the unique, chronic and socially based stress faced by individuals from marginalized group due to their minority status. In terms of LGBTQ context, Mayor in 2013 linked this framework of social oppression to the various mental and physical disparities that are commonly seen in LGBT communities. It includes components such as external stressor, internalized stigma, concealment, anticipated rejection and coping and support, which leads to workplace bias, shame or self-hatred, avoiding schools and workplaces, anxiety in social settings. Second concept, again a very important concept, is of intersectionality, which refers to, in addition to having the minority stress of identifying as a minority community, LGBT community, if the person has some other additional social disparity in terms of the caste, the race, ethnicity, the religion, any kind of disability and class in education, it compounds the experience of oppression or disadvantage that a person has, which leads to further mental health issues and further mental health concerns. Another concept which is very important to us mental health professionals and psychiatrists is the concept of microaggression. We all are engaged in this in one way or the other, including myself. It refers to the subtle and often unintentional behaviors, comments, or attitudes that convey prejudice or discrimination towards members of marginalized group based on various aspects. Here we are talking about LGBTQ community, which may appear harmless to us, but it does lead to microaggressions towards the community. So, saying this to someone, you are gay, you don't look like it. So who's the man and who's the woman in a relationship? These are very subtle remarks that we make, but amount to microaggression towards the community. Being bisexual is just a phase, right? I don't care if you're gay, just don't hit on me. So laughing at or mocking on these non-normative norms, avoiding physical contact with persons belonging to this community, and at the level of institutes like lack of gender neutral bathrooms, not addressing or correcting others who misgender or transgender colleagues or peers. Again, important concept trauma-informed care, I alluded to in the previous session also. It is a framework that recognizes the widespread impact of trauma and understands the potential paths to recovery. Persons who are belonging to the LGBT community, they have faced trauma throughout their life in some way or the other. While coming out, microaggressions from the community, microaggressions from the colleagues, lack of support from the family. Because of this, the traditional care models may unintentionally re-traumatize them. So trauma-informed care, this trauma-informed care is used in across the settings. The psychologist colleagues would know. It's useful in disaster, it's useful in climate change, mental health. It's coming up in different fields. It creates a safe space where identity is affirmed and healing is supported. So one needs to use affirming language, I'll come to this later. Recognize signs of trauma such as anxiety, hypervigilance, and dissociation. Avoid re-traumatizing practices like being judging the person or rushing through the session. And asking invasive questions to the person and build trust over time. And it also includes coordinating with other specialties for providing holistic care to these individuals. Mental health issues are quite significant among this group. There are different studies which have been published, and they have found that the rates of depression, anxiety, suicide, both ideation and defense, substance use disorders, post-traumatic stress disorder is quite high in the LGBT community. The audience can refer to these references for detailed study. We moved on from a phase where there was, when I was doing my post-graduation, we used to study about gender identity disorder, or GID. And then the term came of gender dysphoria, and now the most recent term is gender incongruence. So we have moved from disorder to incongruence. So gender identity disorder is a mental health condition, and it was considered a mental disorder, identified as a pathology, and it was now considered outdated and stigmatizing. Dysphoria is a term used in DSM-5 as well as DSM-5-TR. It moved from distress toward distress, that the person may have distress because of their mismatch in the biological and the mismatch in the sex and the gender. The latest concept, which the community also propagates, is the concept of gender incongruence, which says there is persistent incongruence between the anatomical or the sex and there is the gender, and distress is not a necessary requirement. We have been talking about that we need to establish distress, but the latest thought process, it says that distress is not necessary. A person need not be distressed to be identified as a gender incongruent person. In ICD level, it's not in the section of mental health disorders, it's in the section of sexual health conditions. Now moving on to the last aspect of the presentation about gender affirmation. Gender affirmation in usual, it refers to the recognition and validation of a non-cisgender individual's gender identity, having social, psychological, medical and legal dimensions. It's used as a noun, for example, we use the term medical gender affirmation, or as an adjective like gender affirming care or gender affirming procedures. In the context of mental health, it refers to a supportive, respectful and evidence-based approach in mental health services that validates and affirms an individual's gender identity and expression. It involves addressing the unique psychological, social and medical needs of transgender, non-binary and gender diverse people to promote their well-being, reduce distress due to gender dysphoria, and support their journey towards living authentically. But how do you deliver this approach, which I will try to cover. I'm a huge fan of Rogerian principles. My teacher, Dr. Desai, instilled that into me. So Rogerian principles, we are all aware, and they are very important when applied in delivering gender affirming care towards the LGBTQ individuals. So we know unconditional positive regard, so we fully respect and accept the client's gender identity without judgment or bias. Empathetic understanding, we listen actively and deeply to understand the client's feelings and experiences. Congruence and genuineness, be authentic, honest and transparent in the therapeutic relationship. It should be non-directive support, allow the clients to explore and express their gender identity at their own pace. We provide a safe and affirming space, and we give the autonomy to the client. Respect the client's self-knowledge and decision-making process about their gender journey and the care. So, if anyone wants to move or is moving through the process of becoming a gender affirming practitioner or a gender affirming psychiatrist, So these are the stages that one would go through. And the stage 0 would be a stage of awareness and self-reflection. Stage 1 is awareness and self-reflection. We recognize our own personal biases
assumptions and knowledge gaps about gender diversity, and we need to reflect on our own belief systems, learn the basic terminologies, and identify areas of discomfort or bias. And my talk is effort towards that direction, that we recognize some of the basic terminology related to gender affirmative care. Then the person will move on to acquiring knowledge and education about gender affirming care. You gain knowledge about gender identity, gender dysphoria, the transgender non-binary experiences, study the current research, guidelines like WPATH guidelines, WPATH standards of care, attend workshops like these, and attend courses on gender affirming care. The next step after acquiring this knowledge, one should develop a skill base and a skill set to provide gender affirming care. We learn specific clinical skills by practicing. In our setup, we practice the use of correct pronouns, conduct gender inclusive assessments, and counseling techniques. Next step would be clinical supervision and experience. Work directly with transgender non-binary clients under guidance and the supervision with a person who is attuned to these approaches, seek to provide clinical hours and refine your approach. Then one would become an advocate and acquire system awareness, understand systemic barriers faced by gender diverse people, advocate for the rights, and it's like any other field, it's a lifelong process and a community engagement which is required to be a gender affirming care provider or gender affirming psychiatrist or mental health. While you move and learn about gender affirming care, you move through the journey would consist of from being unaware or pre-aware, having little no awareness of gender diversity issues faced by gender diverse people, which I would acknowledge that after completing my post-graduation, I was possibly in this phase unaware and pre-aware. Then we move on to become gender neutral, we avoid assumptions, use neutral language, but we still have limited engagement and understanding. We use the pronouns by default, but we are cautious that we do not offend anyone who is actively involved. Then we become a curious learner, we actively seek knowledge about gender diversity, terminology, and social issues, we read literature, attend workshops, ask respectful questions, but clinical application is somehow still missing. Then one becomes an ally, supports and advocates for LGBT rights, challenges discrimination, and in various settings, speaks up against bias using language consistently. Then one becomes a competent provider, gains clinical skills and expertise. Then an affirming specialist provides advanced tailored care, understands intersectionality, the various aspects that I talked about earlier, and collaborates with other affirming providers and other practitioners. And then one becomes an advocate and leader. The main concepts of gender affirming care: affirmation of identity, respect and validate the individual's self-identified gender, use correct names, pronouns, and terminology. These are some tips that one can use in everyday practice. Providing holistic and individualized care, recognize each person's unique journey and needs and tailor interventions, considering their physical, mental, social, and legal aspects. We need to be aware about the various acts and the laws in the legal environment in the country. Trauma-informed approach, already I have providing safe and supportive environment. Cultural competence and intersectionality, in addition to being aware about LGBTQ issues, we should be also taking care of the race, class, disability, caste, and religion. Many of the persons belong to the regional community. There are lots of intersectionality related issues, in particular by providing mental health services. Informed consent and autonomy, empower clients to make decisions, provide clear information about the options, risks, and benefits, protect their confidentiality and privacy, be mindful of safety concerns to disclosure. Multidisciplinary, again, very, very important. We alone are not involved in this care. There will be other knowledge, there will be researchers. So we need to work with them, collaborate with them, and also the legal advisory and community organizations. Advocacy and access help clients navigate legal, medical, and social systems and provide lifelong support. Mental health support would proceed throughout their life course, throughout their journey. Broadly, ask the client's correct name and pronouns, avoid gendered assumptions about relationship or appearances using language. Some examples: hello sir and ma'am, prefer would be hello, how may I address you today? Sex assigned birth, gender identity, writing them separately, asking what names and pronouns do you use. Intake question like, are you pregnant? Is there a possibility you could be pregnant? Don't assume that any female who appears as female is to be a female. Anatomically, you have sex as female. For mental health, terms of, in place of patient, a preferred term might be a client. Gender inquiries, so you're transgender, preferably to use. Would you like to share more about your gender journey? So some subtle changes in your communication patterns will enable you to provide gender communication. Create a welcoming environment in your settings wherever you work, display signs of inclusion, use intake forms with gender diverse options, and offer gender neutral restrooms if possible. Last year I was sent to Denmark by the Ministry for some work, and in Scandinavian countries there is a huge gender affirming society which I come here. And here the restrooms were not male or female restrooms. There were common restrooms for anyone to use. Any person could use those restrooms. There was no division in males and females. So they have tried to do this also for the drug administration. Be trauma informed. Assume clients may have experienced discrimination or violence. Use client-led basic conversations and avoid invasive questions about identity or the body. Educate yourself continuously. Stay updated on the terminologies, the rights and the transition options. Attend trainings on LGBTQ and rate inclusive literature. Affirm identity without gatekeeping. We should not become gatekeepers. We should not become a check. And most of the other specialties, as in the previous session also was being discussed, that we use us psychiatrists as a gatekeeper. Then it was certified also, हमारे लिए काम आसान हो जाएगा, उसके बाद ऑफिस हो जाएगा, हम बच जाएंगे. So we should actually avoid this. We should support the clients without requiring them to justify their identity and facilitate to access gender affirmed care as well. Collaborative care is very important. We need to collaborate with other specialties like endocrinology and urology and surgical branches, and ensure client-centered and respectful communication. Normalize the diverse gender identity experiences and validate distress from discrimination without pathologizing identity. Many of the persons who will present to us, they will have stigma themselves, so we need to address their internalized stigma, help them challenge shame and build self-worth, support positive identity and development of disability. Most of you would notice that the principles that I am mentioning are not some alien principles. These are the principles we use in our mental health care, irrespective of the person coming to us. So we need to just tailor the already known principles for this community and be able to provide them. Support transition roles if applicable, respect the client's flow. Not every client will come for help and transition, but they come, help them with their referrals, documentation and support letters. How we do this, how the process of gender incongruence assessment and the role of a psychiatrist, I'll touch upon in the team symposium session that we'll be having post-lunch. So I'll cover that part in that session. I'll not be addressing the details of that particular aspect. Understand this intersectionality, explore how race, class, caste, religion, disability can intersect with the gender, and avoid one-size-fits-all approach. Every person would be different. We have to provide individualized care. We cannot just use a common approach and tailor it to every person. We have to individualize it to a particular person and take care of the intersectionality issues as well. We need to understand relationships also, very, very important. Poor relationships do not follow the norms that we have built as a society. Very, very frequently I come across clients in which they may have polyamory, they may have open relationships, non-heteronormative relationships such as polyamory involving multiple partners, sexual romantic partners. We as mental health practitioners, we have to be non-judgmental, we have to respect their choices and value, and we can use those opportunities to engage in safe sex practices. Be mindful of this particular aspect. And as part of the various sessions that I have attended from members of the LGBT community, this was the most important part that they felt, that when we go to a doctor, they are more interested in my sexual life than my identity as a queer person. So this is something we need to avoid, and that leads that re-traumatizing experience and goes against the trauma-informed care that I was telling about. There is a concept of gender affirming cognitive behavior therapy also. The same principles of cognitive behavior therapy, but validates and affirms child gender identity, challenges internalized transphobia and negative self-belief, addresses minority stress. So we have to address those aspects that I have already covered. And integrate trauma-informed care principles, build resilience, self-advocacy, assertiveness skills, teach emotional regulation, promote engagement in social activities, psychoeducation about the gender transition and rights, focus on healthy relationships, and include safety planning and crisis support. So the same disclosure, some components added would make it gender affirming. Lastly, a word about if anyone is interested in planning a LGBTQIA+ friendly clinic, train your staff in LGBTQ sensitivity, use inclusive language everywhere, make intake forms and electronic medical records inclusive, ensure visible signs of inclusivity. You can use posters, you can have some video clips playing on the TV that you have in your waiting area, create a safe and confidential environment, offer affirmative health services, engage with the community, make them partners in the various processes, and your policies need to be inclusive of the LGBTQIA+. So these are my references. If anyone is interested, I tried to do the presentation. I believe the chief is due to arrive already arrived. So thank you. I end my presentation with the famous statue of Lady Hardinge that we have in our college. We call her respectfully, we call her as Mahatma. So Lady Hardinge. Thank you.
Thank you, Dr. Bhavuk. Finishing well in time and being concise, but still inclusive of most of the areas that are covered. If there are any questions or comments from the audience. Yes. Identify yourself.
I am Dr. Meena, practicing in Government Medical Police, Good morning, sir. Good morning, sir. Myself, Dr. Meena, practicing in District Hospital, Jaipur. My question is, client comes to me that after marriage, my husband is showing bisexual. He is attracted towards both male and both female. I thoroughly examined the history, the patient and informant. Initially, the patient was attractive or interested in sexual activity towards his wife. But after few days, after 2 to 3 years, he is more attracted towards the male. This is the lady before me. Sir, how is possible and what is the treatment step for as a psychiatrist?
So, gender affirming care would say that there is no treatment for it. It's not a disorder which requires any kind of treatment. It's the person's preference that he or she is attracted towards a particular gender, and you have to respect that. You can look for some kind of pathology. You can look for comorbidities. You can look whether it's some kind of an obsessive thought which might be contributing. You can rule those things out, but once you have ruled everything out, there is nothing that as a treatment that you can do. What you can do, definitely do as a psychiatrist, provide gender affirming care, help the person in their journey and understanding how they are feeling, help the family, help the wife also accept that if it needs to be accepted, provide them the support, provide them the education that needs to be provided. But like I said, if you have ruled out any kind of a disorder, there is no quote-unquote treatment per se, either pharmacological or psychological. We cannot correct something which cannot be corrected, which is usually the expectation of the family. And like you mentioned that earlier he was attracted to females, now towards males. That is something that he may be telling. He may always have been attracted to males, but because of societal pressure and the environment, and we have many such persons in the community and in our practice that we have, that out of the society's pressure, they do marry, they have kids also, despite being attracted towards male. That does not mean कि डॉक्टर साहब पहले तो ये उनको बच्चा भी कर लिया अब हो गया इनको ऐसे. So it's not like that. Once you have ruled everything out, then it's something that is normal for that person.
Thank you, sir. Sir, any scale is available to identify this type of bisexual?
None that I'm aware of. But like I said, it's not a pathology, so there need not be a scale for this.
Question?
saying that he is having thought of that he is a transgender. But when we ask that really you are having question on your sexuality or you are having question on your gender identity, but he says that I am male, but I am having thought of that I am a transgender. So how can you proceed with this case?
You've answered the question yourself. If it's an obsession and you're identifying an obsession, treat the obsession.
So first we have to treat obsession first.
If you have established that there is obsession, if you have established diagnosis of OCD, then treat OCD. It doesn't matter which kind of thought or thing that he is having for obsession, or the treatment would remain the same. If you have ruled out that it's not something which is normal, he says that I know that I am not a transsexual and these are just recurrent, repetitive, intrusive thoughts, I recognize his own thoughts, found distressing, irrational, absurd, tries to resist but still coming. If you are able to satisfy these criteria, you have established obsession, treat the obsession. He may be any.
Very nice presentation. I also ask a question. Which one is the psychiatric comorbidity associated with this cause?
Comorbidities?
Any psychiatric comorbidity, especially with these people?
So comorbidities are mostly anxiety, depression and substance use. These three have been found very commonly. In the Western society, post-traumatic stress disorder has also been found. In Indian setup, not so much. But again, Indian studies have a very limited number of participants in these studies. But depression, anxiety and substance use, these three are the major comorbidities found in persons with both gender incongruence as well as LGBT community.
In the era when homosexuality was not legal, or even the other sexual orientations, there was a common belief that these people are high risk for STDs. But nowadays, when once legal, we don't talk about screening, even screening for these people who are, we used to think that they are high risk. Is it
So the rates of STIs and STDs and HIV/AIDS have been found to be higher in the persons belonging to LGBT community because of multiple factors, like multiple relationships, especially anal sex, because of which is known to cause more risk of transmission of the various STIs. So there are higher rates, but as part of this treatment, if we are able to elicit those risk factors, then we should screen for various STIs. But gender affirming care, that says we do not assume that they will have inherently high. Any person who is coming to us, okay, he belongs, he or she belongs, or they, he, she or they belongs to LGBT community, then definitely there is high risk of STIs. So gender affirming care says, do not assume that they are high risk. You can assess, if you find high risk, you do get them investigated, but don't assume that they will have high risk.
For the younger colleagues in the psychiatry, are there any training, specific trainings for gender affirmative therapies so that they can get mental?
So specific trainings for gender affirming mental health care are this Tata Institute of Social Sciences, DTE.GHS. There's a person there by the name of KP Ranade, KP, who identifies as they, them. They have taken out a module on mental health care. Along with that, associations like the Association for Transgender Health in India, they carry out training activities for gender affirming care, including mental health care, and we also have the Mariwala Health Initiative, MHI, which has a specific manual on psychosocial care for LGBTQ or fluid. So these are some modules which are available for this. Go ahead.
NIMHANS has a module.
So NIMHANS has a psychosocial module on LGBT.
NIMHANS has a module, then there is a travel project which follows. And NIMHANS has recently, just around I think 4 or 5 days back, has given an advertisement for the LGBTQ friend affirmative care that they are going to start like some small fellowship.
There's Dr. Jay,
I think 4 or 5 days days back?
Dr. Jay, who is a faculty in psychiatric social work at MIMS, he is leading this LGBTQ related manuals and other activities.
Last question.
I'm Dr. Akhilesh Sharma. I'm APA licensed controller. So, pragmatically speaking, like when we get cases in the clinics, there are very mixed scenarios that we are faced with. Like there might be a person with a homosexual orientation who might express explicit will for the conversion treatment that we are condemning in psychiatry. So ethically, where do we stand in this issue?
Ethically, we have to inform about the current understanding. We have to tell them that there is something we do not offer because it does not work. We know that any kind of conversion treatment which was properly done here, it does not work. The person merely walks down to the pressure put upon him or her. So we have to tell them that there is something which is now not being used. Even if you ask, there is something which I am not competent to provide. I can say for myself, I am not competent to provide any treatment which is not acceptable.
The vice versa also happens. Like there are people who are not having the gender incongruence established, but they might be seeking gender affirmation into the opposite, into a different sex, for some particular social reason. For example, like marrying a partner, right, who desires a heterosexual partner. So this situation has also been faced in the clinic.
So this is clear, very rightly said, and this is one dilemma which has not been clearly resolved. So if we go by DSM-5 it says that for gender dysphoria to be established, you need to establish the distress between your biological sex and the gender identity that you prefer, right? But ICD-11 and the recent thought process, it does away with the distress part. It says that gender incongruence is something that one can just say that may not have distress, that I am born assigned male at birth, but I want to be reassigned or I want to have gender affirmation procedure to become female. And you need not establish anything for that at present. Right? So again a dilemma, but we have to go by the individual case. And we have to present the pros and cons. But now gender dysphoria in the presence of distress is not necessary as per the latest WPATH guidelines that we are running.
Thank you.
Thank you. A very nice presentation and discussion also very meaningful. Thank you.
Over to the organizers. Thanks for giving us the opportunity to chair this important session. And thanks to Dr. Bhavuk.
Inclusive and gender-sensitive care. Your voice is crucial in this evolving dialogue. Now I request the chairpersons to felicitate Dr. Bhavuk Garg. I request Dr. Jose Ali sir to felicitate Dr. Gajanan Verma. I request Dr. Akhilesh Sharma to felicitate Dr. Manu Sharma sir. As a chief guest is about to arrive, so please remain seated. Soon we will be starting with our inauguration ceremony.
To welcome you to the inaugural ceremony of 2nd Raj Mit Psychon, organized by the Department of Psychiatry, Mahatma Gandhi Medical College and Hospital, Jaipur.
This gathering marks the commencement of a significant academic endeavor, an opportunity to exchange ideas, challenge perspective, and deepen our understanding of ever-evolving psychiatric landscape. With this year's theme, Shifting Paradigm, Gender-Sensitive Psychiatry for a Changing World, we collectively take a step towards more inclusive, gender-attuned practices.
We now take honor of inviting illuminaries and grace the dais. May I invite our chief guest, Dr. M.L. Swankar Sir, Emeritus Chairperson of Mahatma Gandhi Medical College, to kindly grace the stage.
We now take immense pride in inviting our guest of honor, Dr. Vinay K. Kapoor, Sir, Pro-Vice President and Pro-Vice Chancellor of Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, to kindly grace the dais. Dr. Vinod Daria, Sir, President of the Indian Psychiatric Society, Rajasthan Chapter, and Professor in Department of Psychiatry, Government Medical College, Kota.
I also request Dr. Parth, Vice President of Indian Psychiatry Society, Rajasthan Chapter, and Professor of Department of Psychiatry, Jawaharlal Nehru Medical College, Ajmer, to kindly grace the stage.
Now I request Dr. Jitendra Jinger, Sir, General Secretary, Indian Psychiatric Society, Rajasthan Chapter, and Professor and Head of Department of Psychiatry at Gitanjali Medical College, Udaipur.
I humbly call upon Dr. Sunil Sharma, Sir, Treasurer of Indian Psychiatry Society, Rajasthan Chapter, and Senior Specialist at Psychiatric.
With respect, I request Dr. Manu Sharma, Sir, Editor-in-Chief of the Annals of Psychiatric Research and Professor of Department of Psychiatry at Gitanjali Medical College, Udaipur, to kindly join us on the stage.
Next, I warmly welcome Dr. Manju Bhaskar Ma'am, Professor and Head, Department of Psychiatry, Mahatma Gandhi Medical College and Hospital, Jaipur, and also the organizing chairperson of this conference. I also cordially invite Dr. Aditya Soni, Sir, Professor of Department of Psychiatry, Mahatma Gandhi Medical College and Hospital, Jaipur, and also the organizing secretary of this conference, to kindly come up on the stage.
Let's begin this auspicious occasion by invoking divine blessings through the traditional lighting of the lamp. It begins with sacred glow of light, an eternal emblem of knowledge and purity, dispelling darkness and gently lightening the path towards the wisdom and truth. Shubham karoti kalyanam arogyam dhan sampada shattu buddhi vinashaya deep jyoti namastate. May I now invite our dignitaries to kindly come forward for the deep prajalan ceremony.
To the felicitation of our distinguished dignitaries as a gesture of our deep respect and appreciation for their presence. I request the organizing chairperson, Dr. Manju Bhaskar Ma'am, to kindly present a bouquet, and the organizing secretary, Dr. Aditya Soni Sir, to felicitate our chief guest, Dr. M.S. Vankar Sir, with the safa and shawl. Dr. M.S. Vankar Sir is not just a torchbearer in medical field, but a name synonymous with visionary leadership in healthcare. as Emeritus Chairperson of Mahatma Gandhi University of Medical Sciences and Technology and Chairman of India Education Trust. He has transformed the landscape of medical education in Rajasthan. A pioneer of IVF in the state, Sir is credited with delivering Rajasthan's first test-tube baby and has helped over 20,000 couples through assisted reproductive technology. From PGI gold medalist to establishing Mahatma Gandhi University, his excellence spans across clinical, academic, administrative, and philanthropic dimensions. Under his guidance, Mahatma Gandhi Medical College and Hospital has been certified with several accreditations. Thank you, sir, for your unwavering dedication to the advancement of academics and healthcare, and for gracing this occasion with your radiant presence.
I request Organizing Chairperson Dr. Manju Bhaskar ma'am to kindly present a bouquet and the Organizing Secretary Dr. Aditya Soni sir to felicitate our guest of honor Dr. V.K. Kapoor sir with Safa and shawl. An alumnus of AIIMS New Delhi, Sir is a globally respected figure in surgical gastroenterology with over 3 decades of exemplary service, including his tenure as Professor and Head of the Department of Surgical Gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. He has made profound contributions to clinical practice and academic excellence. His prolific research with over 200 publications and numerous prestigious orations across the globe earned him a place among 2% scientists worldwide as recognized by Stanford University. I request Organizing Chairperson Dr. Manju Bhaskar ma'am to kindly present a bouquet and the Organizing Secretary Dr. Aditya Soni sir to felicitate Dr. Vinod Daria sir with Safa and shawl. Sir is the President of Indian Psychiatric Society, Rajasthan chapter, is an academician deeply rooted in the clinical service and social outreach as Professor of Psychiatric at Government Medical College, Kota. He is also a crucial figure in district mental health program and legal aid-based well-being units for student mental health. An impactful leader, his expertise covers community psychiatry, suicide prevention, and mentorship of countless young psychiatrists in the state. His humility, clarity of vision, and silent perseverance have positioned him as a pillar of leadership with society. Thank you, sir, for being an inspiring leader in community mental health.
Now I request the Organizing Chairperson, Dr. Manju Bhaskar ma'am, to present a bouquet, and the Joint Secretary, Dr. M.K. Tak sir, to felicitate Dr. Parth Singh Meena sir with a Safa. Sir is the Vice President of Indian Psychiatric Society, Rajasthan chapter, and Professor of Psychiatry at Jawaharlal Nehru Medical College, Ajmer, and alumnus of AIIMS Delhi and SMS Jaipur. Sir is an academic prodigy, but also a guiding light for emerging psychiatrists. He has authored over 30 high-quality research papers, contributed to Indian Psychiatric Society national guidelines, and served 3 terms as an editor of the Indian Psychiatric Society Rajasthan chapter. He is also the founding editor of the Annals of Psychiatric Research, a journal that has elevated the standard of psychiatry in Rajasthan. Thank you, Dr. Parth Meena sir, for your mentorship and tireless contributions to psychiatric education.
I request the Organizing Chairman, Dr. Manju Bhaskar ma'am, to present a bouquet, and Organizing Secretary, Dr. Aditya Soni sir, to felicitate Dr. Jitendra Jinga sir with Safa. Sir, the General Secretary of Indian Psychiatric Society, Rajasthan chapter, and Professor and Head of the Department of Psychiatry at Geetanjali Medical College and Hospital, Udaipur. He also serves as Assistant General Secretary of the Indian Psychiatric Society. With over 16 years of dedicated experience, he is held high regard as a seasoned educator and clinician, widely recognized for his scholarly contributions and for serving as valued resource faculty in the numerous prestigious CMEs and academic forums across the country. A recipient of prestigious honor including the Young Psychiatrist Scholarship Award, Dr. A.K. Kala Award, and Professor Shiv Gautam Oration Award, his presence today is truly an honor for all of us. Thank you, sir, for being the backbone of Indian Psychiatric Society Rajasthan chapter's efficient functioning and bringing youthful dynamism to leadership.
Now I request the Organizing Chairman, Dr. Manju ma'am, to present a bouquet, and the organizing secretary, Dr. Aditya Soni sir, to facilitate Dr. Manish Sharma sir with the SAFA. Sir is the professor of psychiatry at Gitanjali Medical College and Hospital, Jaipur, editor-in-chief of the Annals of Psychiatric Research Journal. He is a gold medalist in MBBS as well as the best outgoing postgraduate in psychiatry from Father Miller Medical College, Mangalore. Also the recipient of prestigious Dr. R.N. Murthy Foundation Fellowship in hands in collaboration with the Association for the Advancement of Mental Health Programs, Geneva. He holds fellowships from the Indian Psychiatric Society, Addiction Psychiatric Society of India, and the Indian Association of Geriatric Mental Health. Sir has authored numerous publications in peer-reviewed journals. He has received multiple research awards, including the Professorship Gautam Orishan Award, and is a recognized academic leader and resource faculty at national conferences and CMU programs. We are honored to welcome you, Dr. Manish Sharma, sir.
I request Organizing Chairman Dr. Manju Bhaskar ma'am to present a bouquet and the Joint Secretary Dr. N.K. Tak sir to facilitate Dr. Sunil Sharma sir with SAFA. Dr. Sunil Sharma sir serves as the Treasurer of Indian Psychiatric Society, Rajasthan chapter, and is the Senior Specialist in Psychiatry and Deputy Superintendent at Psychiatric Center, SMS Medical College, Jaipur. Known for his administrative acumen, he has also served as the State Nodal Officer and Officer on Special Duty for the National Mental Health Program. His pragmatic leadership, community-grounded approach, and unwavering work ethic make him a trusted name in the both clinical circles and government mental health initiative. Thank you, sir, for your dependable stewardship and relentless service to mental health administration.
Now, I request Dr. Gitika ma'am to kindly felicitate Dr. Manju Bhaskar ma'am. Ma'am is the heart of our department, a pillar of academic strength and clinical grace. With years of compassionate leadership in psychiatry, she has nurtured generation of residents and inspired countless minds. Her dedication to teach, research, and service is reflected in many initiatives she has led, and the integrity with which she serves our institutional and academic committees. Calm yet unwavering, ma'am's presence brings quiet confidence and purpose to everyone she touches. Her vision continues to shape the soul of this department and spirit of this very conference. Thank you, ma'am, for being our guiding light. Now I request Dr. N.K. Tak sir to kindly felicitate Dr. Aditya Soni sir. Sir, Professor of Psychiatry at Mahatma Gandhi Medical College, Jaipur, is someone we deeply respect, not just for his qualification and experience, but for steady guidance and clarity he brings into every interaction. With a strong foundation in psychiatry and a global exposure through a dual MBA MSc, he has led by example, blending knowledge through thoughtful leadership. His work in digital psychiatry, de-addiction, and child mental health reflects his dedication to progress in the field. Thank you, sir, for your leadership, innovation, and dedication. May I now request our organizing chairman, Dr. Manju Bhaskar ma'am, to kindly deliver the welcome speech.
Yes, Dr. M.L. Swankar sir, all the dignitaries on the stage, dear colleagues and delegates, a very warm welcome to the second Raj Meet Psychon. It brings us great happiness and pride to welcome Dr. Swankar sir today. He is not just a pioneer in reproductive medicine, but also the visionary who created Mahatma Gandhi Medical College and Hospital. From bringing Rajasthan its first test tube baby to building one of India's best medical colleges, his work has touched many lives. Sir, your presence reminds us that real leadership is not just about making institutions. It's honored by the gracious presence of our guest of honor, Dr. V.K. Kapoor sir. He's a pro-vice chancellor of Mahatma Gandhi University of Medical Sciences and Technology, a globally respected figure in surgical gastroenterology. Contributions as a teacher, researcher, and international speaker have illuminated the academic world. We open our hearts and mind. This conference is a step towards breaking silence, reducing stigma, and learning how to support everyone with kindness and respect. Let this be the beginning of positive changes, not just in psychiatry, but in how we treat and care for each other as fellow human beings. Thank you so much. Thank you.
Dr. Jitendra Chingar, sir, General Secretary of IPS Rajasthan Chapter, to kindly share his words with us.
Ladies and gentlemen, on behalf of the General Secretary of IPS Rajasthan Chapter, I welcome the chief guest of today's function, Dr. M.L. Suvankar. The guest speaker came all the way from the part of the India, dear PG students. At the outset, I would like to congratulate the organizing team for the hosting the second mid-year conference of IPS Rajasthan Chapter, Raj Mid Psychon 2025 at this beautiful venue. The organizers chosen the theme of this shifting paradigm, psychiatry for a changing world. For this, we have from different parts of the country to enrich this academic event. Two highlights of this conference. This event is not less than an annual conference, 1.5 day long event, and we have the theme symposium, plenary sessions, we have quiz.
Now I invite Dr. Midyear, sir, President of Indian Psychiatric Society, Rajasthan Chapter, to address the gathering and share his vision.
Chief guest ML Swankar sir, Emergency Chairperson, Guest of Honor V.K. Kapoor sir, Pro Vice Chancellor, Mahatma Gandhi University and Sciences Technical Institute. सर आपकी महात्मा गांधी इंस्टीट्यूट है जो एनएमसी का नोडल ट्रेनिंग सेंटर है और वो आपने साइट पे इसको बेस्ट ऑफ द कॉलेज जैसे कि मंजू जी ने बताया उसको पहुँचाया है. उसी कड़ी में आपने इस एकेडमिक इवेंट को मंजू भास्कर और उनकी टीम को करने के लिए जो अलाउ किया है उसके लिए सारी सोसाइटी आपके लिए आभारी है. और डॉक्टर मंजू भास्कर और उनकी टीम ने मेरे ख्याल से इतनी हम्बली और इतना अच्छे से सबको इन्वाइट किया है कि पूरा हॉल भरा हुआ है. मिड राज साइकोन शायद सेकंड है और ये इतनी गर्मी के अंदर ऑर्गेनाइज हुई थी कि लोगों को शायद शक था कि पता नहीं कितने लोग आएंगे क्या नहीं आएंगे. और इसमें ऑलमोस्ट ऑल सभी मेडिकल कॉलेज से फैकल्टी और रेजिडेंट सब आए हैं. सबने शायद हमारे पास एक बड़ा विषय आ गया था कि कुछ लोग बोले हमारे पेपर हमें अभी भी सबमिट करने हैं. 4-5 लोग थोड़े नाराज भी होने का लास्ट डेट निकल गई है. तो इतना अच्छा कॉम्पिटिशन था कि हमें इस बार मना करना पड़ा कि आप अगली कॉन्फ्रेंस में कर देना, इस कॉन्फ्रेंस में ऑलरेडी ओवरफुल हो गया है. सो ये डॉक्टर मंजू भास्कर और उनकी टीम आपके मार्गदर्शन में जितना आपने उनको खुला हाथ दिया है काम करने के लिए, उनकी ये सक्सेस है कि एकेडमिक सेक्शन सारे फुल हुए हैं और पेपर्स को मना करना पड़ा है और डेलीगेट्स आप देख ही रहे हैं कितने सारे अच्छे से आए हैं. जो हमारी सोसाइटी के ऑफिस लीडर है वो मैं देख रहा हूँ शायद मिड राज साइकिल में इतने पहले नहीं आते थे. सारे ऑफिस लीडर्स ऑलमोस्ट सब आए हैं क्योंकि मुझे कोटा में अगली कॉन्फ्रेंस करानी है. तो मैंने आज सिग्नेचर ढूंढ रहा था कि सब ऑफिस लीडर सिग्नेचर कराऊं तो कोई एब्सेंट ही नहीं मिला मेरे को. तो मेरे ख्याल से ये मैं अगेन ऑर्गेनाइजिंग टीम को ही धन्यवाद देना चाहूंगा कि आपने शायद इतना हम्बली सबको बुलाया है कि आपके आग्रह को मना नहीं कर पाया. अब मंच में आप सबसे कहना चाहूंगा कि इसकी कंटिन्यूटी में ही अगली कॉन्फ्रेंस मुझे करानी है कोटा में, तो वो 4-5 अक्टूबर को है. आप इसी उत्साह से सब उसमें बता रहे हैं. लॉन्ग लिव आईपीएस.
Thank you, sir, for your encouraging words and for leading with such clarity and commitment. We are grateful to have your presence, sir.
It is now our honor to request our Chief Guest, Dr. M.L. Swankar, sir, Emeritus Chairperson of MGUMST, to deliver the inaugural address.
सभी को मेरा नमस्कार. आज इस राजस्थान मिड साइकोन इंडियन साइकेट्रिक सोसाइटी की मिड कॉन्फ्रेंस है. मैं पधारे सभी डेलीगेट्स तो वो मेरा हार्दिक अभिनंदन. मंच पर विराजमान डॉक्टर V.K. कपूर और प्रो वाइस चांसलर डॉक्टर विनोद जी, प्रेसिडेंट ऑफ द सोसाइटी, डॉक्टर पार्थ सिंह मीना, who is the president-elect, Dr. Jitendra, Secretary of the Society, Dr. Lalit Sharma, Dr. Manu Sharma, and other executives of this conference of the society. Our organizing chairperson, Dr. Manju Bhaskar, Head of the Department of Psychiatry at Mahatma Gandhi Medical College, Dr. Adit Soni, Organizing Secretary, and all the distinguished delegates. कई चेहरे उनको काफ़ी समय से जानता हूँ और वास्तव में इस गर्मी में इतने लोगों का आना जो डॉक्टर गार्ग ने बोला है वो सही बोला है, shows the efforts and humbleness of the whole team organizing this conference. Psychiatry is always a relevant topic in all ages, all times. हमेशा relevant रहा है. Paradigm shift होते रहते हैं, that is different. अभी जैसे जो इशू है डिजिटल साइकेट्री का है, यूज ऑफ मोबाइल और सोशल मीडिया जो हुआ है, मेंटल हेल्थ इशू बहुत ज़्यादा प्रॉब्लम है. नॉन कम्युनिकेबल डिजीज में आफ्टर डायबिटीज, कार्डियोवास्कुलर कैंसर, आई थिंक मेंटल हेल्थ डिजीज इज वन ऑफ द टॉप मोस्ट. तो ये जो डिसऑर्डर्स आ रहे हैं इनको किस तरह से टैकल करना, ये बहुत बड़ा चैलेंज है. सर आज सुबह का अखबार पढ़ा होगा आपने, सुप्रीम कोर्ट ने भी जो कोटा में सुसाइड हो रहे हैं बच्चों, उस पर बड़ा एडवर्स व्यू लिया. वाई देयर आर सो मेनी सुसाइड, मोर देन 14 सुसाइड इन ईयर और सो हैप्पी व्हाट द गवर्नमेंट इज डूइंग. इसमें गवर्नमेंट से भी ज़्यादा पूरी सोसाइटी में पीयर प्रेशर है, आपस में कॉम्पिटिशन की भावना, पेरेंट्स का प्रेशर, बड़ों का प्रेशर, मुझे बच्चे को डॉक्टर बनाना, मुझे बच्चे को इंजीनियर बनाना. दुनिया में बहुत चीज़ें एक्चुअली मुझसे पूछा जाए तो यू लर्न मोर फ्रॉम द फेलियर अदर देन सक्सेस. और वो जो प्रेशर बनाते हैं, और इवन शादियाँ भी टूट रही हैं, डाइवोर्स रेट बढ़ गई है, इंटरफेरेंस ऑफ दी फैमिली बहुत साइड हो जाता है. तो ये सोशल मीडिया का, मोबाइल टेक्नोलॉजी का एडवांटेज भी है, डिसएडवांटेज है, जिसको आप साइकेट्री वालों को, क्लिनिकल साइकोलॉजी वालों को फेस करते हैं. इससे कैसे डील करें? ये चीज़ आज की नहीं है, ये चीज़ शुरू से चली आ रही है. आपने जब महाभारत का युद्ध हो रहा था तो अर्जुन जब अपने फैमिली मेंबर्स को देखा बहुत इमोशनल हो गया. सीधंतिमम गात्राणी मुखम च परिशिष्यति, मेरा शरीर एकदम ढीला हो गया है, नर्वस हो गया है, मुंह सूख रहा है, कुटुंब से पर देखे थे, पूजा चल रही है, गाँव के खड़े अनुसर को उसने नीचे कर. That was sort of symptoms of generalized anxiety disorder. तो फंडामेंटल ऑफ साइकेट्री तो भगवत गीता से जो भगवान कृष्ण ने बोला है अर्जुन को, एक ही श्लोक, मात्रा स्पर्शास्तु कौनते शीतोष्ण सुख दुख आगमापायन कृष्ण. जो विषयों के मिलने से, इंद्रिय विषयों मिलने से जो भोग हैं वो तो आते जाते हैं, अप एंड डाउन, सुख दुख, दिन रात, ठंड गर्म, जितनी भी चीज़ें हैं प्रॉब्लम से लाइफ में आती रहती हैं. उसको आप सहन करना सीखें, तितिक्षा भी सहन करना. यू शुड हैव द टॉलरेंस टू एक्सेप्ट योर फेलियर्स, टॉलरेंस टू एक्सेप्ट योर डिफीट, एंड सिमिलरली टू टॉलरेंस टू एक्सेप्ट योर सक्सेस ऑल्सो. दैट शुड ऑल्सो नॉट गो इनटू योर माइंड. ये भी साइकेट्री का, क्लिनिकल साइकोलॉजी का, दैट इज कॉग्निटिव बिहेवियर थेरेपी का एक पार्ट है. जो फंडामेंटल स्टेटमेंट है भगवान कृष्ण यहाँ से 5000 पहले. अभी जैसे आपने टॉपिक रखा है पैराडाइम शिफ्ट एंड जेंडर डिस्फोरिया. डिस्फोरिया आजकल बच्चे अपना सेक्स चेंज कराना चाहते हैं आइडेंटिटी क्राइसिस की वजह से, और वो इसमें भी सोशल मीडिया so many reasons. And there is definitely gender difference. I being a gynecologist, I know the effect of hormones, estrogen, progesterone on the female cycle, what happens during menstrual cycle, what happens during pregnancy. So all those things are there. They are more emotional, more empathetic, easy to get disturbed, easy to get depressed also. But other problems are there in the other child, that is late gender also. They become sometimes very violent. They have माता बहनों सम्मान घट रहा है और रेप की घटनाएं हो रही है और रिलेटेड टू साइकोलॉजी। तो आपका एक बहुत ही बड़ा दायित्व है, जिम्मेदारी है कि इसको बड़ा इफेक्टिवली डील करें। आप इन योर ऑर्गेनाइजेशन itself ड्यूरिंग एग्जामिनेशन देखते हैं बच्चे कितने प्रेशर में रहते हैं, स्पेशली फर्स्ट एंड सेकंड एंड इसमें आप इस चीज़ को वहाँ पे टैकल करें और उनको सिखाएं कि किस तरह से इन चीज़ों से कोप अप किया जाए। ये सबसे इम्पोर्टेंट चीज़ है। बहुत ज़्यादा अभी रिसेंटली लास्ट वीक की मैनचेस्टर यूनिवर्सिटी से महात्मा गांधी यूनिवर्सिटी मीटिंग आई थी और उसको हेड कर रहे थे डॉक्टर विमल सर। हिमसेल्फ मुझे साइकेट्रिस्ट फ्रॉम जयपुर और PGI चंडीगढ़ में मेरे साथ के सीनियर थे और वो यूनाइटेड नेशन की मेंटल हेल्थ की ग्लोबल लीडर, काफ़ी सजेशंस और एडवाइजरी और जो सॉफ्टवेयर डेवलप किए हैं कोटा के लिए भी उन्होंने एक सॉफ्टवेयर गवर्नमेंट ऑफ राजस्थान में इस तरह से स्ट्रक्चर्ड प्रोग्राम बनाया क्या क्या चीज़ें इंक्लूड होनी चाहिए सो दैट वी कैन रिड्यूस दिस डिप्रेशन एंड लीडिंग अप टू दिस सोसाइटी वेरी वेरी डेंजरस। बहुत ही दुख होता है कि छोटे से आप गोल को अचीव करने के लिए अपनी जीवन लीला को खत्म करें। जीवन बहुत अमूल्य है, ईश्वर का दिया हुआ है। आप जरूरी है कि जो आप चाहते हैं वो हो। और भी बहुत चीज़ें दुनिया में आपके पेरेंट्स हैं, आपके भाई बहन हैं, आपके मित्र हैं, कई तरह की चीज़ें करने के लिए वो करें। तो ये जो आपने टॉपिक रखा है डिजिटल साइकेट्री एंड जेंडर डिस्फोरिया, मैं तो ज़्यादा इसमें जानता नहीं डेफिनेटली, इतना जरूर जानता हूँ मेंटल हेल्थ प्रॉब्लम्स ऑल ओवर मेरी ग्रैंड डॉटर्स को ले लो, जब तक वो मोबाइल नहीं देते खाना खाने के लिए उनको मोबाइल खाना पड़ता है, ऐसी लत लगे लोगों को, बच्चों को, सबको। और दूर हो गया जो फैमिली यूनाइटेड रहती थी वो अब हर आदमी मोबाइल लगा हुआ, चाहे पास में बैठे कभी दूर से कई एग्जाम्पल दे सकते। और आज मुझे बुलाया, मैं सम्मान दिया, इसके लिए मैं पूरी ऑर्गेनाइजिंग कमेटी का, पूरी इंडियन साइकेट्रिक सोसाइटी राजस्थान चैप्टर का तहे दिल से आभार व्यक्त करता हूँ। और मैं तो ये चाहता हूँ कि हमारा 2 अक्टूबर से सिल्वर जुबली मतलब 25 साल पूरे हो जाएंगे मेडिकल कॉलेज को, तो पूरी 1-1.5 साल तक हर डिपार्टमेंट के कॉन्फ्रेंस एकेडमिक एक्टिविटी में कई चीज़ें होंगी। आप लोग प्रयास करें, आप सभी से मेरा आग्रह रहेगा कि राजस्थान की नेशनल कांग्रेस महात्मा गांधी साइकेट्री में लाए 1.5 साल किया था। तो वो यूजुअली वी लाइक टू डू इट फ्रॉम अक्टूबर टू मार्च में तो ज़्यादा हॉट सीजन होता है। ये तो मतलब रियली वेरी हैप्पी। तो आप आए तो खुले दिल से हम आपका स्वागत करेंगे। एज बेस्ट केयर थैंक यू वेरी मच।
Thank you so much, sir, for your inspiring address. Your wisdom, vision, and lifelong dedication to healthcare continues to illuminate the path for us all. Now I would like to invite our guest of honor, Dr. V.K. Kapoor, sir, to address the gathering.
Dr. ML Swankar sir, the Chairperson Emeritus of the Mahatma Gandhi University of Medical Sciences and Technology, Office Bearers of the Rajasthan State Chapter of Indian Psychiatry Society, invited guests and delegates, ladies and gentlemen. First of all, on behalf of the university, I would like to thank the Indian Psychiatry Society and the Rajasthan State Chapter for asking our Department of Psychiatry, headed by Dr. Manju and assisted by Aditya and Parth, to host this meeting. Thank you all very much. In my capacity as the Pro Vice Chancellor of the University, it is my duty and responsibility that I attend the academic events of all departments, even if I don't understand what is being discussed there. I try to do that. But when Dr. Manju invited me to come to this meeting, I was a bit hesitant. I was a bit scared because I knew that the moment I walk into the hall, all of you would notice my body language. You would see how I am sitting, how I am walking up to the stage, and you would analyze each and every word that I speak, because that is what you are expert in. But I really admire and envy the psychiatrists and psychologists, because the physicians think that they are great because they can diagnose every disease. But they can't do that without investigations. We, the surgeons, think that we are great because we can treat any disease, but we can't do that without equipment. You people diagnose and treat without any support. So I think you are above physicians and surgeons. With more and more mental health issues, with less and less stigma now attached to these diseases, I'm sure more patients are coming to you than they used to come 10, 20, 30, 40 years ago. That is an opportunity, but it is a responsibility also. Dr. Swankar sir mentioned about the news item today, the quota deaths as they have come to be known. I think it is a huge responsibility on all of us in the Rajasthan State Chapter of Indian Psychiatry Society to do something about it, to assist the government to do something about it. After all, government is what? Government is us. And when it comes to quota deaths, it is you all, because you all are experts. My request and suggestion is that some of you should go into these deaths. Obviously, the people who ended their lives, the boys and girls who ended their lives, they are not there, but their families are there, their friends are there, their colleagues are there, teachers are there. Please look into that and try to find out what were the risk factors, what were the warning signals which were present in these boys and girls, which now can be identified into the remaining population of these children. I would also request that the Rajasthan State Chapter should start a program that each member of your society should adopt a school or a college nearby where teens and youth are there. And then you should conduct a survey as soon as the boys and girls enter the school. And this is what Manju and our clinical psychology head Sunita are planning to do in our university. The day the student joins the university, within a month of the admission, there is a mental health screening done by the experts. And then we classify these children into a green, that means they are mentally healthy. You don't have to worry about them. They can have a follow-up either at the end of the year or at the end of the course, just to make sure that they remain in the green channel. Then you identify the yellow. Yellow are the ones who have minor issues, which can go down. So you keep a tag on them. You keep a tab on them. They keep coming to you. If they don't come to you, you call them. You go to them. And make sure that they come down to green. And then you can also identify the reds. Reds are the potential future. I don't want to say it, but they can do what these 14 boys and girls have done. They are the ones who have to be under your close scrutiny. So my request to all your members is, please adopt any school, any college nearby, and offer this service free to that school, that you will do the screening of these boys and girls, catch them young, catch them at an early stage, keep a tag on them. The second suggestion which I would like to make to the Rajasthan State Chapter is that please start a helpline where these, I know the government helplines are there, but maybe they are not enough, maybe students are not approaching them. But if a local doctor is involved who is known in the city, the students may be better or more comfortable to approach. And it's very easy. For a month, you just need 30 experts. So I am on call only on one day in a month. I think everyone can afford to do that. If the demand is more, you can put 2 people on call. You can say 6-hour shifts and advertise this through all the portals that any child who is having any issues can talk to you. Nowadays, every child has a smartphone. They can even see you. You can even see them. So it becomes a virtual consultation, because still the stigma is there. No boy or girl would like to walk into a psychiatry or a psychology clinic to get the problem solved. But if that opportunity is available, when I am sitting in my room, nobody is watching me, I think more and more boys and girls will utilize this facility. So these 2 suggestions, I would request the office bearers of the Rajasthan State Chapter to keep in mind. As I said, that I'm very happy that both Manju and Sunita, my clinical psychology chief, they have already started working on this, and we are going to institute this. If the Rajasthan State Chapter decides to do this, and I can say that without even asking my chairperson emeritus, whatever help is required, the Mahatma Gandhi University of Medical Sciences and Technology will be able to offer that help in terms of secretarial assistance, in terms of planning, coordination, providing our faculty and staff to do this. I have the approval of our chairperson emeritus for all such activities, so I don't have to take his permission when I make this announcement on his behalf. And I think the university and the Rajasthan State Chapter can join hands and do this service to the society, to these children who are under tremendous mental health issues. Thank you all very much for inviting me to this meeting. Thank you.
Thank you, sir, for your inspiring words and gracious presence. After such insightful and heartening addresses, it is our privilege to express our gratitude through a small token of respect. We now proceed with the felicitation of our distinguished dignitaries with memento as a symbol of our appreciation. May I request Dr. Manju Bhaskar ma'am to kindly present a memento to our chief guest, Dr. M.L. Swankar sir, for gracing us with his visionary presence today. Thank you, sir, for your words of wisdom and unwavering support.
I now request Dr. Manju Bhaskar ma'am to present a memento to our guest of honor, Dr. V.K. Kapoor sir, as token of our gratitude. Thank you, sir, for honoring us. May I now request Dr. Akhilesh Sharma sir to kindly present a memento to Dr. Vinod Sarya sir for his steadfast leadership of the IPS Rajasthan Chapter. Thank you, sir, for being the guiding force behind many psychiatric initiatives in the state.
Now I invite Dr. N.K. Tak sir to felicitate Dr. Parth sir, Vice President of IPS Rajasthan, with a memento. Thank you, sir, for your dedicated administration and energetic presence.
May I request Dr. Manju Bhaskar ma'am to present a memento to Dr. Superintendent sir, General Secretary of IPS Rajasthan and a stalwart academician. Thank you, sir, for your visionary cabinet contributions and inspiring energy.
May I now invite Dr. N.K. Tak sir to present a memento to Dr. Sunil Sharma sir, Treasurer of IPS Rajasthan Chapter, respected mental health leader. Thank you, sir, for your years of dedicated service and support to the community.
I now request Dr. Aditya Soni sir to kindly felicitate Dr. Hardinge Sharma sir with a memento. Thank you, sir, for advancing psychiatric literature and research across the state and nation.
I now invite Dr. Priyam Gupta ma'am to felicitate Dr. Manju Bhaskar ma'am with a memento. Thank you, ma'am, for your constant support.
I now invite Dr. Lalit Batra sir to felicitate Dr. Aditya Soni sir. Thank you, sir, for your outstanding coordination and dedication.
Now I invite our organizing secretary, Dr. Aditya Soni sir, Professor of Psychiatry of Mahatma Gandhi Medical College and Hospital, Jaipur, to deliver the vote of thanks.
Good afternoon, everyone. Honorable dignitaries on the dais, respected seniors, esteemed speakers, dear colleagues, delegates and friends, a very good afternoon to all of you. On behalf of the organizing committee of the second Rajasthan Cyclone, it is both a privilege and a sincere duty to deliver the vote of thanks. First and foremost, I extend my profound reverence and deepest gratitude to our distinguished Chief Guest, Dr. Ajmer sir. His very presence dignifies this occasion, and his words, shaped by a lifetime of heartfelt commitment to health care and education, continue to be a lasting source of inspiration. Sir, a visionary chairman and managing trustee of the Indian Education Trust, has redefined the landscape of medical education across Rajasthan. He is the driving force behind the illustrious Mahatma Gandhi University of Medical Science and Technology in Jaipur, a pioneering institution that stands as the first residential medical university in Rajasthan. Your wise counsel and unwavering commitment are the very bedrock upon which our institution flourishes. A special moment of appreciation to Dr. Batra and to all esteemed office bearers of the Indian Psychiatric Society, Rajasthan chapter. Dr. Parth, Singh, Meena, Dr. Jitendra Jinder, Dr. Sunil Sharma and Dr. Manoj Sharma. Thank you all for your gracious presence, leadership and steadfast support. My heartfelt appreciation to Dr. V.K. Kapoor sir and to Dr. Manju Bhaskar ma'am and our organizing committee, whose composed demeanor and unrelenting support ensured that every aspect came together seamlessly. To all our eminent speakers and chairpersons of the scientific session, thank you for raising the academic bar. Your insights reflect the evolving paradigm of gender-sensitive psychiatry, and they illuminate the path we must walk. I would also like to express heartfelt gratitude to all the psychiatry department of various medical colleges across Rajasthan. A special thanks to all respected head of departments for their moral support and encouragement, which helped us fortify the foundation of this conference. To all senior psychiatrists across the state, your mentorship and blessings, not only a source of guidance, but also a reminder of your legacy we are privileged to inherit. Last but not the least, our students and resident volunteers, technical staff behind the scene, coordinators a humble salute to your tireless efforts and the meticulous execution which brought this event to life. And of course, to all delegates and attendees who traveled the distance and gave us your time, enthusiasm and dedication, thank you for being a part of this shared vision. As we proceed towards an engaging scientific session ahead, I hope this conference proves to be a catalyst for revolution, leading to the conversations that matter and actions that heal. Before we move ahead, I would like to take a moment to acknowledge something beyond the scope of medicine, yet deeply concerned to the peace and stability that allow us to gather here today. In the light of the recent attack in Pahalgam and Operation Sindoor, the sacrifices made by our armed forces, we are reminded of the quiet strength that protects our freedom. It is because of the courage and the dedication of our Indian Army and defense personnel that we are able to meet in safe lands, speak openly, and build a future in peace. I humbly request everyone to please rise for a minute of silence to honor our soldiers, to respect our country, and to express our deepest gratitude to those who protect it, seen and unseen.
Everyone to kindly rise for the national anthem as we conclude this inaugural ceremony with tribute to our great nation.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जगति तरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
forms of anxiety and depression. But in schizophrenia, it is very clear to the patient, especially when he has insight, to the families all the time, and to public in general, that it is the domain of the psychiatrist. So, World Schizophrenia Day has a very special importance for us, and also because of our responsibility towards our patients. Schizophrenia is a devastating illness. We have read about the one-third rule long back. But except for that one-third who are kind of awakeners or who have recovery, rest are chronic patients. They need our care. The minor improvements on a long term that we are able to provide them, help them gain functionality, be a part of the family and society, active. So we look forward to this World Schizophrenia Day panel discussion with our esteemed panelists. So I would like to welcome first on stage Dr. Anil Tambi sir. Sir has been my teacher, ex-professor from SMS Medical College, Jaipur in Psychiatry. He is among the senior-most practicing psychiatrists in Rajasthan, currently working in his own private establishment by the name of Vivekananda Institute of Mental Health and Neurological Sciences. Sir, I welcome you. Please take it. He is a professor, head of department, Jaipur National University in Psychiatry. Again, he is a familiar name, passed out of SMS Medical College, and he is also well known for his very key interest in artificial intelligence and its applications in psychiatry. And recently we have come across many of his publications in the same. He has an interesting degree, which is MSc in bioinformatics, health informatics. So I correct myself, it's health informatics. So technology in psychiatry, he is a trained. Welcome, sir. Now I would like to welcome last but not the least, Professor Jitendra Singh sir. He is the head of department Psychiatry at DTE.GHS Medical College and Hospital, Jaipur. He is a well-known name again among our society, very active member, current organizing General Secretary for IPS Rajasthan, and also the Assistant General Secretary for IPS National Body. So his footprints again bring Rajasthan to the national stage. It's my pleasure to have him. So with our esteemed panel here, we would like to begin with the panel discussion. So the way we have conceptualized this panel discussion, we had a discussion among ourselves also, that there will be a few questions addressed to the panel, and then we would be open to the audience questions. So here we would like to begin. And also, as per our panel's wish, if the audience want any questions in between, they are open to it. So it's not only a panel discussion among 6 people, but it's with the entire audience. So to begin with, I'll ask Anil Tamil regarding refractory schizophrenia. Many times we come across patients who are not responding to treatment. What is his general clinical approach? His clinical wisdom would be very useful.
Thank you, Dr. Raghav. As all you know, refractoriness, non-responderness, and non-response to clozapine, there is a graded approach. So, if you take 100 patients of schizophrenia and introduce first neuroleptic, first antipsychotic, about 50% patient respond. Then you add the second antipsychotic, 10 to 20 patient, 10 to 20% patient will respond. Rest 30% patient, they do not respond to the 2 antipsychotic trial. Current discussion is that what we should do to improve the life of these 30 to 40% patient of schizophrenia. So, as you know, the clozapine is the #1 choice in treatment refractory patients. But again, clozapine help only 20% of these 30% patients. Then comes the number of ECT. Again, it is effective only in 10 to 15% patients. Then rest 10 to 15% patients, they do not respond to the first antipsychotic, second antipsychotic, clozapine and ECT. Then what we should do? So there are several approaches how we should handle these patients. So first approach is that combining the 2 antipsychotics. Combining 2 antipsychotics, one thing. Second is the augmentation by the another molecule that is not antipsychotic medicine. So combining the 2 antipsychotics, we can combine clozapine with the risperidone, with olanzapine, with amisulpride, and if aripiprazole and ziprasidone, we can also combine. So there is an advantage of combining aripiprazole and clozapine. Studies show that amisulpride and clozapine combination is again a better efficacy is found in these studies. So then next comes the augmentation. There are several molecules which are used to augment the clozapine. The #1 is the lamotrigine. Lamotrigine is a drug which helps in this, many of the refractory patients. #2 is the memantine, particularly when we are addressing the negative symptoms of schizophrenia. In that patient, memantine can also work. Another one molecule mirtazapine also help in the treatment of refractory patient. Duloxetine also help. And one many a times after treating schizophrenic patients, there are persistent auditory hallucinations. In subset of patients, RTMS, temporoparietal lobe stimulate करते हैं, उसको dampen down करते हैं, तो then the refractory auditory hallucinations, they respond best to this RTMS treatment. Anybody want to share and ask some question?
So as sir has responded, I would just like to summarize it in a very few lines that combination of antipsychotics is justified when we are treating refractory schizophrenia. There are a lot of studies regarding this, but in terms of a guideline, that combination of antipsychotics is recommended. I am not very sure which are those, but in terms of meta-analysis and reviews, we have seen that combination of a FGA and SGA can be a better option compared to two SGAs. And among SGAs, Mirtazapine, of course, is a drug for refractory schizophrenia, and it can be its effect can be combined with a risperidone or amisulpride, like many trials we have seen, which are not exactly SGA or FGA. They have properties bordering on the zone. Then there is also a combination of medicines based on different syndromes of schizophrenia. Like sir has mentioned about some antidepressants, midazapine, duloxetine, and some other areas. So there we can address the additional syndromes of schizophrenia like cognitive syndromes or depressive syndromes, which may further aid in refractory hallucinations. There has a view that RTMS can be an important aid in that. Thank you, sir.
Some of the studies show that high dose olanzapine can be tried before trying the clozapine.
Okay, sir. So, yeah, Dr.
Yeah. So maybe I'll add one with the kind permission of the panel and all the speakers with other one question you can ponder. Who are the guys who are likely to develop refractoriness or resistance to the schizophrenia treatment which we provide? So how do we know? A patient comes to us, then we usually try one antipsychotic, second antipsychotic, wait and watch. But the biomarker actually helps nowadays. And one of the very proponent biomarker which was there quite before time where we have actually forgotten it is the serum fasting insulin levels. So those individuals which perhaps you are worried about identifying, please do this particular molecule, this insulin free fasting levels analysis. You would be able to differentiate between responders and non-responders. Thank you.
Thank you, sir. Now I request Roop Sirana.
Regarding the use of antipsychotics, and I agree that most of the younger generation psychiatrists, they are using second generation. They have not tried first generation because of the reasons everyone knows. But to label anybody refractory or to put on to clozapine, I think the first generation antipsychotics should not be neglected. They must be tried. And secondly, the question related to refractoriness and trying the augmentation strategy would depend on the syndromal, the symptoms that are refractory. Is it the negative, is it the positive, or whatever symptoms are there? According to that, we will have to choose these strategies. And which patients would go to become refractory? Apart from the biomarkers, the usual early onset, negative symptoms, family history, these are everybody knows. One of the things which has been become obsolete because none of us now do a physical examination. soft neurological signs in early schizophrenia. If the soft neurological signs are present, these are the cases which are likely to become refractory and non-medical.
Thank you, sir. So now I'll move to the next, Dr. D.M. Madhusudhan.
Thank you. Talking about the refractoriness of the schizophrenia, should we not look for comorbidity? Because schizophrenic condition is usually associated with comorbidity. Affective disorders are there, organicities are there, borderline personality disorder is there. So it should be need to review the diagnosis or to add any comorbidity before finishing the medication. Thank you.
Here I would like to add this pseudo-resistance. Sometimes patients are not taking medicines, so we have to check the compliance also. As sir has very well mentioned, there are comorbidities we have to check. So before selecting or before treating, we have to identify the several of the factors. Even we can go for the CT scan also, so that if there is a ventricular to brain ratio is not good, the chances of responding, because the major part of the brain is already atrophied.
Dr. Vikas.
I would like to add that psychiatry is like any other branch of medicine, works on trial and error. Okay, so when we treat any patient, we all know that if apply this rule that 1/3 patient will respond, approximately 1/3 patient will partially respond, and the remaining will obviously be converted into refractory. Beforehand, we cannot say that a particular patient is going to be treatment resistant unless, according to the definition, we have tried at least 2 different class antipsychotics. And then, if the patient does not respond, then we can label it into a treatment refractory. Otherwise, beforehand, we cannot say which patient is going to be, although there are certain prognostic markers. In this particular manner, AI can help in this, but beforehand, I think it's impossible to label any patient as treatment refractory unless we have tried the treatment.
So before we move on to the next question, there have been some trials which are mentioned in the monitoring guideline as well. The earliest when you can see the direction of, because the response as such may take time, but they say that around 1 week there should be some improvement in some criteria. That may not be a part of guideline, but there can be a justification when you have a strong clinical inclusion as well as history and other markers. So now I'll move to the next panelist, Dr. Batra, with our next question. So from the minor subset of schizophrenia, which is refractory patients, which are a huge burden in terms of treatment needs, there is another bottom of the pyramid, which has a large number of patients with the milder disease, prodromes, or schizophrenia and associated personalities and delusional disorders, which are a greater problem for the society, family, and which may not be appearing as treatment requiring. So how you would like to comment on that, sir?
तो हमारा DSM-5 है, उसने एक अच्छी कैटेगरी दी है थर्ड पार्ट में, एटीन्यूएटेड साइकोसिस सिंड्रोम। वो इस चीज़ को, हमारी चीज़ को काफ़ी अच्छा एड्रेस कर रहा है। उसके अंदर हमारे जो रेजिडेंट आउटडोर बैठते हैं, सब जगह बैठते हैं, सबसे बड़ी दिक्कत ये आती है सर, ये हेलुसिनेशन को मतलब जो क्राइटेरिया उसको सेटिस्फाई नहीं कर रहा है, इसका जो सिस्टम है एटीन्यूएटेड को नहीं कर रहा है। तो उसमें जो DSM-5 में 5 क्राइटेरिया दिए, उसमें 3 हटा ले लिए उन्होंने एस्टिमेट से कि आपका अगर हेलुसिनेशन या डिल्यूजन एटीन्यूएटेड फॉर्म में है या आपका डिसऑर्गेनाइज्ड स्पीच जो है वो एटीन्यूएटेड स्टेट में है, तो आप उसको इस कैटेगरी में ले सकते हैं। इसमें आगे चीजें ये है कि जैसे सपोज करिए मैं 2 पेशेंट बता के बात करूँगा आपसे। मेरा एक पेशेंट था जो कोचिंग का शायद बच्चा था और कोचिंग पूरी हो चुकी थी, उसके बाद भी कोटा में रहता था। तो उसका था कि उसकी जो भी कोई फ्रेंड बढ़ती थी लड़कियां, उसमें इंस्टाग्राम पे वो उसका कहता था आईडी पासवर्ड दो मेरे को। तो वो आईडी पासवर्ड लेने के बाद उसकी सारी हिस्ट्री सर्च करता था, पूरा करता था। उसके बाद वो जब तक सारी सर्चिंग करता तब तक वो फ्रेंड से छूट जाती थी उसकी। ऐसा 3-4 बार हुआ। लेटर ऑन वो पेशेंट हमारे पास साइकोसिस में और रादर स्किज़ोफ्रेनिया में ही डायग्नोज हो गया। तो ये मैं वो जो आप प्रोड्रोमल सिम्टम बता रहे हैं या जो एक्यूट सिम्टम बता रहे हैं उसी का एक तरीका था जो आजकल आपको जो मीडिया और इसके थ्रू जो बता सर ने कहा था कि आपके लिए इंडिकेशन हो सकता है, बल्कि एक इन्फॉर्मेशन मिल सकती है इसकी। दूसरा केस था मेरे पास, एक बिजली विभाग में एक सीनियर आदमी ने अपने एम्प्लॉय को रेफर किया कि ये जो अथॉरिटी सब मिसबिहेव है इसका और ये साइकोसिस और तब से उसको लीव देके कहा कि तुम तुम्हारा साइकियाट्री डिपार्टमेंट फिटनेस लेके आई। तो मैंने उसको देखा, मैंने सडनली ये तब DSM-5 आ गया था थोड़ा सा, तो उसमें देखा कि भाई ये जो अथॉरिटी कई जगह बहुत ज्यादा अथॉरिटेटिव होते हैं, तो वहाँ एम्प्लॉय की एडेप्टिव मैकेनिज्म होती है, वो हॉस्टाइल हो जाता है, वो अथॉरिटी का छोटा-छोटा लेकुना पकड़ने लग जाता है, लेटरबाजी करने लग जाता है। अब वो परिस्थिति उसकी जो है उसको हम डिस्ट्रेस समझे या हॉस्टाइल समझे उसको, या उसकी एडेप्टेशन समझे। तो ये हमें एज ए साइकियाट्रिस्ट जब आउटडोर बैठेंगे तो हमें ये चीज देखना है कि सिंपली जो अथॉरिटी ने कोई लेटर दे दिया है, कंप्लेंट कर दिया, किसी ने बता दिया, उसके ऊपर जंप होने के लिए ड्यूल नर्स के लिए बात कर रहा हूँ जनरली, तो उसको एज ए होलिस्टिक देखना पड़ेगा। दूसरा जो है प्रोड्रोमल सिम्टम के अंदर बड़ी मिक्स पिक्चर आती है, कई बार छोटी मैनी पिक्चर भी लगती है। जैसे हमारा कोटा में अगर हड़ौती बात करूँ तो हड़ौती का तो कल्चर है कि वहाँ हमारे वार्ड में अगर आप आएंगे तो वहाँ 70% पेशेंट आपको मीनिया के मिलेंगे। तो वहाँ की कल्चर है कि वहाँ थोड़ा मैनी प्रेजेंटेशन रहते हैं लोग, हाइपोमेनिक तो जनरली रहते हैं। तो ये वहाँ पे हमने बहुत बार देखा कि जिस पेशेंट को हमने शुरू में मेनिया डायग्नोसिस किया वो लास्ट में स्किज़ोफ्रेनिया टर्न आउट हुआ, इवन हाइपोमेनिया डायग्नोसिस किया वो भी टर्न आउट साइकोसिस में हुआ स्किज़ोफ्रेनिया। तो एक जो जहाँ ये चलते हैं अपने ये क्या बोलते हैं फेक लीडर्स का काम चल रहा है। मैं जब सेक्रेटरी पहली बार आना था तो अजमेर के अंदर हमने ये इशू उठाया था और उसके बाद हमने मीडिया को इन्वॉल्व किया था कि आप कंटिन्यूसली मीडिया में इसके बारे में दीजिए कि फेक लीडर्स के पास न जाएं, साइकियाट्रिस्ट के पास जाएं। तो ये मैं हालांकि साइकियाट्रिस्ट है पर आपको अनऑफिशियली बोल रहा हूँ, ये चीज उनकी बताई थी। उन्होंने 5-10 दिन उसको खूब छापा दिल्ली का और अजमेर की कॉन्फ्रेंस के इतिहास से छापा, उन्होंने सडनली बंद कर दिया उसको छापना। मैंने कहा भाई क्या हुआ तुम्हारा इशू? बोले साहब वो उन लोगों का इतना होल्ड है उस कम्युनिटी में कि हमारे अखबार वहाँ बंद हो गए बिकने। तो हमारे कमर्शियल सेल ने हमें फोन किया कि फालतू काम तुम्हें नहीं करने, जिनको करने होने करो, तो पब्लिक के इंटरेस्ट की सब। तो मैं ये कहना चाहता हूँ कि वो जो प्रोड्रोमल सिम्टम वाले पेशेंट हैं वो ज्यादा हमारे के पास जाते हैं। और वहाँ पे जो मैं एक चीज बोलता हूँ कि वहाँ पे एक पेशेंट तो ऑलरेडी उसको ये वहम है कि मेरे साथ वाले मेरे ठीक नहीं है मेरे लिए, उसको वो एक नया वहम और डाल के देता है कि तेरे को ऊपर की हवा का है, तो वो एक नया सिम्टम और जनरेट कर देता है उसके अंदर। तो कहने का मतलब सोसाइटी के अंदर ये जो क्लास है, ये कुछ स्टडीज ने यहाँ तक कहा है कि भाई 7% पॉपुलेशन है, जबकि हमारी स्किज़ोफ्रेनिया की अराउंड 1% है। तो ये पॉपुलेशन हमारी बड़ा पोटेंशियल पॉपुलेशन है जिसको हम इसको मेनस्ट्रीम लाइन से जोड़ें और इनके सिम्टम्स को अर्ली आइडेंटिफाई करें। बोर्ड मैंने जैसे आपको बताया कि सोशल मीडिया वाला ऐसी कोई भी छोटी छोटी इन्फॉर्मेशन देगा उससे आप उसका निकाल सकते हो चीज़ों के कि ये प्रोड्रोमल सिम्टम्स में चल रहा है नहीं चल रहा है। तो कुल मिला के बात ये है कि हमें जो सिम्टम है उसमें डायग्नोसिस करते टाइम ये ध्यान रखना चाहिए कि अगर साइकोसिस के थोड़े बहुत सिम्टम है तो उसको अगली बार रिव्यू या असेस करने का ऑप्शन रखना चाहिए, क्योंकि एक ओपीडी में जनरली अगर लेबल लग जाता है परमानेंट तो दूसरी जगह वो ओपीडी में जहाँ हैवी ओपीडी होते हैं, पर्टिकुलरली गवर्नमेंट ओपीडीज में, वहाँ उस पेशेंट का डायग्नोसिस रिव्यू नहीं होता है।
So, sir has raised a very important point that there is a difficulty in connecting the technical terminology for such patients. How would you diagnose them or what information you can give them for correct communication to future treatment providers? And the discrepancy with the intuitive feeling or knowledge that this person has some psychotic. Many times patients come to OPD, their family members, their relatives know there is some problem, but we do not find how to put in there. And he also raised the question about diagnostic stability, that whom you diagnose may turn out to be in due course of time as a schizophrenic process. So it's very important, very pertinent issue. Now move to the next panelist, Dr.
There are two specific situations. One is the schizotypal disorders and another one quasi-psychotic episodes of the borderline personality disorder. They are also at times present as a psychotic illness, but they are very short-lived illnesses. So I have seen many of our residents in the past, many of the our colleagues also miss this diagnosis of borderline personality disorder. It's a very common disorder. Borderline means neither it is psychotic nor it is neurotic. It is in between. Sometimes patient एब्सोल्युटली नॉर्मल बिहेव करता है, समटाइम्स क्वाजी साइकोटिक एपिसोड होता है।
Right, sir. So my next question is for Dr. Tushar Jadhav, as he is working in a general hospital psychiatric unit. So I would ask him that how schizophrenia and other medical comorbidities present together, and just for an idea that how many reference are generated from other medical specialties regarding a person with psychosis.
Thank you, Dr. सबसे पहले तो डॉक्टर मंजू को बहुत बहुत धन्यवाद कि हमने बहुत ही इम्पोर्टेंट कॉन्फ्रेंस में बुलाया और एक अच्छे तरह इस प्रश्न के लिए इन्वाइट किया। जहाँ तक सवाल स्किज़ोफ्रेनिया का है और जनरल हॉस्पिटल का है, मैं ये कहना चाहूँगा कि स्टिग्मा बहुत ज़्यादा है। जो मैंने 30 साल पहले अपनी ड्यूटी ज्वाइन की थी, उस समय जो स्टिग्मा था और आज जो स्टिग्मा है, उसमें मुझे लगता नहीं कि कोई बहुत ज़्यादा विशेष सिग्निफिकेंट फर्क आया है। अभी भी 90% के आसपास जो डिफरेंट स्टेटीज हैं कि लोग फर्स्ट साइकेट्रिक कंसल्टेशन नहीं करते हैं। अभी भी वो या तो फेथ हीलर्स के पास जाते हैं, वेक्स के पास जाते हैं, वास्तु वालों के पास जाते हैं, एस्ट्रोलॉजी है, बहुत सारे एम्पामिस्ट हैं और बहुत रिलीजियस स्पिरिचुअल एक्टिविटीज़ हैं, ग्रुप्स हैं। फिर जाते हैं तो फिजिशियन के पास जा सकते हैं, दे गो टू द न्यूरोलॉजिस्ट और न्यूरो सर्जन्स आल्सो, और फिजिशियंस मान लीजिए चेस्ट पेन है, इस तरह के सिम्टम्स हैं तो दे गो टू फिजिशियन और कार्डियोलॉजिस्ट। लेकिन वो अभी भी साइकेट्रिस्ट के पास नहीं आते। सिर्फ जो आते हैं वो या तो मुझे लगता है कि मेनिया के पेशेंट हैं जो बहुत ओपनली डिस्टर्ब होते हैं, वायलेंट होते हैं, या कुछ स्किज़ोफ्रेनिया साइकोसिस के आते हैं या कुछ ओसीडी वगैरह के आते हैं। बाकी बहुत मुश्किल से अभी भी फर्स्ट कंसल्टेशन साइकेट्रिस्ट के पास आना है। तो स्टिग्मा बहुत है, फीलिंग बहुत ज़्यादा है समाज में, और इतनी अवेयरनेस के बाद सारे साइकेट्रिस्ट काम कर रहे हैं, सारे डेज बना रहे हैं हम लोग, और सबने अपने ओपीडी में हिंदी में बहुत सारे बैनर पोस्टर लगा रखे हैं, कैंप करते हैं। लेकिन अभी भी मुझे लगता है कि बहुत ज़्यादा मेजर चेंज नहीं आया लास्ट 30, 40 या 50 ईयर्स में। तो ये बहुत बड़ा चैलेंज है हमारे लिए, स्पेशली साइकेट्रिस्ट के लिए। तो जो पढ़ाई है क्लिनिकल और रिसर्च के अलावा, इसके अलावा हमारा इम्पोर्टेंट काम है कि अवेयरनेस बढ़ानी है। ये इम्पोर्टेंट चैलेंज है फॉर द ऑल मेंटल हेल्थ प्रोफेशन। अभी मैंने अखबार में रिसेंटली पढ़ा था कि आसाम के अंदर एक लेडी थी, ओल्ड लेडी, जिसको कि हेलुसिनेशन जैसी सिचुएशन थी, इसकी जो मैंने जैसे सिम्टम्स थे, उसको डायन समझकर 23 लोगों ने टॉर्चर किया और उसका फिर डेथ हो गई थी। तो अभी 23 लोगों को लाइफ सेंटेंस, उम्र कैद की सजा दी है हाई कोर्ट आसाम में। रिसेंटली एक लेडी को उनको लगता था कि डायन है। तो अभी भी ये चीज़ अभी कितनी चल रही है, आप सोचिए पूरी कम्युनिटी, पूरी सोसाइटी, चाहे रूरल लेवल चाहे इवन अर्बन भी लोग नहीं आते हैं। जो लोग लेके भी आते हैं स्किज़ोफ्रेनिया के पेशेंट को या साइकोसिस के पेशेंट को, जो हमारे मेडिकल फैकल्टी के कलीग्स हैं, फ्रेंड्स हैं, नेबर्स हैं, वो भी छुप छुपा के आते हैं, लेट आते हैं और धीरे से पूछते हैं सर इसको कोई बड़ी बीमारी तो नहीं है, इसकी स्किज़ोफ्रेनिया तो नहीं है, ये ठीक होगी कि नहीं होगी, या इसको दवाई जिंदगी भर तो नहीं चलेगी। जो अभी भी बहुत सारे लोगों में ये मिसकंसेप्शन है कि स्किज़ोफ्रेनिया या ऐसा कोई बीमारी का लेवल हो गया तो कोई बीमारी कभी ठीक नहीं होगी। सबसे बड़ी बीमारी है साइकियाट्री की, सबसे भयंकर, सबसे जटिल, सबसे गंभीर और लंबी क्रोनिक बीमारी है, और जिंदगी भर दवाइयाँ इसकी चलेगी और आदत पड़ जाएगी। ये अजीब सा नोशन है मेरी सोसाइटी में, सर इसको आदत तो नहीं पड़ेगी, इसको और कोई तरीके से ठीक तो नहीं हो जाएगी। एक बार कोशिश कर लीजिए काउंसलिंग से ठीक हो जाए। तो ये काउंसलिंग वाला भी लोगों में अभी भी एक बहुत ज़्यादा स्थिति है। दूसरी चीज़ रिसेंटली मैंने एक पढ़ी थी अखबार में कि अभी बहुत सारे साइकोलॉजिस्ट हैं, स्पेशली BA और MA, दे आर नॉट मेंटल हेल्थ प्रोफेशनल, दे आर नॉट MPhil और PhD इन साइकोलॉजी, दे आर जस्ट BA MA। वो काउंसलिंग का 6 महीने 3 महीने का कोई कोर्स कर लेते हैं, और उन्होंने मशरूम की तरह जयपुर में कम से कम 50 ऐसी साइकोलॉजी क्लिनिक्स हैं लोग में, क्योंकि दवाई के लिए स्टिग्मा है, साइकेट्रिस्ट के लिए स्टिग्मा है, तो दे गो टू, मतलब उनकी प्रैक्टिस, उनके पेशेंट अभी भी हमसे ज़्यादा है, और दे आर जस्ट BA और MA ना, दे आर नॉट ट्रेन्ड इन मेंटल हेल्थ फैकल्टी, कोई ट्रेनिंग नहीं है। और अभी एक अखबार में रिसेंटली किसी साइकोलॉजिस्ट ने निकलवाया था कि मैंने 2 साल के अंदर 18,000 पेशेंट ठीक किए बिना दवाइयों के। तो इस तरह की जो क्लेम्स अखबार में पेपर आ जाते हैं, उसको देख के पब्लिक में अवेयर होती है कि ये जब कोई आदमी बिना दवाइयों के 18,000 या इस तरह के पेशेंट ठीक कर सकता है, तो लोग उसके पास जाएंगे, और हमारे पास आने में फिर भी झिझकेंगे कि ये तो दवाई देते हैं, मिस्त्री लगाते हैं या इंजेक्शन लगाते हैं या भर्ती करते हैं। तो ये चीज़ें हैं जो कि स्टिग्मा को और बढ़ाती है। तो ऐसे लोगों के लिए हम लोगों को भी और अवेयरनेस बढ़ानी है पब्लिक में कि ये केमिकल प्रॉब्लम है, ये बीपी और शुगर की तरफ एक बीमारी है, जैसे ब्लड प्रेशर की लंबी बीमारी चलती है, शुगर की बीमारी लंबी चलती है, थायराइड की बीमारी लंबी चलती है, अस्थमा की लंबी चलती है। तो अगर सिजोफ्रेनिया, साइकोसिस, ओसीडी या कोई बीमारी है, डिप्रेशन, बाइपोलर, तो लंबा 2 साल, 5 साल, 10 साल चल भी सकती है, लेकिन सुपरविजन में चलनी है। मेडिकल प्रॉब्लम है, उसको ठीक हो सकती है, और केमिकल कंपोनेंट है, इसलिए दवाइयों की जरूरत है। जहाँ साइकोसोशल कंपोनेंट है वहाँ तो काउंसलिंग से, थेरेपी से काम चल सकता है, लेकिन जहाँ केमिकल कंपोनेंट है, हार्मोनल कंपोनेंट है, वहाँ पे दवाइयों की जरूरत होती है। और रिसर्च के बाद दवाइयाँ बनी हैं, जैसे कि बीपी, शुगर की या बुखार की दवाइयाँ बनी है, कोरोना की दवाइयाँ बनी है। दूसरा जो जनरल हॉस्पिटल साइकियाट्री की बात है, अभी भी रेफरेंस आते हैं, लेकिन हमारे हॉस्पिटल में भी साइकोसिस बहुत कम आता है। तो जनरल हॉस्पिटल है, लोग समझते नहीं, अगर ज़्यादा रजिस्टर है तो दे गो टू द साइकियाट्रिक सेंटर, या जहाँ पे प्राइवेट नर्सिंग होम्स है ना, अभी भी न्यूरोटिक पेशेंट आते हैं। 90% जो लोग हैं वो न्यूरोटिक हैं, और जो रेफरेंस भी होते हैं वो एंजाइटी, डिप्रेशन, इंसोम्निया के होते हैं मैक्सिमम। तो जनरल हॉस्पिटल में अभी भी साइकोसिस देखने को कम मिलता है।
थैंक यू सर। तो what Dr. Tushar wanted to imply was reference related to psychosis are very few, maybe due to lack of awareness or maybe less serious treatment need, which is more easily managed in a mental setting. And secondly, yes, there is a lot of stigma in identifying and making these patients treatment ready. So, sir, I just put in my comments that what I have seen in my practice is that there is always one person who can bring that. घर वाले अक्सर ये बोलते हैं कि इसको वो उसके कहने से आ जाएगा, बाकी तो किसी की बीमारी हुआ और उसके कहने से आ जाएगा. So in that psychotic world, there is some person who will be sharing that, or if not sharing that, they somehow have that confidence in that point of time. और बाद में जब वो आदमी ट्रीटमेंट के लिए ले आता है तो समझ जाएगा निकलता है कि he also falls out of that psychotic world. So next time there is nobody to bring in. So this is a very catch-22 situation, but very important, and these patients are a big stress to the family, because these patients are quite balanced many a times, especially when they are in the exacerbated phase, that they don't have a problem. And the family members are like in a big problem. If they agree with him, if they don't agree with him, how to carry out daily life, we have these questions which are very difficult ones. So now I'll move to our next panelist, Dr. Vidya. Sir,
more observation. In my opinion, the problem of stigma is more in the city population. It is less in the rural population. Because there are live examples in most of the villages कि इस फलाना लड़के को ये ऐसी हरकतें कर रहा था, ऐसी बातें कर रहा था, इसको वहाँ लेके गए और वहाँ जाकर के ठीक हो गए. तो अपने सभी कोलीग्स ने फाइंड आउट इतना ग्राउंड वर्क किया हुआ है कि हर जगह आप लाइव एग्जाम्पल्स हैं कि ऐसा करता है तो इसको वहाँ लेके जाओ और वहाँ जाकर के इसका इलाज हो जाता है. गांव वाले सारे 4 आदमी जीप के अंदर और लेके आ जाते हैं. शहर वाले जो है कि साहब कोई दवाई लिख दो तो मिला के दे दें, कैसे लेके आएंगे, फ्लैट के अंदर बड़ी बदनामी हो जाएगी. तो आई डोंट नो व्हाट इज द एक्सपीरियंस ऑफ द अदर पैनलिस्ट एंड अदर कोलीग्स कि गाँव में ज़्यादा है स्टिग्मा या शहरों में ज़्यादा.
So what you meant was that in a collectivistic society versus an individualistic society. In a collectivistic society, the locus of control is amongst others. Every person is more ready to listen to what the other person. In an individualistic society like urban centers or in developed countries, they have it. They feel that local control is inside. So in a psychotic situation, I think a collectivistic society can better handle such a person. And even if the forceful treatment occurs later on when these patients come and follow, it seems like the things have patched. There is no lasting bitterness amongst the family members for bringing that patient for treatment. There might be some, but not very apparent. But in urban centers, treatment for schizophrenia is definitely bigger. Right. So we move to our next panelist, Dr. Vikas Gaur. So sir has a keen interest in the interface of mental health overall with technology, intelligence. So in this paradigm, what would you like to comment or explain about schizophrenia?
As we all know, artificial intelligence is just like in many other areas, is rapidly transforming the field of mental health care. And particularly relevant to schizophrenia, it can offer us 3 P's. Number 1, that is precision. Second, personalization, and third, predictive abilities. So just now we were discussing about attenuated psychosis or subsyndromal symptoms or prodromal psychosis, or even we all know that there is a golden window period or duration of untreated psychosis PUP. It is said that within 6 months, once the patient starts developing symptoms, if we start treating that patient during this particular period, the patient is going to have good prognosis. So AI can right from early diagnosis and risk prediction to management play a very important role in schizophrenia. For example, using natural language processing techniques and computer vision. Just imagine if we are just analyzing what the patient is speaking, that is the speech pattern of the patient, what the patient is writing, that is the text, facial expression of the patient, behavior of the patient, and what the patient is writing in social media. We can develop certain AI genetic models which are already there. They can analyze and predict whether this is a high-risk individual for developing schizophrenia. So this is early risk prediction. Then continuous monitoring. If suppose we have a patient of schizophrenia and we started, there are certain available sensors available, there are certain mobile apps, and with the help of these apps, we can continuously follow the sleep pattern of the patient, particularly, and how he is behaving, what he is doing, and these data can help us in predicting whether there is a risk for relapse. There are certain AI models which can help in developing medicines within a span of 2 or 4 days. Usually it takes about several years to develop a particular medication. But in the field now, we can develop antipsychotic medications with the help of AI within 3 to 4 days. AI can help in research. AI is helping in developing new biomarkers which can help in predicting whether the patient is vulnerable to develop schizophrenia or not. AI can help us in predicting which particular antipsychotic will be useful for which particular medicine, that is the precision psychiatry. Now, in terms of management therapy, we have virtual chatbots. Many of our patients are already using ChatGPT for counseling and psychotherapy sessions. Then we have avatar therapy, which use augmented reality and artificial intelligence for schizophrenic patients, for psychosocial rehabilitation. So, in a sense, right from early diagnosis to management, AI can just help us in tremendous way. Lastly, I want to add that, but this will be in collaboration with the psychiatrist. AI alone is currently not in that phase that it can help us in treating these patients. Our role of psychiatrist will always be there.
Thank you so much. So, somewhat what I understand is that big data concept, that collecting data from various sources and not just a clinical interview or a diagnostic schedule, but from various sources. All the things which have been mentioned by the panel as well, the audience of neurological science, and in your terms, even the expression of that person in speech, on social media, all the things that they could be synthesized together to generate a decision about the treatment that would be more precise, more individual.
Well, obviously, for example, suppose using neuroimaging techniques and behavioral patterns and speech analysis, we have developed an algorithm now which can predict the brain age of the patient. I'm not sure you have heard about this concept. What is brain age? It has been found that schizophrenic brain is approximately 3 to 4 years older than the chronological age of the patient. So now we have such algorithms with the help of which we can easily predict, okay, this is differentiated, this is a schizophrenic brain and this is a normal brain. But obviously we are using multi-model, different types of textual data, whether it is text data or voice or neuroimaging data. We have to combine all of that for giving predictions.
So in a simple clinical practice, if we save the number of the patient and we'll get accessible to his WhatsApp BP. So any change in BP, very simple, we can reflect, it will be an indication. We can try on that patients. So our next question is for Dr. Jitendra. Sir, I would like to ask you regarding the perspective of care. caregivers in a schizophrenic illness have huge burden and benefit across studies as well as the intuitive common observation. So can you just, in your experience, describe the burden of the caregivers and how to reduce it?
As we all know that caregiver burden of psychiatric patients are very huge. Like किसी को अगर hypertension है, diabetes है, तो उसमें फैमिली मेंबर्स का कुछ ज़्यादा इम्पोर्टेंट रोल नहीं है, वो खुद ही पेशेंट दवाई दे। लेकिन अगर किसी को साइकोसिस है तो इट्स वेरी डिफिकल्ट तो पहले तो एजुकेट करना, तो डॉक्टर के पास लेके जाना, उसका ट्रीटमेंट कंटिन्यू करना, एंड मोस्ट इम्पोर्टेंटली कि साइको एजुकेशन ऑफ फैमिली मेंबर्स इज ऑल्सो वेरी इम्पोर्टेंट। जैसे एक्सप्रेस्ड इमोशन की बात करें, ओवर इन्वॉल्वमेंट, क्रिटिसिज्म, हॉस्टिलिटी ऑफ फैमिली मेंबर्स, इट इंक्रीज द रिलैप्स रेट। तो इवन रिमिशन आने के बाद में भी पेशेंट को रिलैप्स रोकने के लिए भी वी हैव टू टेक केयर ऑफ ऑल दी एस्पेक्ट्स ऑफ देयर ओन बिहेवियर कि हमारे पेशेंट को बार बार रिलैप्सेस नहीं है। सो burden, yes, there is, and we have to take care of that. Or apart from pharmacotherapy of psychiatric patients, we have to psychoeducate the family members. It's very important. And again, for the longer treatment is also very important.
One more question would be that sometimes genetic predisposition is there in the caregivers also. Many times there are more than one psychiatric patient in the family. So I have heard this dictum, common sense, that if there is one psychiatric patient in the family, he generally improves. But if there is more than one, then it's a like a decline of a group. So what is your view? Have you seen any anecdotal evidence of this? Any example?
एक पेशेंट हमारे पास है, लास्ट 15 ईयर से वी आर ट्रीटिंग हिम, परसिस्टेंट डिल्यूजनल डिसऑर्डर का पेशेंट। तो रिस्पेरिडोन 8 मिलीग्राम, क्लोजापिन 250 मिलीग्राम पे स्टेबल है पेशेंट लास्ट 15 ईयर से, एंड ही इज लाइक टॉप मोस्ट ऑफ एडमिनिस्ट्रेटिव एसटीएम की पोस्ट पे। आई एम नॉट डिस्क्लोजिंग दिस आइडेंटिटी। तो जब वो शुरू में हमको दिखाने के लिए आता था, उसके बच्चे, एक तो 8 साल का बच्चा था उसकी, और बेटी जो थी 6 साल की, वो अब 23 साल का हो गया लड़का। तो लड़के में इनिशियल डेज में पोर्टेबल की बात कर रहे थे ना, तो एज उसकी मदर, बच्चे की मदर पेशेंट की वाइफ ने बताया कि ये बच्चा 15 साल का, कि आजकल ये हमारा बच्चा जो पढ़ाई में ध्यान नहीं देता, कटा सा रहता है, बात नहीं करता, मतलब उसके स्कूल ग्रेड जो वो डिक्लाइन होते रहे हैं। तो उस समय से ही, मतलब एट द एज ऑफ 8 ईयर्स 9 ईयर्स ऑफ दैट बॉय, हमको ये प्रेडिक्ट हो गया था मैंने आने वाले टाइम में इसको साइकोसिस हो सकता है। तो अभी 23 ईयर ऑफ एज उस बच्चे को, उसने इंजीनियरिंग पूरी कर ली है, बट उसको भी परसिस्टेंट डिल्यूजनल डिसऑर्डर हो गया। और उसकी छोटी बहन जो उससे 2 साल छोटी थी, नाउ पहली बार उसके लिए कंसल्टेशन भी इस बार हो गया। तो मतलब 4 फैमिली मेंबर है उसकी, मतलब मेन लेडी को छोड़ करके फादर, बॉय और उसका जो डॉटर है, उन तीनों को जो है साइकोसिस हो गया।
So as we approach towards the end of our session, we have like 20 more minutes. Dr.
My question is that we talk about schizophrenia, where in spite of advancements in therapy, there are still residual symptoms, there are still inability to carry on work, there is a caregiver burden. But as a service part, what we have been lacking is the daycare centers for schizophrenia patients. None of the institutions in Rajasthan, I suppose, have a good daycare center. Many of the patients whom we have been treating are lying in de-addiction centers because the family cannot take it. And even there are patients who are not being looked after by the family. the chronic patients are not being taken up even in the institution like SMS. But the chronic patients are still running around, not getting proper. So daycare centers and chronic care for patients who are not being responded is probably lacking, and as a society we must do something.
Right, sir. In fact, you have yourself answered this question, but anyone from the panel, if you would like to comment, like what would be a daycare center setting?
So you have rightly pointed out the problem, but whenever such patient come to OPD, then we ask कि target problems क्या है, क्या तो ठीक हो गया और क्या क्या अभी कमी महसूस कर रहे हैं. तो यूजुअली पेशेंट है उसमें कुछ बिहेवियरल इश्यूज होते हैं कि ज़्यादातर टाइम तो ठीक रहता है, कभी कभी परेशान करता है. मेजर जो इशू आते हैं दैट इज द कॉग्निटिव इम्पेयरमेंट. वी कैन retrain them by cognitive remediation. Usually जैसे कि mixing the different color pulses, we are asked them to show. जो उठते खेलने वाला जो होता है, so eye and eye coordination. There are many simple exercises. ताश का जो गेम होता है, ताश के गेम के अंदर हम कहते हैं कि रेड कलर को छांटो, इसके अंदर से ईंट के पत्ते को छांटो. तो वो इस तरीके से जो सीवियरली कॉग्निटिवली इम्पेयर्ड पेशेंट्स हैं उनमें इम्प्रूवमेंट यूजुअली आता है. दूसरा क्या है कि जो यहाँ की जो सोसाइटी है उनकी टॉलरेंस पावर ज़्यादा है, तो वो उनके एब्नॉर्मल बिहेवियर को बेटर तरीके से टॉलरेट कर लेते हैं. तो गाँव के अंदर जो फैमिली मेम्बर्स हैं उन फैमिली मेम्बर्स को ही हम एज ए थेरेपिस्ट ट्रेन करते हैं कि भाई इसको ये चीज़ें करो. थोड़ा सा ये करके कर सकते हैं. ऑफकोर्स जैसे मेजर सिटीज हैं, मेजर सिटीज में क्या है कि दूर से आना, हमने इसका एफर्ट किया था कि गुड डे केयर सेंटर स्टार्ट करें, है ना, बट हमारे पास 3-4 से ज़्यादा पेशेंट नहीं है. वी हैव इनफ प्लेस, वी हैव गुड क्लिनिकल साइकोलॉजिस्ट. हमने एक को आज से 7-8 साल पहले स्टाफ भेजा था वहाँ से भी ट्रेन करवा के लाया था, बट वो वी वर फेल्ड इन दैट एक्सपीरियंस.
Right, sir. So now I'll put a question to the panel, which is for all of them to answer. Sir, in delusional disorders or delusions related to schizophrenia or depression and bipolarity, a major challenge arises when the delusions are in the cultural domain, like wife doubt, having doubts over her husband, or with the mother-in-law, keeping a doubt that she is planning something against her. Here, a common problem which arises is that the patient feels that we as a thinking team become party to the power equation or the power balance of that group. If we somewhere declare that the wife or the husband is paranoid, then they would say that I have evidence that they are planning against me. It is very difficult to refute if that evidence is of circumstantial nature. If the evidence is clear cut, it's very simple. If the delusions are very bizarre, it's very simple to label them. So I would start with Dr. Kami. If, for example, we get into this that a lady is saying that the mother-in-law is against her, she puts things here and there in the kitchen or around the house to disturb her mental balance. How can we label it as a delusion, and how will we ever get that evidence that it is not done with a plan?
सर ये बड़ी कॉमन प्रॉब्लम है. तो हम जब वो ऐसे डिल्यूजनल पेशेंट को देखते हैं तो हम पूछते हैं कि घर में कौन कौन लोग तो आपके पक्ष में हैं और कौन कौन लोग आपके विपक्ष में हैं. आपके पीहर वाले में से कौन तो आपका पक्ष लेता है और कौन आपके कंवर साहब का या सनीलों का या उनका पक्ष लेता है. तो इस सिंपल क्वेश्चन से अपने को ये पता चल जाता है कि भाई वो कहते हैं कि सारे के सारे घर वाले ही है ना मेरे खिलाफ हो रखे हैं। कोर्स पॉसिबिलिटी है कि सारे घर वाले भी खिलाफ हों। फिर हम पूछते हैं कि पीहर वालों का क्या हाल है, पीहर वाले कौन कौन लोग हैं, तो साहब पीहर वाले भी इन्हीं का पक्ष लेते हैं, हमारा तो पक्ष नहीं लेते हैं। ये उसकी लाइफ कितनी प्रभावित हो रही है, इससे फिर हम डिसाइड करते हैं कि वो कितना फोर्सफुली उस डिसीजन के रिएक्ट कर रही है और उसका असर।
It's a quick question for parents, so I have to interrupt you. What meant was that if the majority is against that person, it is safer to label it as a delusion, and if the dysfunction is more. But again, this is questionable.
It's a questionable, but how we can...
Now, I would like to move to Dr. Lalit. Sir, what would be your comment in this?
जो मैंने एग्जाम्पल दिया था बिजली विभाग वाला, उसमें मैंने ये लिख के दिया था कि जो इस पेशेंट का सोशल एटीट्यूड है वो दो, इट इज ए नेगेटिव एडेप्टिव मैकेनिज्म, बट ये इसका एडेप्टिव मैकेनिज्म है जो हमारे पास अवेलेबल इंफॉर्मेशन प्राप्त हुई है उससे। सो ये साइकोसिस स्टैब्लिश करने के लिए जो आपने डाटा दिया है, हिस्ट्री दी है, जो आपने इसकी जॉब हिस्ट्री दी है, वो सफिशिएंट नहीं है। तो इस तरह के मेरा ये मानना है कि मैं लीगल से डील करता हूँ, मेडिकल में छोटा काफी दिनों से, स्किज़ोफ्रेनिया या साइकोसिस डायग्नोसिस करने में डिफेंसिव रहना चाहिए अगर लीगल कॉम्प्लिकेशन से बचना है। पेशेंट को ठीक करना है तो पेशेंट को ठीक करने के लिए आप टाइम बाय करिए, उसकी जब तक इंफॉर्मेशन पूरी आपको नहीं मिलती है तब तक आप जंप मत करिए, जब तक कि वो डेंजरस टू सेल्फ या डेंजरस सोसाइटी नहीं है। एक मैं छोटा सा किस्सा बताऊँ मैं आपको, स्किज़ोफ्रेनिया पेशेंट की तो बात करते थे, पेशेंट के साथ रहने वाले कैसे सफर करते हैं वो बताता हूँ आपको। रेजिडेंट सफर के रेजिडेंट ध्यान से सुने प्लीज। एक रेजिडेंट पीजी करके चला गया था, फीमेल लड़की थी, उसका हस्बैंड बाद में पता लगा उसको, पर एक आरटीआई है हमारे पास सिंपली, उसने कहा कि फला डेट को इसकी अटेंडेंस की सर्टिफाइड कॉपी दीजिए एंड आई एम हिज हस्बैंड, सो मेरा राइट है कि मैं जानकारी ले सकता हूँ, इतनी जानकारी नहीं आती। हमने उसको एज ए थर्ड पार्टी लिया कि भाई थर्ड पार्टी में इंफॉर्मेशन लेनी होती है, भाई पूछना होता है कि भाई आप अपनी इंफॉर्मेशन देना चाहते हैं क्या, जिसके लिए होती है, जैसे वो लड़की थी उससे पूछा थर्ड पार्टी में 10 डेज का टाइम मिलता है उसके अंदर। मीनवाइल मैंने डिपार्टमेंट से अप्रोच किया क्योंकि हमारी कॉलेज का मामला था, मैंने कहा पहले आप अपना रजिस्टर चेक करो, दिन का अटेंडेंस मार्क है नहीं, उन्होंने कंप्लीशन दे दिया और रजिस्टर खाली था उस दिन का। तो मैंने कहा पहले तो उस लड़की को बुलाओ, उसको पूछो कि कहीं वो उस दौरान कहीं घूमने तो नहीं गई थी या कोई कॉन्फ्रेंस नहीं की थी बिना बताई, और पता लगा बाद में अगर तो आप भी मुसीबत में आ जाओगे। तो बाद में पता लगा कि वो तो हमने क्या मैनेज किया, कैसे क्या वो नहीं बात लीजिए यहाँ पे, लेकिन वो पेशेंट स्किज़ोफ्रेनिक निकला जो उसका हस्बैंड था, और दोनों के अंदर डिवोर्स का केस फाइल हो चुका था। तो ये पेशेंट पैरानॉइड वाले कितना परेशान कर सकते हैं साथ वालों को भी, ये तो मेरा मानना है कि उसमें डायग्नोसिस में जब तक कोई अगेंस्ट बात की डेंजरस टू सेल्फ या डेंजरस सोसाइटी नहीं हो, थोड़ा डिफेंसिव रहना चाहिए।
Over the years, the delusions of infidelity, जब हमारे पास पहले पेशेंट्स आते थे और हस्बैंड या वाइफ कंप्लेंट करते थे कि वो उसका कहीं अफेयर कर रहा है, तो we used to consider that is true delusion. It's a delusion unless proved otherwise. But nowadays, it is reverse. We have to be very, very careful because most of the time, it is not a delusion. Is a real story.
Sir, when I was doing my residency, so I had एक किस्सा सुना मुझे कि यार I was treating a patient for 15 years. हस्बैंड अपनी वाइफ को लेके आता था डिल्यूजन ऑफ इनफर्टिलिटी, और 15 साल तक वाइफ ने एंटीसाइकोटिक खाई है। 15 साल बाद एक दिन हस्बैंड ने एडमिट कर दिया कि सर अफेयर चल रहा है। तो सर इट इज़ रियली वेरी डिफिकल्ट टू डिफरेंशिएट एंड पिनपॉइंट। और जो बात है डिल्यूजनल वर्ड या एनकैप्सुलेशन की, इन शुरू में एक होता है ये मेरे अगेंस्ट है, जैसे जैसे पेशेंट की साइकोसिस बढ़ती जाती है, ये भी मेरे अगेंस्ट है, वो भी मेरे अगेंस्ट है, और फिर उसके बाद एनकैप्सुलेशन होता जाता है, सब लोग उसके अगेंस्ट होते जाते हैं। तो हम किस स्टेज पे उससे ये पूछ रहे हैं कि उस पर भी डिपेंड करेगा कि हाँ ये रियली में डिल्यूजन है नहीं है क्या है।
इवन ऐसा भी देखा गया है कि ऑलमोस्ट 80% ऑफ द पेशेंट व्हेन कम्स टू यू दे विजिटेड their mother first then come to you. So लेकिन उनमें यूजुअली ट्रेंड है, जो भोपा है वो यही बोलेगा कि आपके तो ऊपर की हवा है या कोई चक्कर चल रहा है। तो अगर उसको डिल्यूजन नहीं है तो भी वो वहाँ से थोड़ा सा तो मतलब इंसल्ट कर लेते हैं। फिर वो आप उनको डायरेक्ट ओपीडी में यू हैव लिमिटेड टाइम, अच्छा आपको ऐसा लगता है क्या कि आपके लोग आपके हाँ डॉक्टर साहब है, अब आप और डिटेल पूछ लो, वो बोलेगा भोपा ने बताया, वरना तो कहेगा नहीं भोपा ने बताया। तो इवन लाइक सोशल एंड कल्चरल बैकग्राउंड में भी अपन को एक मतलब डिटेल हिस्ट्री लेना इम्पोर्टेंट है, अदरवाइज आपको डिल्यूजन ऑफ प्रेसिपिटेशन डाल करके स्टार्ट एंटीसाइकोटिक ऐसा भी देखा गया।
वेरी राइट सर। सो आई लास्ट
एक चीज़ और ऐड करना चाह रहा हूँ मैं, क्योंकि लीगल सेल में इसको तो कई बार मेरे किससे ध्यान रहते थे बात बोलते हैं। रोसार टेस्ट अपन पेशेंट्स का कराते हैं जनरली ये देखने के लिए। हमें एक केस पकड़ में आया जिसमें वो रोसार के नेचुरल रिस्पॉन्सेज या मोस्ट पॉपुलर रिस्पॉन्सेज क्या होते हैं वो पहले नेट पे पड़ गया है, और हमने सब तरह कोशिश करके हमारे से वो डायग्नोसिस मतलब हमने कोर्ट का डायरेक्शन था कि उसको एविडेंस दे डायग्नोसिस करो, सीटी एमआरआई सब कुछ करा लिए, किसी में कोई ऐसा सपोर्टिव एविडेंस नहीं रोसार को करके आया। वो बाद में जब उस केस को बहुत कॉन्फिडेंशियलिटी से जब असेस किया तब पता लगा उसकी किसी घरवाली ने लीक करी बात, साहब ये सब गूगल पे देख के आया, इसको रोसार टेस्ट आपने पहले दिन लिख दिया, आपने भेज दिया अपॉइंटमेंट दे दिया कि 3 दिन बाद आना, क्योंकि आज बिजी हमारा साइकोलॉजिस्ट, और ये सब पढ़ के आगे नेट पे।
राइट सर। सो बिफोर द लास्ट panelist speaks and rather recites that will clarify the end, any of the participants in the audience, if they have anything to share,
especially the younger ones,
rather than a question, if it is something to share, it will be nice, because the tone of our discussion is more about clinical and personal experience regarding this. So if anybody wants to.
यूएस के आप अभी मेडिको लीगल बात कर रहे थे, तो मुझे लगा कि शायद मैं थोड़ा सा मेडिको लीगल वाली चीज बताऊँ। जब कभी क्वेश्चंस में आते हैं तो यूनाइटेड स्टेट्स में न्यूरो इमेजिंग के बहुत एडवांसेस है, शायद हमारे एटलीस्ट एक स्टेट में एक जगह तो भी एफएमआरआई सिस्टम ऑन होना चाहिए साइकियाट्रिक में। फॉर एग्जांपल मैं वैसे बता रहा था इंसुलिन का, आप 1 मिलीमीटर स्क्वायर को 264 छोटे क्यूब्स में डिवाइड कर दीजिए और वहाँ पर डेंड्राइटिक अर्बोराइजेशन का डेंसिटी आइडेंटिफाई करिए। अगर आपके डेंड्राइट्स एक दूसरे से बहुत अच्छे से जुड़े हुए हैं, आप देखिए स्किज़ोफ्रेनिया के पेशेंट में क्या होगा, श्रिंकेज मिलेगा। तो जब भी कोई डिल्यूजनल पेशेंट होता है, उसका 1 क्यूबिक मिलीमीटर का 1:264 पार्ट ले लेते हैं, उसका इमेजिंग करके फोटो निकाल के प्रॉपर एनालिसिस करके भेजते हैं, तो वो एक बहुत अच्छा सॉलिड एविडेंस बन जाता है। और एक्चुअली ये जो डेंड्राइटिक अर्बोराइजेशन है वो इंसुलिन रोकता है, तो शायद वो बायोमार्कर बहुत बड़ा सेंस है। मेरा एक और ऐसा ही दिमाग में आया 24 में है, स्किज़ोफ्रेनिया डे है, इतने सारे फेक वर्कर्स काम करते हैं, वो लोग एक्चुअली बेसिकली पैसे के लिए होते हैं। उनको पता होता है कि पैसे मिल रहे हैं, लोग आ रहे हैं और उनको बड़ा सेटिस्फेक्शन भी मिलता है, एक आइडेंटिटी भी मिलती है। इनफैक्ट पीजीआई में मेरे पास जब मैं फर्स्ट ईयर में था तो एक फेक डीलर की बेटी आई थी हमारे पास, उसके पास तो लाइन लगी रहती थी, लेकिन उसकी बेटी के साथ कोई शादी करने के लिए तैयार नहीं था। और इनफैक्ट एक बहुत बढ़िया सा अजीब सा प्रेजेंटेशन था कि उसके यहाँ पे एक क्या लगा देते थे, फाइन लगा देते थे, तो कोई पर्टिकुलर डे ऑफ द मंथ में वो फाइन चिपक जाता था। उसके बाद वो 2-3 दिन तक लोगों के भविष्य वगैरह बताते रहती थी। पंजाब यूनिवर्सिटी के सामने जो मैथमेटिक्स के प्रोफेसर थे, उसकी वो बहन थी, तो उसको वो लेके आ गए क्योंकि उसकी बेटी की शादी नहीं हुई। तो अल्टीमेटली मुझे ऐसा लगता है कि पब्लिक और एडवोकेसी में एक गवर्नमेंट के साथ हमें मॉडल बनाना चाहिए। इन लोगों को में भी है ना, जैसे सर कह रहे थे 90% लोग आते ही नहीं है, एक रेफरल ऑफिसर करके उनको एक छोटी सी सैलरी दे दी या कुछ एडजुवेंट पोस्ट दे दिया, तो हो सकता है शायद हमारे इसमें भी सिस्टम थोड़ा ठीक हो जाए। कानून का क्या कहना है?
गुड आफ्टरनून सर, आई एम डॉक्टर नारायण फ्रॉम मंगलौर। सर मेरा पूरे
से एक क्वेश्चन है रिगार्डिंग सिजोफ्रेनिया कि सर कोई यंग पर्सन है मेल और फीमेल, तो जैसे उसके साइकोटिक सिम्टम्स रहते हैं तो उस टाइम वो 1-2 साल इलाज चलता है, तो उनके पेरेंट्स बोलते हैं कि अब इसकी शादी करें या नहीं करें, और करें तो सर फिर उनको हम क्या एडवाइस करके करें, आगे हमें एज ए साइकियाट्रिस्ट बाद में क्या प्रॉब्लम हो सकती है। हम बोलते हैं कि अभी तो ठीक हो गया, आप तो शादी कर सकते हैं, और कई बार ये हम पे कहीं रिवर्स तो हमारे ऊपर कोई एलिगेशन नहीं लग सकता साइकियाट्रिस्ट पे, क्योंकि सर ये भी एक पार्ट है स्किज़ोफ्रेनिया के पेशेंट को रिहैब करने का।
So, I request Dr. Tami as the senior most panelist to answer this question.
इसका कोई फुल प्रूफ आंसर नहीं है, बट हमने हमारे टीचर्स को इस क्वेश्चन को हैंडल करते हुए देखा है और हम लोग भी इसको डे टू डे लाइफ में हैंडल कर रहे हैं, तो इट्स अ वेरी कॉमन क्वेश्चन। तो सबसे पहला हम लोग कहते हैं कि भाई वो अपनी जिम्मेदारी निभाने में सक्षम है कि नहीं, और उसका बिहेवियर कैसा है। जैसे किसी भी परिवार में कोई बहू आए, है ना, उसका बिहेवियर अच्छा हो और अपनी जो पति के प्रति, घर वालों के प्रति जिम्मेदारी है अगर वो निभाने में सक्षम है, और वो स्टेबल पेशेंट है काफ़ी दिनों से और 1 और 2 मेडिसिन पे स्टेबल है, तो उस पेशेंट्स को हम सलाह देते हैं कि भी आप शादी कर सकते हैं, है ना। बट उसको एक प्रैक्टिकल प्रॉब्लम है कि भी जो मैरिज है वो एक कॉन्ट्रैक्ट है, और तथ्यों को छुपाकर किया हुआ कोई भी कॉन्ट्रैक्ट वो नल एंड वाइड हो जाता है। तो अब ऐसी स्थिति के अंदर अगर वो लड़की वाले कहते हैं कि साहब ये इसको स्किज़ोफ्रेनिया है और ये दवाई ले रही है डॉक्टर तांबी की या फला XYZ की, और हम इसकी शादी करना चाहते हैं, तो कोई भी लड़के वाला यूजुअली जो हमारा जो है वो एक्सेप्ट नहीं करता है इस चीज़, है ना। तो हमारा उसमें जो सेकंड होता है कि भाई आप पहली फेज में ये नहीं बोले कि भाई ये इसको स्किज़ोफ्रेनिया है, पहले उसको बोले कि जैसे किसी को भी अपन जो बड़ा डायग्नोसिस डिस्क्लोज करते हैं तो सडनली नहीं डिस्क्लोज करते हैं, उसको अपन कहते हैं कि थोड़ा सा ग्रेजुअली डिसेंसिटाइज करके करें। तो उसको पहले बोले कि भाई आप ये हमारी डॉटर है, आप देखो, इसके साथ आप उठो बैठो चाय पियो, इसके हाथ से खाना बना के खाओ, है ना, सारी चीज़ें आप कर लो और आप संतुष्ट हैं तो फिर अपन आगे बात करते हैं। तो इस तरीके से जब वो उसको थोड़ा सा वो एक्लिमेटाइज हो जाते हैं उससे, तो उसको बोलते हैं कि थोड़ा सा इसको परीक्षा के कारण से कुछ इश्यूज हुए थे और इनकी दवाइयाँ भी चली थी, तो आप इसकी थोड़ी सी दिन दवाइयाँ और चलेगी इसकी। अब आप सोच लो, तो अगर अप फ्रंट ही अपन कह देते हैं कि भाई इसको स्किज़ोफ्रेनिया है या XYZ की दवाई चल रही है, और वो तो पहली स्टेज पे वो मना कर देते हैं। अगर वो सेकंड स्टेज पे वो कहते हैं कि चलो ठीक है कि आप हमारे को डॉक्टर साहब से मिलवा दें, तो वो कई बार जो लड़के वालों को लेकर के हमारे पास में आते हैं, तो हम उनको कहते हैं कि देखो ये प्रॉब्लम है, और इस तरीके के पेशेंट के अंदर, है ना, जो अपना जो प्रोग्नोसिस का जो है कि कई बार फर्स्ट एपिसोड होता है और लाइफ में दोबारा उसको कभी एपिसोड नहीं होता है। तो यूजुअली जो गुड प्रोग्नोसिस वाले पेशेंट हैं जो अपनी जिम्मेदारी निभा सकते हैं और जिनका बिहेवियर अच्छा है, उन्हीं को मैं यूजुअली शादी करने के लिए कहता हूँ। ज़्यादातर जो अगर स्टेबल नहीं है पेशेंट, प्रॉब्लम क्रिएट कर रहा है, तो मैं घर वालों को कहता हूँ कि आप इस बच्ची के नाम से जो पैसा है वो आप इसकी वेलफेयर के अंदर एक फंड बना लो, और इसको है ना, अगर आप शादी करेंगे तो आपका पैसा भी चले जाएगा और लिटिगेशन और स्टार्ट हो जाएगा, क्योंकि अगर ये अपनी जिम्मेदारियाँ नहीं निभाएगी, बिहेवियर ठीक नहीं होगा, तो कोई भी फैमिली इसको एक्सेप्ट नहीं करेगी।
Right, sir. So, after this informative panel discussion, which has been about clinical aspects, personal experience, wisdom of the senior members of our panel. I think that we are about to close this, but before that, I would request Dr. Tushar Garg. He has a poem to recite. So, sir,
Thank you, Doctor. आज schizophrenia day है. This is the right time to make awareness to the people. एक छोटी सी हिंदी में कविता लिखी है जो मैं आपसे सुनाना चाहूँगा. स्किज़ोफ्रेनिया कोई श्राप नहीं, कोई अभिशाप नहीं, ऊपरी हवा का चक्कर या पुनर्जन्म का पाप नहीं. इसका दवाइयों एवं मनोचिकित्सा से उपचार संभव है. इसका इलाज जादू टोना, झाड़ फूक, तंत्र मंत्र, जाप नहीं. रोगी की कभी अनुभूति व कभी विचार बदलता है. कभी रोगी का मूड तो कभी व्यवहार बदलता है. कभी साथ में डिप्रेशन तो कभी साथ में ऑब्सेशन. 6 लक्षणों के आधार पर उपचार बदलता है. वो सच्चाई और कल्पना में फर्क नहीं कर पाता है. वो सच्चाई और कल्पना में फर्क नहीं कर पाता है. बेवजह परिजनों व मित्रों पर शक कर जाता है. कभी गुस्से में आकर डरा देता है सारे जमाने को, तो कभी खुशी सुरक्षित स्थानों पर बेवजह डर जाता है. अक्सर शक और वहम के चक्रव्यूह में फंस जाता है. तर्कहीन अर्थहीन ख्यालों के दलदल में धंस जाता है. पार्टी हो, खुशी हो या त्योहार हो तो रोने लग जाता है. तो कभी दर्दो गम के माहौल में अचानक फंस जाता है. कभी जेनेटिक, कभी जैविक रासायनिक कारण होते हैं. कभी परवरिश तो कभी मनोसामाजिक कारण होते हैं. सोचने, समझने, महसूस और व्यवहार में परिवर्तन होता है. तो कभी डिवीजन तो कभी हेलुसिनेशन होता है. अस्थमा, बीपी और डायबिटीज की तरह ये भी एक रोग है. अस्थमा, बीपी और डायबिटीज की तरह ये भी एक रोग है. इस मनोरोग से पीड़ित आप और हम जैसे ही लोग हैं. इस मनोरोग के पीड़ित आप और हम जैसे ही लोग हैं. समय पर मनोविशेषज्ञों से नियमित परामर्श करने से इस मनोरोग से निदान, उपचार और पुनर्वास का योग है. इस मनोरोग में निदान, उपचार और पुनर्वास का योग है. धन्यवाद.
And I must say special thanks to Dr. Manju Batra for organizing this. He was not there in the initial part when we started. So with the permission of the panel, can we close this? Thank you.
Such an insightful session. There couldn't be any better way to celebrate World Schizophrenia Day and spread awareness. I extend my heartfelt thanks to all the panelists for your insightful contributions. Your perspective enriched the conversation and added a great value to the event. We take this moment to express our deepest appreciation and felicitate our esteemed panelists. For the same, I would like to invite Dr. Rajiv Kasliwal sir to kindly felicitate Dr. Anil Tambi sir. I would like to invite Dr. Anita Sidhana ma'am to felicitate Dr. Vinod Daria sir. Next, I would like to invite Dr. Bhavuk Garg sir to felicitate Dr. Tushar Jadawat sir. Next, I would like to invite Dr. Sidhana sir to felicitate Dr. Vikas Gaur sir. Next, I would like to invite Dr. Gaurav Chandravanshi sir to felicitate Dr. Jitendra Jingra sir. Next, I would like to invite Dr. Nukul Sumani sir to felicitate Dr. Raghav Shah sir. So please, can you have a photo? I would like to invite our next event. I would like to make an announcement for the participants to hold their breath for a final round. And the quiz awards will be announced soon after the next event. Thank you so much. Growing world increasingly aware of the spectrum of gender and identity. This session aims to bridge gaps, reduce stigma, and promote holistic and compassionate care. Through an interdisciplinary lens, our esteemed speakers will explore medical, psychological, clinical dimensions of gender dysphoria and LGBTQIA mental health, offering insights academically rich and socially vital. So, we are moving to our theme symposium, Understanding Gender Dysphoria, LGBTQI Identity, Integrating Medical, Mental Health and Clinical Perspectives. A revolutionary transgender activist, the first person to get admission in Rajasthan University, the first person to get birth certificate in Rajasthan, valid drive, and there are so many firsts that I would like to mention to the list of transformation that she has got. She also took up an initiative from Honorable Chief Minister of Rajasthan to provide facilities of National Food Securing Act to transgenders. She is also the President of State Rainbow LGBTQI Society. We welcome you.
Good evening, everyone. We are here for the discussion of transformation. कि transformation जो रहता है, उसके क्या पूरा procedure रहता है? Why we need psychiatric GID certificate? Why we need endocrinologist treatment? And why we need like पूरा जो process रहता है, उसमें psychiatrist का क्या main role है? तो उसमें psychiatrist का जो main role रहता है, वो ये रहता है कि हमारे पास multiple counseling sessions रहते हैं. उसके बाद फिर endocrinologist का role रहता है. वो हमको hormonal therapy के through हमको medicines जो हमारे रहते हैं, जैसे कि फॉर एग्जांपल ट्रांस वुमेन के लिए एस्ट्रोजन, और अगर ट्रांस मेल है तो उसके लिए टेस्टोस्टेरोन, और उसके बाद फिर सर्जन का रोल आता है जो कि बॉटम और टॉप सर्जरी रहते हैं, फॉर एग्जांपल वर्जिनोप्लास्टी. तो इसमें मेन जो रोल है वो साइकियाट्रिस्ट का इसलिए भी है क्योंकि एक जो रहता है, कई हमने केसेस देखे हैं कि कई लोग क्या रहते हैं कि उनको क्लियरिटी ही नहीं है कि अगर वो ट्रांसफॉर्मेशन पे जा रहे हैं तो क्यों जा रहे हैं. मतलब लाइक कई ऐसे होते हैं अपने पार्टनर्स के लिए सेक्स रीअसाइनमेंट सर्जरी करवाते हैं. कई लोग होते हैं कि उनको लगता है कि शायद ये रिस्क है, एक बार मतलब करने में ट्राई करने में जा ही क्या रहा है. तो वो सब चीज़ें हमने देखी है. हमने कई ऐसी चीज़ें भी देखी हैं कि जहाँ पे वो सेक्सुअल रीअसाइनमेंट सर्जरी करवा लेते हैं विदाउट काउंसलिंग सेशन. बाद में फिर अगर हम देखते हैं तो वो डिप्रेशन एंजाइटी में चले जाते हैं क्योंकि उनको भी दिखता है कि कई जो फैमिली एक्सेप्टेंस नहीं है, सोसाइटी एक्सेप्टेंस नहीं है. तो वो सब चीज़ें भी हमने देखी हैं. तो इसलिए यहाँ पे जो मेन रोल है वो साइकियाट्रिस्ट का ही है. तो मैंने ये चीज़ नोटिस करी है कि काफ़ी जो ट्रांसजेंडर्स हैं जो डायरेक्टली सर्जन्स के पास जाके अपनी सेक्सुअल रीअसाइनमेंट सर्जरी करवा लेते हैं, बाद में वो क्या रहता है ना, एंजाइटी और डिप्रेशन में चले जाते हैं. तो यहाँ पे मेन जो रोल है वो साइकियाट्रिस्ट का ही है अकॉर्डिंग टू मी और अकॉर्डिंग टू ऑल डॉक्टर्स. आप ये सब जानते हैं कि बिना उसके मतलब आगे का जो प्रोसीजर है वो मतलब पॉसिबल ही नहीं है अगर देखा जाए तो. क्योंकि अगर साइकियाट्रिस्ट के साथ अगर मल्टीपल कॉन्सल्टेशंस अगर नहीं हो पाते हैं उनके, तो फिर आगे अगर उनको जेडी सर्टिफिकेट नहीं मिल पाता है तो एंडोक्रोलॉजिस्ट के पास जाके अपना ट्रीटमेंट परस्यू नहीं कर पाएंगे. तो काफ़ी मैंने एक हद तक ऐसी चीज़ें देखी भी हैं. कई ऐसे सर्जन्स हैं जो बिना जीआईडी सर्टिफिकेट के या फिर बिना एंडोक्रोलॉजिस्ट के सर्टिफिकेट के भी सर्जरीज कर रहे हैं, जिससे काफ़ी हद तक जो चीज़ें हो रही हैं ट्रांसजेंडर्स के साथ. अगर आप देखेंगे, हम जैसे जानते हैं कि अगर किसी मेडिकेशन के, जैसे अगर फॉर एग्जांपल अगर मेरा एक्सीडेंट होता है, ठीक है, और अगर जो डॉक्टर ने ट्रीटमेंट कर रहे हैं तो मैं उनको ये बताऊंगी नहीं कि मैं HRT पर हूँ, या फिर अगर मेरे को थायराइड है, तो फिर मेडिकेशन इफेक्ट करते हैं। फॉर एग्जाम्पल अभी आप देखेंगे कि काफ़ी जो साइलेंट अटैक आ रहे हैं उसमें भी काफ़ी हद तक ये सब चीज़ें देखा जाए तो ट्रांसजेंडर साथ भी हो रही हैं, तो वो एक चीज़ें हैं यहाँ पे। उसके अलावा मैं यहाँ पे डॉक्टर्स के जी मैं मंजू मैम एक एग्जांपल हमको बताया था कि एक बार मेरी मंजू से बात हुई थी कि यहाँ पे एक ट्रांस मैन के साथ एक केस हुआ था कि 5 साल का था आई गेस मैम, वो है ना 5 साल का एक उसके जो फादर थे वो लेकर आए थे और उनको ये बोलता कि आप इसी काउंसलिंग सेशन कीजिए। उसके उस जो आदमी था उसके 5 लड़कियां थी, ठीक है, 5वीं लड़की थी वो उसको सेक्स चेंजिंग सर्जरी के थ्रू उसको लड़का बनाना चाहते थे और वो भी फोर्सफुली। तो ऐसा भी नहीं है कि GID चाहिए तो हमको फोर्सफुली चाहिए, ठीक है, जो क्योंकि हम लोग का मेन मोटिव ही ये रहता है कि जब हम देखेंगे जितने हम साइकियाट्रिस्ट बैठे हैं जो मल्टीपल काउंसलिंग सेशंस वो लोग करते हैं तो उसमें वो यही जानने की कोशिश करते हैं कि वो अगर जिसके हम ट्रांसफॉर्मेशन पे जा रहे हैं तो वो क्यों, एक रीजन क्यों हम जाना चाह रहे हैं उस चीज़ के लिए, क्या हम अपने पार्टनर के लिए जाना चाह रहे हैं, क्या हम, क्योंकि आजकल देखा जाए तो कई लोग को ये लगता है कि बीइंग अ ट्रांसजेंडर अगर आपको देखा जाए तो फाइनेंशियली भी आपको उसमें बहुत वैसा रहता है, ठीक है, इजी वे ऑफ इनकम रहती है बधाइयों में और इन सब में। तो कई लोगों को ये चीज़ का भी रहता है कि भाई फाइनेंशियली भी वो करवाते हैं ट्रांसफॉर्मेशन, ठीक है, बट हम ये चीज़ नहीं कहना चाहेंगे खाली वो इसीलिए ही करवाते हैं। कई लोगों को जेन्युइनली भी ऐसे एक रीज़न होता है कि उनको करवाना चाहिए, करवाना पड़ता है इन चीज़ों के लिए। जैसे कि बहुत से लोग बोलते हैं कि आप लड़के पैदा हुए थे, ठीक है, आपको क्या जरूरत पड़ रही लड़की बनने की। ये क्वेश्चन अगर कोई डॉक्टर रेज करे ना तो बहुत गंदा लगता है, कोई काउंसलर अगर रेज करे तो बहुत गंदा लगता है, ठीक है, क्योंकि बीइंग अ डॉक्टर आपको ये चीज़ समझनी चाहिए कि आपके जो पेशेंट्स हैं, ठीक है, तो वो लोग ये चीज़ करवा रहे हैं तो उसके पीछे कोई रीज़न है, ठीक है। मैं एज अ मेल पैदा हुई थी, जब मैं पैदा हुई थी तो आई वाज अ मेल, ठीक है, बट मुझे वैसी जिंदगी नहीं जीनी थी जैसा मैं जीना चाह रही थी, ठीक है। मेरे को उस चीज़ के लिए मुझे अपनी जेंडर अफर्मेशन सर्जरी करवानी थी, उसके लिए मुझे साइकियाट्रिस्ट की जरूरत थी, मुझे एंडोक्राइनोलॉजिस्ट की जरूरत थी, वो सब चीज़ें मुझे नहीं पता थी। आज भी अगर आप देखेंगे ना हमें अगर मेट्रो सिटीज़ में देखेंगे, फॉर एग्जाम्पल दिल्ली या मुंबई में देखेंगे तो वहाँ पे इन सब चीज़ों के लिए लोग बहुत अवेयर हैं, ठीक है, वहाँ के ट्रांसजेंडर्स अवेयर हैं थोड़ा बहुत चीज़ों के, क्योंकि एजुकेशन रेट जो है वहाँ पे थोड़ा मतलब ट्रांसजेंडर्स में देखा जाए तो है, मतलब वहाँ पे वो लोग अवेयर हैं इस चीज़ को लेकर। बट व्हेन इट कम्स टू राजस्थान थोड़ा यहाँ पे बहुत, अभी मेरी राजस्थान कातराल सर से मेरी बात हो रही थी इस चीज़ को लेकर, तो ये बता रहे थे कि ट्रांसजेंडर आते तो हैं, है ना, बट वो ये देख कर कि बहुत लंबा प्रोसीजर है वो फिर नहीं आते हैं। फॉर एग्जाम्पल कि अगर जैसे कि अभी काउंसलिंग सेशन जब होते हैं किसी ट्रांसजेंडर के, ऐसे जब GID सर्टिफिकेट के काउंसलिंग सेशंस होते हैं तो वो जो प्रोसीजर है वो ज़रूरी नहीं है कि आपका 2 महीने चलेगा या 6 महीने चलेगा या साल भर चलेगा, वो डिपेंड करता है आपके काउंसलिंग सेशंस पे। हो सकता है कि आपने 6 काउंसलिंग सेशंस के बाद ही आप लोगों को पता लग जाए कि वो क्यों करवाना चाह रहे हैं ये ट्रांसफॉर्मेशन, और हो सकता है कि आपको साल भर बाद में पता भी ना लगे, है ना, तो वो एक चीज़ रहती है। बट ये बहुत इंपॉर्टेंट पार्ट है क्योंकि अगर आप बिना इस प्रोसीजर के आप डायरेक्ट सर्जरी करवा लेते हैं तो फिर बाद में आपको एंजाइटी डिप्रेशन में चले जाते हैं। मैंने बहुत से ट्रांसजेंडर्स देखे हैं जो सुसाइड भी कर लेते हैं। इंडिया में यहाँ पे देखा जाए तो इस चीज़ के लिए बहुत, मतलब अभी मुझे ऐसा लगता है कि एक्सेप्टेंस बहुत कम है अभी हम ट्रांसजेंडर्स के लिए स्पेशली। आप ये देखिए, आई एम द फर्स्ट ट्रांसजेंडर इन इंडिया हु गॉट बर्थ सर्टिफिकेट, मतलब एक बर्थ सर्टिफिकेट पाने वाली पहली ट्रांसजेंडर मैं हूँ। तो इसका मतलब जितने भी ट्रांसजेंडर आप देख रहे होंगे सिग्नल्स पे, ठीक है, आप ट्रेन में बैगिंग करते हुए देखते हैं, आपके घर में बधाई मांगने पे आते होंगे, तो क्या मतलब वो पेड़ से हो गए हैं, आसमान से गिरे हैं या फिर क्या है, ऐसा तो नहीं है, वो लोग भी आप ही का पार्ट है, ठीक है। और यहाँ पे 99.9 ट्रांसजेंडर जो होते हैं सेक्सुअल रीअसाइनमेंट सर्जरी करवाते हैं। यहाँ पे लोगों का मिथ है कि नहीं वो बाय बॉर्न होते हैं, है ना, ऐसा नहीं है कि बाय बॉर्न होते ही हैं। बाय बॉर्न जो होते हैं वो इंटरसेक्स होते हैं, और इंटरसेक्स यूजली 1 से 2% ही होते हैं, बाकी सारे सेक्सुअल रीअसाइनमेंट सर्जरी ही करवाते हैं। तो वो एक चीज़ की हमको नॉलेज में बहुत ज़रूरी है। मैंने एक डॉक्टर है मेरे नोन बहुत अच्छे, तो उन्होंने मुझे बताया था कि एक साइकियाट्रिस्ट की ऐसी कॉन्वर्सेशन चल रही थी विद दी साइकियाट्रिस्ट, ठीक है, तो उसमें उन्होंने एक चीज़ बोली कि ये तो एक बीमारी है और ये तो एक तरीके से दवाई भी ठीक हो सकती है, जैसे आपके पास और भी पेशेंट्स आते होंगे, है ना। अभी हम कितनी बात कर रहे थे जो उनके साइकोलॉजिकल जिनको प्रॉब्लम होती है उनके बारे में, तो ये कोई बीमारी नहीं है, ये कोई ऐसे दवाइयों से ठीक होने वाली चीज़ नहीं है। इफ आई वांट टू बिकम अ गर्ल, आई वांट टू बिकम अ गर्ल, और उसके लिए प्रोसीजर फॉलो करना रहता है। तो ये सब चीज़ें जो होती हैं ना, डॉक्टर से हम लोग सुने तो वो हमको बहुत ज़्यादा, जैसे कहते हैं ना, प्रॉब्लम है, मतलब हम लोग को अच्छा नहीं लगेगा। अगर फॉर एग्जांपल अगर आपका कोई पेरेंट्स आते भी हैं और वो बोलते हैं कि भाई हमारा बच्चा लड़का है और लड़की जैसे बिहेव कर रहा है, या लड़की है लड़कों जैसे बिहेव कर रही है, तो आपको ये चीज़, मतलब आपको ये चीज़ नहीं कह देंगे उन लोगों को कि हाँ भाई इसको कुछ प्रॉब्लम है, इसको काउंसलिंग सेशन की जरूरत है, ये लड़का है तो लड़का ही रहेगा काउंसलिंग सेशन के बाद, या लड़की है तो लड़का बनना बंद कर देगा काउंसलिंग सेशन के बाद। आपको ये चीज़ देखनी होगी और आपको इन सब चीज़ों पे थोड़ा वर्क करना रहेगा। और आई नो आप लोग डॉक्टर हैं, आप लोग एक्सपीरियंस हैं, आप लोगों के पास केसेस आते भी होंगे, बट मुझे ऐसा लगता है कि क्या यहाँ पे डॉक्टर्स को इतना पता है GID सर्टिफिकेट के बारे में, जेंडर डिस्फोरिया सर्टिफिकेट के बारे में, और कितने ऐसे डॉक्टर्स हैं जिनको ये लगता है कि खाली बीमारी जो कि दवाइयों से ठीक हो सकती है, जो कि नहीं है। ये एक बीमारी नहीं है, ये जैसे कि अगर हम फॉर एग्जाम्पल मुझे एग्जाम्पल डॉक्टर्स को देते हुए मुझे बहुत अजीब लग रहा है, पर ये जैसे अगर सपोज कोई बच्चा है, कोई अगर विकलांग पैदा होता है, तो आज जीवन विकलांग तो नहीं रहेगा, उसका ऑप्शन होगा अगर, तो वो आजीवन विकलांग तो नहीं रहेगा ना। तो वही सेम चीज़ हमारे साथ है ट्रांसजेंडर्स के साथ। सोसाइटी में हम लोगों को बहुत ज़्यादा डिस्क्रिमिनेशन स्टिग्मा का सामना करना पड़ता है इन्हीं सब चीज़ों के कारण। मतलब अभी आप देखिए, अभी मैं रिसेंटली मेरे साथ ऐसा हुआ था कि मैं फ्लैट लेने गई थी, वहाँ पे मैंने टोकन अमाउंट भी जमा करवा, मतलब डिपॉजिट करवा दिया था वहाँ पे, बट उन्होंने मुझे मना कर दिया जस्ट बिकॉज आई एम ट्रांसजेंडर। तो अब ये चीज़ देखिए कि हम लोग कितनी प्रॉब्लम फेस करनी पड़ती है। अब जब डॉक्टर से ही हम ये सब चीज़ें सुनते हैं, काउंसलर से हम ये सब चीज़ें सुनते हैं, तो हमको कितना बुरा फील होता होगा इन सब चीज़ों को लेके। तो वही सब चीज़ों पे आज हम डिस्कशन करेंगे, उस जेंडर सेंसिटिव जो हमारे सेशन है। उसके अलावा डॉक्टर नकुल हमारे साथ हैं, राजीव सर हमारे साथ हैं, अनिरुद्ध हमारे साथ हैं फ्रॉम द LGBTQ कम्युनिटी। तो मैं चाहूँगी बाकी जो चीज़ें हैं वो बताएं तो ज़्यादा मेरे को लगेगा वो बेटर है। सर प्लीज, डॉक्टर नकुल सोमानी सर।
It is a privilege to welcome Dr. Rajiv Kasliwala sir, Professor and Head of Endocrinology at Mahatma Gandhi Hospital and Medical College, Jaipur. He also brings his expertise to ICAM super specialty clinics, Durgapura, with over 40 international PubMed indexed publications. Dr. Kasliwala is a distinguished voice in the field. His clinical interests include diabetes, metabolic disorders, neuroendocrinology, and adrenal pituitary neoplasms. We are delighted to have you, sir, join us today and look forward to your valuable insights.
Thank you. Thank you, Manju Madam, and the whole Rajasthan Psychiatry team who invited me and to talk upon this topic which is probably less spoken and something is being kept away from the front or from the limelight. So, but it's a very important thing. I would, my slides can look a little bit more crowded because I was not sure how, what kind of, how much interest would be there in terms of hardcore hormonal therapy and everything. So we can keep it two-way also. You can interrupt me and ask questions, and I'll try to just give the, just some few points about to ponder upon and think about it. So don't read the slides too much. So it's just to give a title and nothing more than that. So this is basically, these are, it's not even visible. So there are a lot of terminology which we use so that we should now aware of what's movement, transmission, GID and other things. I think you are already knowing this thing. So, and so the whole thing starts from the beginning, from the childhood. There are certain traits and features by which we can make a distinction that someone is probably having the problem of GID, especially in Western countries where childhood psychology is so much in focus. So there at least they can recognize the things. And as the child grows, the internal struggles start because it's like a feeling of trapped in someone else's body. That's the apt word. You are inside, you feel inside like a female or female, and then you are trapped in a body which is of someone else. That's the exact feeling. So that's how from this internal struggle starts and the dysphoria starts. Then when we can identify the things, then we start the medical treatment which includes medicinal treatment plus surgical treatment. And at the end of this thing, then ultimately last step is the social integration of the people who have this condition. So these are the basic 4 steps through which we go through. And as just we discussed now, there has been change, and I think you guys are more aware than me that DSM-5 has taken this out as a disorder or disease. In fact, they have put it up in a different category altogether in a sexual conditions, no longer a disease. So it's basically depathologization of the condition. It's not a disease, which was the Noor was just trying to say. It's no longer a disease. That concept has gone, and the whole focus is to address the dysphoria, distress or dysphoria rather than being looked upon as a disease. And in fact, ICD-11 also has shifted this thing from mental health disorders to sexual health chapter. And that's why the current understanding is to recognize this just a natural variance, not a disease or disorder or something like that. And our focus should be more towards the affirmative care, the integration, and ultimately the support which we can provide as a society, and we can absorb everyone just that. So coming to the parts, gender affirmative hormonal therapy, GHT, there are multiple guidelines, and there are the World Professional Association for Transgender Health, then Endocrine Society, US Endocrine Society basically is there, then SAPO, good practice guide is there for gender affirmative care, and then there are certain Indian version of these guidelines. Most of the material has been taken from the US Endocrine Society as far as the hormonal care is concerned, and then there are certain minor changes which we have done based on our own cultural things and all. So this is the agenda. I think I'll skip that. So where do we fit in? So it's a gender affirmation is a multidisciplinary condition that needs to be taken care by multiple people. Psychiatrists, psychologists, endocrinologists, and then surgeons who are doing the surgeries. So ultimately, most of the time they are being referred to us to develop the physical characteristic of the affirmed gender that patient has, or I will not say patient, the person has decided. So that's why they are being referred to us. So we do clinical assessment, who are the candidate for HRT, is there any contraindications, relative or absolute, then whether there are no other conditions which can get aggravated with HRT or not. Then what are the treatment protocol, best possible options for HRT? There are multiple options of giving HRT also. And then long-term monitoring, that is most important. That it's not just about starting, you need to monitor them regularly as we do for other conditions like diabetes, hypertension, every 3 months, 6 months follow-ups are required. So what is basically what we do in gender affirming hormone therapy? What we do is we suppress the endogenous sex hormone, that sex hormone secretion determined by the person's genetic or gonadal sex. So if someone is a trans woman, then we need to suppress the testosterone so that we can make the glass empty. Then we need to give the treatment which will feel her or which will matches with her gender or his gender identity. So once we need to make the glass empty, and then we have to fill this with something else so that it can match with the person's gender identity. So that is the job of endocrinologist. Now I just don't go the table, but I just want to highlight, because in our country probably we are not facing this question still, the adolescents, because that's a very tricky age. The traits can be seen, or the signs can be seen, we can see them from childhood also only. And in Western country where the awareness is more and more, in adolescence it's something difficult to decide about whether we should start HRT or not. So, and there are some ethical issues also, because the person who is giving consent for it is not still major. So the parents comes into the picture, whether they can take decision on their behalf, that is also a question. Because in Western countries there have been actually court cases against the parent as well as the treating doctor who has done the actually gender affirming surgeries and other things, because these are the irreversible things. And one fine day the person himself decided to I do not want this thing. So basically 14 to 18 years is the period where we need to decide what to do. The reason being that first thing is that if we do not allow the puberty to happen, So suppose if someone is a trans woman and we suppress the puberty at that level and give them time to think and decide, we can prevent the breast development. In a case of trans woman, we can suppress the development of facial hair and other things, which is a very big issue later on in the life. You need to do laser and spend lakhs of rupees. So we can suppress all those things. Let them take a decision till the time of 18 years, and then we can do the whatever HRT depending on their preference we can give them. So we have options of giving DTE.GHS analogs which can suppress the puberty reversibly. Whenever we want to stop it, we can stop it. There are multiple guidelines which we need to fulfill before we consider them for DTE.GHS analog therapy. But that can be done. That is happening very well in Western country. In our country, the area is still grey because in our country the age of consent is 18 years. We still cannot give, or maybe it's evolving field. We cannot give gender-affirming hormonal therapy for adolescents. So these are the basic checkups we do. So every therapy which we do has to be done under medical supervision, because there are always one or other side effects or things to be watched for during this therapy. Especially this is a growing age. So not only it's about secondary sexual characters, it's about the growth also, height development also. So these things needs to be seen. Again, that second part is that one is suppression of puberty, second is induction of puberty according to the gender identity of the patient. So that age is 16 years as per the Western guideline. Indian, we still don't know. So 16 years. At 14 we can suppress the puberty, but minimum age for cross-sex hormonal therapy is 16 years. With parents' consent, they can still not go for surgery before 18 years. And there are different protocols by which we can induce male puberty or female puberty depending on HRT. So there are different doses. The only idea is to mimic the physiological development. So you start with low dose and gradually, just like the normal puberty happens over next 3 to 4 years, that's how we increase the dose of hormones. We don't just start with a full dose what is required in a fully grown male or female. So that's again, we need to monitor them because HRTs, the estrogens can lead to epiphyseal fusion. So it can actually shorten your height also. So there has to be proper documentation of height and other parameters as well as multiple other hormones and their levels, so that we do not undershoot or overshoot in terms of hormonal therapy. So in India, as far as we are actually getting away by saying that age is 18 years, so we are not going to start anything. But soon I think the things are evolving and rapidly changing, so we will be having this question of 14-year boy where puberty is not there. We don't know what male or female, so these are the tricky questions. They cannot give the consent legally, so we need a big board of doctors to decide where or what should we do. US, yes, there is DTE.GHS. Usage of DTE.GHS is very, very established practice till there is a clarity happens. We do not allow the puberty to develop before that. So coming to the adults, so adult is like as it is the first the requirement before we start gender affirming hormonal therapies. We get the opinion from our psychiatrists and psychologist colleagues, mental health professionals, to certify the diagnosis whether there is a well documented gender dysphoria or gender incongruence, whether there is some other mental health concerns which are leading to this condition, whether the patient is having the capacity to make a fully informed decisions and give consent for the treatment, and of course then that the person should be able to give the consent. So then we have for trans women we use basically estradiol, and for basically trans male or trans men we use basically testosterone for the gender affirming therapy. Of course, the doses are depending on the person's age, and generally the basic principles start low and gradually build upon. So the average doses are almost like higher than what is in normal male or female we require. So and then once we start HRT, there is a proper monitoring protocol, how much level should be there, in the body of that particular hormone. So there are like for goal for estradiol is 100 to 200 micropicogram per ml, and testosterone level in a trans woman, because in a trans woman we need to do the two things. It's more difficult with trans women. So what we need to suppress the testosterone and we need to increase the estradiol. Then only the things are going to work. In trans men, sometimes giving testosterone alone is sufficient to stop the cycle and stop the decrease the secretion of estradiol. But in a trans woman, we need to do both things. We need to suppress the source of testosterone and we need to supply the estrogen from outside. So it requires a lot of monitoring, because estradiol especially has a lot of side effects also if not being properly given. So frequency of monitoring in first year is every 3 months, and then maybe later on every 6 months, and sometimes later once they are well settled in, well transitioned, then once in a year also. In trans men, when we give testosterone, sometimes, as I just mentioned, sometimes giving testosterone is enough, but sometimes they still keep on cycling just like a female, or we are not able to suppress estrogen completely. Then there are further things which we can use, maybe DNS analogs or dipoprogesterone also. Now coming to the important point is again, because every HRT has its infringing side effects that we need to understand very well. So if the transgender people are following with you, then it's very important to emphasize that we need to monitor for the complication, and most important complication is thromboembolic disorders. DVT, cerebral sinus thrombosis, pulmonary thromboembolism is fairly common. Someone who is on HRT, if not being given under supervision. Then there is a risk of prolactinoma, because the pituitary, the prolactin cells have estrogen receptors. So once we replace estradiol in higher doses, there is a chance that tumor can increase. And of course, the increased chances of breast cancer, coronary artery disease, so all kind of cardiovascular disorders increases whenever someone is on estrogen. Then lipid profile is a big problem with estradiol therapy if not being managed properly. In a male, someone who is on in a transgender male, when someone is on testosterone, then polycythemia is a big problem. Almost 25% of the people who are on testosterone replacement therapy, they have hematocrit of more than 50%. And in fact, more than 54%, we need to actually do regular phlebotomy for that, or we need to decrease down the testosterone level or increase the duration. So that is very, very common. Then hepatic dysfunction is common. More than 3 times elevation is seen almost in 20% cases. Again, and then coronary cerebrovascular cardiovascular disorders. Because we don't see these patients, sometimes because of the lack of awareness in society, because of the poor follow-ups, the complication, it seems, appears to be very less because they are actually not following up. The person who are giving certificates do not know what happens after to that. The person who is operating upon don't know what is happening after that. And in fact, for people like us, we start HRT, but they will take it for the time, till the time surgery is done. That's a fact. And then once the surgery is done, then there is no follow-up after that, what has happened. And it's so funny sometimes when I was just discussing with Noor, the people have that fixed 3-4 that combination which is going on in their WhatsApp group. It's like it's a toffee or chocolate or churran, whatever you want to say. Everyone take that thing, कोई जरूरत ही नहीं है 4 दवाइयाँ खानी है, fixed dose में खानी है, ये करना है, that's it. And it's a very close community. So these close communication, वहाँ पे ये मिलता है, वहाँ ये मिलता है, वो ये करता है, everyone knows everything. So that's the problem. So there is no follow-up, so we don't know what is happening. Sometimes even we can see in our day-to-day OPD, they hide their history. So we don't know the thromboembolism which is happening there, or the CBT which is happening there is because of actually HRT, we need to withdraw it or something, we need to reduce the dose. Because many times these things are never being told to you as a person when you see them in general OPD or not. So this is the consensus statement, idea statement which we need to screen before we give HRT. On just one line, again, just to there is always a temptation whether when we give high estradiol, I would be looking more feminine. That's because once you want to become a woman, then you want to become perfect woman. So there is a attempt or many times that you, again, because it's not supervised, so they can take 2 milligram, they can 4 milligram, someone will say 6 milligram of estradiol every day, someone even 10 also. But same time, as the dose of estradiol goes up, actually the risk of cardiovascular disorders, thromboembolism also goes up. So there is no relationship between the dose of estradiol, as long as it is in the range prescribed, then there is no further increase in the sense of feminism. That's the important message which I want to convey more also. And then we again, when someone is on HRT, smoking is more common in transgender, alcoholism is more common in transgender, obesity is more common in transgender. So all these things along with HRT is a deadly combination. So we need to encourage them to lose, to cease the smoking. They need to take care of their cardiovascular health, their physical activity much more appropriately, and then dementia is again more common. So those things, screening should be done. Now, when do the changes happen? So generally, most of the these are the timelines. Generally, the changes, because that's the next question which they are very much eager to know. When I will start getting, the features which I want to have. So like someone who is a transgender male, the first question when will I going to have mustache or beard or something like that. So that's the first thing they are going to ask. So this is the timeline. Most of the changes happens between 3 to 6 months, and then they keep on happening till 3 to 5 years. Feminizing changes, again same thing. So especially they are more worried about the hair growth, so they want to get it decreased. So it is again the thing starts at 3 months. So it's important basically is to keep them calm and keep them patient, because even after HRT it is going to take time. The full features takes 3 to 5 years for development, and there are certain things which we cannot change, like voice change. We cannot do anything for that unless we do some extensive surgeries for that. These are the monitoring again. So monitoring can be in the form of hormones, at what level you are treating, the doses are sufficient or not, and then second, monitoring for the various complications of HRT. So these are the two parts of monitoring which we will do once the transgender person is well transitioned. And so there are certain difference between male and female, but more or less the idea is to monitor the complication, and idea is not to overshoot or undershoot the hormones. Now about gender affirming surgery, I think Dr. Nakul is going to speak to this thing in detail. The most important thing is we need a legal age of consent, 18 years, to do the surgery. We need to spend, and the person should be at least spend 12 months of time on HRT, then only legally they can undergo. There are other ways also, but legally they can undergo gender affirming surgery only after 12 months of completing the HRT, behaving and living like a cross gender. So that someone who is, because most of the time surgery may be irreversible. So before you go for a irreversible thing, the person who is going for this thing has to be 100% sure. They should have they should have crossed the river and go to the other side, check whether they are comfortable or not in that role, and then only you should go for something which is irreversible. So these are the various things. The only important things which we want to communicate here is that someone who is on HRT, there are certain things, precautions which we need to take, especially someone like a trans woman who is on estradiol therapy. There is a risk of thromboembolism, especially surgery. Anyway, the risk of thromboembolism increases. So we need to stop the HRT 4 weeks before, and we need to restart it if required. If most of the cases where we started after 4 weeks, so that's a very important thing. But the bigger message is someone who is on HRT, they should not hide their history, because any surgery, even for appendix or hernia, puts the same risk of venous thromboembolism. So that needs to be stopped 4 weeks prior to surgery until unless it's an emergency. If it's emergency, you need to take care of good anticoagulation during perioperative period. That thing is many times is hidden. We need to disclose this information to the treating doctor if they are on HRT. Testosterone, on the other hand, for trans male, do not have that much effect on the coagulation, so that can be continued or they can be stopped just 1 week prior to the surgery. But for estradiols, there is a lot of issues. These are the various endocrine, at least consensus statement, how to do the, give the HRT in a proper way in transgender populations. supported by the Endocrine Society India. So before we start HRT, we do routine biochemistry, hormonal labs, 2 independent psychiatrists. So these things keeps on changing. So yes, I'm just going to point out. So another one thing, HIV is more common, so be careful about the interaction of HRT and ART if someone is on. Then elderly population, one again challenge is there that we do not know. Now someone who is a trans woman, we do not know when to stop the estradiol, like a normal menopause, 45, 40, 60, we don't know. So that's the another challenge. We are seeing the patients who are in elderly population who are already on HRT, or now sometimes we find a patient who is 60-year-old and now want to change. So that is also happening. That happens lots of time in West, but in India that's also starting to happen. Another thing is, the only thing is venous thromboembolism, I already told, there's 200 higher time risk of because of HRT. So these are the another one of the important topic which I just want to touch upon is the human being wants more. So now there is more and more integration. They are coming into the mainstream. So the next step is once they are in the mainstream, they start living together, find a partner, start living a normal life. The next thing want is family, because they are still alone. They want to also expand the family. They also want to have the children. So that is another topic which we need to discuss with them before they go for surgery. Because again, embryo preservation, ovary preservation, ovum preservation, sperm preservation that can be done. So that is still possible because many of the trans males actually they have uterus and ovary, and testosterone leads to only temporary suppression. As soon as it discontinue, they can have their own ovary and ovum. So fertility is possible. It's not the end game. So that is we need to tell them. So last slide. So there are some legal hurdles. We still do not know what to do in adolescent. We still do not know which category sports, male or female. There's lots of controversy. This keeps on happening once in a while. We all read in the paper. It's a multidisciplinary work. Multiple people should work together. And then there should be adequate skill to get the good work done, HRT, surgery, and also that good outcome can be there. And of course, the last not but the least, the sensitization of community, sensitization of doctors. Just to highlight the fact, it's not a disease. It's just a natural variance. And we should stop treating it as a disease. Thank you very much.
Thank you, sir. We are pleased to welcome Dr. Nakul Somani, a distinguished plastic and cosmetic surgeon with expertise in aesthetic transformation. He is the founder and director of Sana Aesthetics Jaipur and a visiting consultant at Apollo Hospital with international training in cosmetic surgery from UAE. We look forward to his expert perspective and contribution to today's symposium. We welcome you, sir.
Thank you so much. Okay, so I thank Dr. Manju and the Indian Psychiatric Society for inviting me and to talk about this sensitive and less spoken topic, that is gender identity dysphoria. So as we heard Noor and Dr. Rajiv sir about the psychiatric problems, about the endocrinologist problem. So as we know, this is not a disease, as we have heard from the sir and Noor also mentioned this. So it's a dysphoria. So definitely after the psychiatric evaluation, after the endo people, they start with the hormone therapy. What role do we play in their lives to make their lives simple and more happening? And to have a peace in their life actually, because dysphoria is something that they feel from the right after birth, maybe not right after the birth, but yes, as they start growing, like after 4 to 5 years time, they start feeling that they are entrapped or they are not fit into the body they are into actually. By the time they reach puberty, they want to take some decision, but in India, as we all know, that parents, they are not so open about this topic, about this dysphoria thing. So definitely they undergo a lot of struggle, a lot of problems during their life. So as a plastic surgeon, after the psychiatric evaluation and after the hormone therapy, Definitely for 1 year, as sir has mentioned, because many people, they come to us that, sir, we have the GID certificate that we have taken from the psychiatric people, but we don't have taken any endo suggestion or endo counseling, and we are not on any sort of HRT. So 1 year, this HRT is important if you want to go, if you want to undergo any sort of surgery. So as a plastic surgeon, my role would be definitely we work in a multi-team approach. So psychiatric people, endocrinologists, sometimes we take help from the general surgeons, gynecologists, urologists also in different aspects of the surgery. So I will not talk much about this theoretical part, but after the surgery, from male to female or a female to male, that what differences they feel in their life, how confident they feel, and a peace in their mind after the surgery. So I'll show you, I'll showcase the surgical procedures, I'll showcase the before and the after pictures. So if we talk about this female to male is basically a trans men, in which mostly 3 procedures are done. One is the top surgery, that is removal of the breast. Then the internal surgery, that is the removal of the uterus, ovaries, and the vagina. It is actually a vaginectomy. And then the phalloplasty. So in these 3 procedures, so this was the patient.
Age पे आने के बाद they feel they are not comfortable with the body they are into. The soul is different and the body is different, so they want to get rid of their body और वो अपने आप को transform कर देते हैं. So आज जो हमारे साथ patient है, well educated patient, उनसे पता करते हैं कि उनकी ये जर्नी कैसे रही और कितना टाइम लगा उनको अपना ये mind.
So it was a keyhole surgery. So done in 2 ways. One is a keyhole surgery in which we do a small hole into the breast area and we take the tissue out. And the another surgery is a double incision mastectomy. So talking about this particular patient, well educated, a lawyer by profession from UP. So UP parents, as we all know, quite strict, and the parents were also at some level in the government. So they didn't allow him for this surgery. But yes, he tried to manage and tried to convince the grandparents actually that I want to undergo this surgery. They came to me. So he was already had the psychiatric certificate, and though he was a well-educated patient, so was undergoing this HRT therapy also. So they came to me and they said, okay, we agree for this surgery. So kindly just help him because he is not at all in this situation that he just lost his family just 1 year before. So he came for the surgery. So this surgery was done in this case. The another patient was same from the UP patient only, but in this patient, instead of a keyhole surgery, we did a double incision surgery, double incision mastectomy. So same story was with this patient as well. उनका हमने 5 दिन पहले टॉप सर्जरी की है from kidney to main. So this is how it is done. We remove the breast and we give an incision. It is generally in those cases where the breast size is a little bigger, so we cannot make a small hole and take the tissue out. So this complete breast is taken out by incision. The first surgery that is the top surgery is the mastectomy की है, that is जो breast का tissue होता है, जो breast gland होती है, वो remove करके and we have given him Now, if we talk about the male to female vaginoplasty, that is a male wants to convert into a female. So, 2 surgeries are mostly done in this patient, actually 3. So, one is the breast implants, then it is vaginoplasty and the facial feminization surgery. So, in this particular patient, we have done vaginoplasty, that is by the penile inversion technique. So, in which we use the patient's own penis skin to create a vagina. So this is also something, a very important step in their life. After getting, this penis, when they took out this penis and when they see their vagina for the first time, they feel so happy, they feel complete after this procedure. So these plastic surgery procedures, they actually help them to have a peace in their life. The rest of the surgeries, so I'll just show the photos that how we actually do the surgeries. So this was a normal female. So from this forearm part, we try to create the phallus. That is the phalloplasty surgery is done by this method. We take the proper measurements and then we convert that skin into a penis. We take the penis out from the forearm skin, including all the vessels, all the sensory nerves, and then we put it into the area where previously it was a vagina. Proper and a normal urination, but yes, a patient can go for the further surgeries, like he can have a scrotum in which we can put the implants, the testicular implants, and also the benign implants, so that for a proper erection. This was the another case. Now, one more variation of this surgery is when patients, they are on the hormone therapy. So sometimes what happens is their clitoris, it increases in the size. So instead of going for a phalloplasty, so they can go for this metodeoplasty, in which the clitoris is converted into a, though not that proper size of the penis, but yes, not a major surgery. And patient, those who just want to have a, not exactly a family I would say, but yes, those who want to go into a relation and the female partner, they just want to have, that the male partner should have a penis. So this metodeoplasty can be done in those patients. Now if we talk about male to female, so we can convert the penis into a vagina. So this is how we convert it. We take out the testicular parts, we take out the glands, and this is the initial sponge that we put it into the vaginal cavity. After some time, like after 3 months time, this is the extra skin that we need to take off, and this is a redo surgery, not exactly a redo, but a vaginal rejuvenation surgery, and this is how the vagina looks after the vaginoplasty, sorry. Then for the male to female, this breast implants are also an important part. So after the breast implant surgery, they feel more confident. Some patients, they want to go for the body contouring surgeries also. So yes, liposuctions. In some patients, we go for the tummy tuck surgeries as well. And this was the patient, a very well-known transgender. She was Miss Transgender India. Now she has a filed herself for the Miss Transgender International, but she was not happy with the looks, so she wanted to, a more rejuvenated face. So we did a facelift surgery in this patient, and this is just a 1 month before picture. Now for the facial contouring, especially a male to female, some patients, they want to go for the hair transplant, because in males usually the hairline is a little recessed, so they just go for the hair transplant surgeries as well. For the skin whitening procedures, these are non-surgical things. Then yes, in the facial feminization procedures, this rhinoplasty plays a very important role to get a female-like nose, or even if the patient is getting converted from a male to female, then from female to male, then we can convert, or we can try to give him a male-like or a masculine-like nose. This was the case of tummy tuck. A female to male, though got rid of the this breast, but wanted a more masculine body, so we created this abs. That was a high definition liposuction for the abs creation. As sir has also mentioned this thing, that facial hair is a very problematic thing. So yes, facial hair removal with the help of lasers can also be done. Some patients, they want to give a more cute look to their face, so they go for the dimple plasties as well. Then high definition liposuctions can be done for the patients, those who want a more feminine look like bodies. In that same session, we can go for the buttock, the fat transfer, hip dips can be corrected. In the facial contouring surgeries, like in this patient, we have done a chin implant so that she gets a more feminine look. Rhinoplasty, in this patient. So as I mentioned before, that facial surgery, this is how we do it. So guys, we are doing the facelift surgery, and this is the incision that we get. Now as you can see, this is the scissor that I am putting from the neck area all the way. This skin is all free, goes up to the eye area. I'll show you with my finger. So this is the finger. As you can see, the skin is all free up to the neck region. So now, so yes, this is the life-changing surgeries for many patients.
and the patient will get very
Facial
good
fragmentation surgery in the form of brow lifting, facelift, rhinoplastics, chin implants.
Some part of the skin it is coming over the ear region. So this extra skin will cut and will suture it. We'll also suture the smash layer, that is the underlying layer. So
the hair transplant procedure. Trans women, after the breast implant, she wanted to get rid of this extra tummy part. So we did tummy tuck in this procedure, in this patient. The rhinoplasty.
We are doing rhinoplasty, so we will be correcting the bulbous stem. So yes, as you can see, please focus here. These are the lower atrial cartilages. So beautifully exposed. We are doing right.
This is the tummy tuck procedure. We take out that extra stem, and the patient gets a good contoured and a more flatter tummy.
So friends, हमने इंट्राओरली above the mandible region एक pocket बनाया है. Now we will put in the strip.
Now in the body procedures, liposuction is very common procedure. It is done for the abdomen as well as for the back also. So the trans women, those who want to transform or they want a more defined look of their body, they can go for the liposuction. This is how it is done. This extra fat is taken out from the abdomen or the back area of your body. So yes, that's all. As a plastic surgeon, this is how to gain more confidence and to have a peace in their life. So if any question?
Thank you, Dr. Nakul. Rajiv. It was indeed a great experience to have all the professionals involved in these kind of surgeries, and the person herself has experienced, the surgery and the aftermath of the surgery. And she has also underscored her anguish with regard to the professionals, the doctors who still do not acknowledge the importance of their feelings, and sometimes they feel shattered the way they have been treated even by the professional, not by a layman. So thank you so much for sharing your experiences with us, Rajiv and Dr. Nakul. And I thank you so much on behalf of Indian Psychiatric Society Rajasthan chapter for being with us and sharing your expertise. And since we are already running short of time because we have a quiz next session, so I would request all my audiences to, if you have any kind of query, then you can get in touch with them personally. And I request you to please announce to them.
Thank you, sir. We are delighted to welcome Dr. Bhavuk Garg, Associate Professor in Psychiatry at Lady Hardinge Medical College, Delhi. He serves as a consultant to the National Mental Health Program and is a key member of several national committees. With a strong academic foundation from MAMC and ABAS, his contributions span clinical work, research, and policy. His interests lie in community psychiatry and child psychiatry, with numerous publications and book chapters to his credit. We are honored to have you, sir, and we are honored to have him with us today to share his insights and experience.
I'm sorry, Dr. Bhavuk, I didn't know that we have two more speakers, but I request you to please be concise, okay? Yes, because we have to be concise.
Okay, so I think after the insightful discussion from Noor and the previous two speakers, my work has been again made easier. So I'll touch mainly on the psychiatric aspects. And I have to specifically talk about the informed consent and certification, legal and ethical responsibilities of a psychiatrist. So I think this part touched in the morning session, and the speaker after me I think will also cover these aspects. So gender identity disorder or gender dysphoria and gender incongruence in the morning session I mentioned how we have moved from disorder to incongruence. The earlier concept of disorder from DSM-3 to then DSM-4 had gender identity disorder and DSM-5 had gender dysphoria, and currently we talk about gender incongruence, and the criteria about having distress or dysphoria is not necessary to diagnose as gender incongruence, and the diagnosis of gender incongruence is not under the mental health chapter but under conditions related to sexual health. If you look at the ICD-11 diagnostic criteria for gender incongruence of adolescents and adulthood, it says it's a marked incongruence between the individual's experienced gender and their assigned sex at birth, and the individual experiences a strong desire to be treated as a person of the experienced gender, or varied of primary or secondary sexual characteristics and require the sexual characteristics to experience gender. Important thing to note that the experience should be present for several months, although it does not define how much the duration is. ICD-11 I am talking about. And the diagnosis does not require the presence of distress or impairment. It can apply to both binary and non-binary identities. Someone was asking me during lunchtime, I think this will answer the question. And not a mental disorder in place with a condition related to sexual health. We also have criteria for gender incongruence of childhood separately. Personal intense incongruence between experienced gender and assigned sex evident in pre-pubertal children. Strong desire or insistence that one is of another gender. Dislike to sexual anatomy, strong preference for cross-gender role in play or dress, rejection of typical gender roles assigned at birth. Again, present for several months and should not be based on gender non-conforming behavior alone. This is very important. And again, distress is not required, but may be present due to social rejection or depression. In DSM-5 here, we have what we normally call as gender dysphoria under mental and behavioral disorders. It provides a duration of at least 6 months, whereas ICD-11 does not require any specific duration, it just says several months. Core requirement is marked incongruence and distress. ICD-11 does not talk about the distress part. And each specific criteria both have for children, adolescents and adults. Again, transition for desire is necessary for DSM-5 tier diagnosis for ICD-11. May include desire for transition, but it is not necessary. And DSM-5 criteria are more relevant for binary transitions that you do, male to female or female to male. But we have, as I mentioned in the previous session, that there can be non-binary presentations as well, and ICD-11 definition or the criteria cover those better as compared to DSM-5 text solution. So if you look at the legal and ethical aspects, we were very rightly saying that the persons belonging to transgender community, they face a lot of stigma and microaggressions from the professionals. So we need to, as psychiatrists, we need to provide affirming and non-discriminatory care. I have covered those aspects in the morning session. We need to take informed consent, ensure capacity and understanding, especially for medical transition, and legal obligation by age and jurisdiction. So for example, in India right now, surgeries below the age of 18 are not permitted. We can only go for advice surgery after the age of 18. Confidentiality and privacy needs to be ensured. Conversion practices, again, they need to be ethically condemned, and we can be as psychiatrists and mental health professionals support identity exploration and not suppression. We need to have professional competence. We need to be updated with the latest guidelines, WPATH guidelines from the Ministry of Health, DSM-5 tier and ICD-11 criteria. We need to have multidisciplinary collaborations, more such sessions in which we have endocrinologists, aesthetic surgeon or plastic surgeon, urologists, surgeons, gynecological surgeons together on the same forum to discuss these issues and make each other aware about the current updates. And we need to, as mental health professionals, we need to be advocates and follow the principle of justice, that is the principle of justice. So in legal aspects, we have two major documents notified in the Gazette. The Rights of Transgender Person Protection of Rights Act and Transgender Person Rules 2019 and 2020 respectively. I would urge all of you to please go back and read some of the sections I have discussed in the morning session. So how one should go for assessment of gender incongruence as a psychiatrist? How should we proceed? It's a multidimensional approach. So like any kind of mental health evaluation, it begins with a clinical history and individual history taking, personal gender history, gender roles and behaviors, experience of gender role behaviors in childhood adolescents, experience of social, legal or medical transition, current experience of incongruence, degree of distress or discomfort, body and social dysphoria, duration and consistency needs to be established as part of history taking. We can also go for psychological assessments, especially we need to screen for other comorbidities like depression, anxiety, history of trauma, suicidality and substance use. Because presence of significant severity of these conditions is a contraindication for going for gender affirming procedures. And we need to consider differential diagnosis like body dysmorphic disorder, dissociative symptoms. Someone was mentioning in the morning again, OCD as well. We need to look at protective factors also, the coping, resilience, strengths, sources of support from the family of birth, and there is a concept of chosen family. Many a times these persons from this community live in, they have their own chosen family structure, so we need to look for support from there. We need to assess the internalized stigma or minority stress, again discussed in the morning session. We can use certain psychometric tools like gender identity or dysphoria questionnaire, and for common with respect depression or anxiety inventories, PHQ-9, GAD-7, etc. Medical and endocrine evaluation in liaison with an endocrinologist. Hormonal status, puberty stage, reproductive considerations, physical health assessment, which should be done baseline before the gender affirming treatments. And like sir was mentioning, it's very important to have a fertility preservation counseling before going for gender affirmation procedures or treatment. Look for family and social support, cultural and religious influences, school, work and legal context as well, especially in terms of bullying, discrimination, policy barriers, and the legal gender recognition. We need to, by knowing the act ourselves, we can tell them and help them to know that how they can apply for a gender certificate, how they can apply for change in their documents like Aadhaar card, etc. Informed consent, we should ensure that they understand the options and the potential outcomes is very, very important. Sir was mentioning in the previous session that before irreversible procedures, that process needs to be done. They should be aware of the complete process and what the outcome can be. Otherwise, many times we face a situation that they are not happy and they want to revert back. But after irreversible procedures like surgeries, it's difficult and sometimes impossible. We need to assess the capacity for informed consent, and it should always be a collaborative care planning. We should coordinate with the other specialities before taking any further steps and decisions. Some principles that we should follow as psychiatrists while offering our services for gender incongruence and gender affirmation procedures. The approach should be affirmative and non-pathologizing. I have discussed this in detail in the morning session. Recognizing that gender diversity is a natural way, avoid framing identity as disorder and prioritize affirmation and not correction. Respect self-determination in identity and transition goals. Balance adolescents' autonomy with developmental needs. Respect the identity and language. Use a firm name and pronounce consistently. If you are unsure, you should ask. Never assume. That's the most important principle. Simple question like how would you like to be addressed? That goes a long way in maintaining trust and confidence, improving the relationship. Developmentally appropriate evaluation needs to be done. Avoid pressuring or labeling, especially in children. Focus on gender exploration and identity formation. Recognize the legal, the cultural and religious context. Avoid ethnocentric assumptions. Don't bring your own ethnic assumptions onto the person that you are helping. Have a trauma-informed care and safe environment. Should not re-traumatize the person. Don't ask all the questions repeatedly and remind them of the trauma that they have faced throughout their life. Multidisciplinary collaborative care cannot be emphasized enough. Focus on strengths and support. Focus on the resilience and protective factors. Confidentiality and ethics need to be upheld. Be aware of legal obligations and rights. Practice ethically and transparently. And be open and flexible in your approach. Acknowledge fluidity in gender identity. Again, we cannot assume that even in gender incongruence, we cannot assume binary identities like male to female, female to male. We will have gender fluid presentations as well. And support evolving self-understanding. It's a dynamic process. Daily we are learning new techniques and new knowledge is coming up. We should be aware and orient ourselves with the advances in the medical science as well as the philosophy behind it. The most important thing that we can do is follow evidence-based medicine, and we all know that evidence-based medicine is a combination of clinical judgment, relevant scientific evidence, and patient value and differences. While offering services for gender affirmative care and gender affirmative procedures, keep updated with the relevant scientific evidence, know the latest guidelines and the latest international norms in terms of mental health, endocrinology, and surgical procedures. Exercise of clinical judgment. That which particular procedure would suit a particular patient, which particular technique would be useful for a particular patient, and always take into account patient values and preferences. Collaborative decision-making process approach should be there. Treatment has to be individualized. There is no one-size-fits-all model to go. And EBM for the students, very important, comes as a short note given by second. So please be aware of this. So guidelines, we have two major guidelines. World Professional Association of Transgender Health, which had come out, the latest are the Standards of Care version 8, which are available freely on the internet. It gives the criteria, different chapters of mental health, adolescents, children, adults, and the criteria for surgery, criteria for hormonal treatment, some hormonal treatment protocols as well, and the various surgical approaches. And the Indian version, Association of Transgender Health in India, in collaboration with Parth and IPAT and Jamia Institute of Medical Science and Research, they had taken out Indian Standards of Care Volume 1. This was based on WPAT 7 and I think they have not been revised recently. So this is very important. So Ministry of Health, Director General Health Services, Ministry of Health had come out with these standard operating procedures for medical treatment of transgender persons, and I was one of the members of the same and was the coordinating member of this document. And we had experts from psychiatry, urology, obstetrics, gynecology, plastic surgery, general surgery, endocrinology and dermatology from the 3 central government medical colleges in Delhi as well as MGUMST in Delhi, Medical College, RML, and Surgeon Hospital. And we had brought out a very comprehensive document, and this is available on the website that I have mentioned below, freely available, website of DTE.GHS in the resources part. So please note down and go through these standard operating procedures. So I have taken out the excerpts of relevant to the psychiatry from these guidelines. So the guidelines mention the role of mental health professional, psychiatrist, and or clinical psychologist as per availability. The primary role of mental health professional would include assessment of gender incongruence as per the current diagnostic system followed by World Health Organization and certification for the same. Before endocrinology treatment, certificate from one psychiatrist is required. Before gender affirmation surgery, 2 certificates are required, one by a psychiatrist and the second one certificate by a clinical psychologist or psychiatrist. Along with that, mental health professional would also assess for distress and comorbid mental and or substance use disorders and provide management for the same. They would also provide support or therapy, is very important, if needed to cope with the issues related to gender incongruence, including participation in integrated cross-disciplinary care and intersectoral collaboration as required for clients and caregivers. And support usually begins before the gender-affirming treatment per se, as well as follows the hormonal as well as gender-affirming surgeries. So pre and post surgery as well, if need be and if required. The guidelines do not mention that a gender affirmation surgery board is necessary in all cases, but in centers which have an option to create a board if required, they can create a board consisting of 2 mental health professionals, at least 1 psychiatrist, 1 endocrinologist and 1 specialist from concerned surgery department, and 1 representative from the hospital administration, that is the medical superintendent, medical superintendent can be part of this. So the guidelines also mention recommended therapeutic flow, and this will answer many of the questions that have been coming up since the morning. So a person would come and get registered at the hospital. They'll be referred to the psychiatrist as a first step. Comprehensive assessment for diagnosis of gender incongruence and comorbidities, other mental health issues and WHO and substance use disorders as per the latest WHO diagnostic system. If criteria for gender incongruence are not met, management of psychiatric treatment should be done. If diagnosis of GI is made, certificate of client eligibility for hormonal treatment is provided, which is signed by a psychiatrist, and referred to endocrinologist for hormonal treatment unless contraindicated. They give the contraindications for hormonal therapy in such cases. Minimum 1 year of hormonal treatment. Again, this was a point of contention. We got many presentations that the latest WPAP guidelines, they recommended 6 months period is good enough. But considering the Indian context, a decision was made to keep it at least 1 year, and like sir was mentioning in his talk, many of the changes they take around 12 months to 24 months to come into effect, and then the surgical procedures are more acceptable and outcomes are better. During this time, regular follow-up with mental health professional has to be ensured. If required, refer for gender affirmative surgery to specific surgical department. Before that, certificate by 2 mental health professionals, 1 psychiatrist and 1 clinical psychologist / psychiatrist, and also a certificate from endocrinologist is required before the gender affirmation surgery is started. And post-surgery hormonal support and post-surgery psychiatric support needs to be continued. It's a continuous process, and in many cases a lifelong process for hormonal support. Thank you.
Thank you, Dr. Bhavuk. Thank you for respecting our session. And Aninda, I know the wonderful orator, she will also respect our request and expect that to be considered there. But before that, two of our guests are supposed to leave. I would request please.
Since we've pushed past the point in time and we are humbly apologetic for it, but before they proceed, we'd like to call upon Dr. Rajiv Kastabal sir and Dr. Nakul Somani sir. We'd like to be grateful and we'd like to felicitate you. Thank you so much, sir, for your valuable time. We are now honored to welcome our next speaker, Dr. Ananda Siddhana, Assistant Professor of Psychiatry at Dr. S.S. Kandiya Medical College and Hospital, Sri Ganganagar, with extensive experience in addiction psychiatry and community mental health. She is deeply committed to both clinical excellence and academic mentorship. She actively teaches postgraduate students, mentors psychology interns, and serves as a member of POSH committee. We welcome you, ma'am.
Welcome, Aninda, and please stay put. We have many questions for audiences as well in next session. So request you all to do it.
So today, I will take you through the journey of, basically the tree of life of a LGBTQ individual. Navigating the coming out journey. Why I say tree of life? Because as it is imagine like a seed, you don't know what you are going to become, what identity you are going to get. So similarly, you don't know what seed is going to come from the soil and the roots. There are a lot of challenges which are the mental trauma, stigma from the society, discrimination, and leading to, and that trunk which comes like we can take up more of a trunk by giving them the support, by giving them the mental wellness program. So this, as in 2006, Prince Manvendra Singh Gohil, he actually, despite coming from the royal roots, he came out to the society as a gay prince. He was the first one to come out, served a lot of backlash, but still he thrived with the support and showed the resilience as the tree. So he grew it. So the mental wellness is much more important to talk. It is but first I will show you the tree of this. So basically it is like the navigating the tree of life for the LGBTQ community. So the challenges they face is very different: social discrimination, fear of rejection, trauma, lack of support, and then there is post-traumatic stress disorder coming out. Then we can provide them affirming care, trauma-informed care, self-acceptance, authenticity, and then the fruits are good and we can make our places DEI, diversity, equity, and inclusion. So that is the tree of life which I wanted to take you through. So now we can go through the presentation. So basically, it's not a presentation. I don't want to state the facts. I want to build the empathy in you to treat the patient with LGBTQ. That is, and to bring you to the advocacy for that. And it's like how many of so the LGBTQ anyways is a history. From history it has faced a lot of backlash. People were treating it, criminalizing it, then they started accepting, but again now the Trump has given, again the backlash has come. So now it is from history to acceptance to advocacy, and again there is some difficulty which is going. So instead of the definitions, let's talk about what is coming out. First I would like to ask, how many LGBTQ friends do you have? Do you know anyone who is LGBTQ or who has come out or you have any LGBT? So first So I know there is a group of 400 doctors, WhatsApp group, who have already come out and all the processes coming out and only from India. And they are only doctors, 400 doctors are there in the WhatsApp group. And also there is an organization run by MGUMST, which is a matrimonial organization, Mr. and Mr. Gay. They have every month they have a meeting in which gay matrimonial is decided and they have this. He is the co-founder. And they run the Hobby Club of India in which they deal with the mental health struggles. So there is a lot of acceptance and a lot of things coming up. So gender is of the mind and while sex is of the body. And I always say gender is between the ears but sex is between the legs. So there is a lot of difference between gender identity and sex. So I think definitions and all, anyways we have covered it since the morning it is going on. So I would like to know if I should repeat it or should go with the coming out process. So coming out, first you don't fall in love with the gender, you fall in love with the person. So that is the one thing which we have to accept first of all. And coming out is not a one-time process. It's a lifelong process. It is not a sprint, it is a marathon. And it is not a marathon. You have to do it at your own pace. Some people take 1 month to come out, some people take years to come out. And also coming out is a lifelong process. Today I have to come out to my family. Tomorrow I will have to come out to my friend. Then I change my job, I will have to come out and there also. So it's a lifelong process. Every time I have to come out. First of all, why I have to hide in the closet? I am also a normal person. The best example I can find is like if I like non-veg and my sister doesn't eat non-veg, it doesn't make anyone abnormal. So if I like boys, she likes girls, or if I like girls, she likes boys, that doesn't make us abnormal. But the acceptance is definitely going to be difficult. Even if my parents are psychiatrists, they are also going to find it difficult. So society has to be educated and the acceptance has to come. So what is the feeling? The feeling like everyone is saying like we are suffocated and trapped in the body. So there is an inner circle of self-acceptance during the coming out process. Inner circle there is. So first of all you have to take care of your own self, accept yourself, be kind to your own self. Then to your inner world, self-compassion should be there. And then to the outer world. In the outer world, we all come. Psychiatrists, mental health professionals, anyone who is going to support them. So that is then they will stop feeling suffocated and they will stop having to hide in the closet. So what skills like Bhavuk has anyways defined many things. Like we should have empathy, we should have acceptance, and service providers should not automatically assume a client's sexual orientation or gender identity. As in the morning, Bhavuk gave the example, like we should not assume that a female is pregnant or not. We should not ask that history because maybe she is not. So that is important to understand. And also, before the patient enters your clinic, not the patient, the client, I call it. So before he enters the clinic, make sure your staff is also trained enough. If you are respecting the client, maybe your staff is not respecting, staff is making fun, then it all will anyways go to make the stress. So we have to make them educate the education and all begins from your institution level, from the lower staff to the highest authority. All have to be educated to make the places DEI friendly. And acceptance is the key. So all like we should, then the toilets are there. These have been explained. Yeah. So as I said, sleep vary from everyone. Some come because there is a lot of identity crisis first of all. Then there comes the tolerance level. Like one accepts it and then he tries to tolerate it. Like yes, I am okay. Then after a few months they will start socializing in the circle which is the gay circle. And then the total acceptance comes, even for the person, and then they will come out to the society. So even inner acceptance, the acceptance to me, my own self takes a lot of time. So that depends from person to person, how egosynchronic and whatever like their social ingrained behaviors and whatever society they are in. It depends. And how much courage they have, first of all, that is also the most important thing. So there is no right way to come out. I can call my parents, I can tell my sister, and I can just introduce directly to my parents, to my girlfriend. Yes, I have got my girlfriend home, but we live home. So, like this is the example. You know, girl is telling the boy, you know what I love about boys? Their girlfriends. So this is also a way you can come out and tell, yes, I am a lesbian, I don't like you, I like your girlfriend. So how do I remove the fear of being different? First of all, if a person comes to me and asks, I feel very different from everyone, how do I remove it? Acknowledge your uniqueness, cultivate self-compassion, love yourself. Acknowledge it that yes, you are different. Connect with the supportive communities, embrace your individuality, practice self-esteem boosting activities, and transform your negative thoughts. First of all, accept it. It is not a disease. It is absolutely normal. Whoever asks me, I just have one answer. I think you don't need treatment. Your parents need treatment. Give them. So that is my answer to every client who comes to me. Otherwise, like there are a lot of psychiatrists in Karnataka. You can go to them. You have come to the wrong place. And so this is a CAS model, which is the most accepted model of coming out. In which, first of all, there is the awareness, like confusion, whether I have the same sex, just the crush is there. Sometimes first kiss happens under the influence of alcohol, or then there comes the feeling of alienation, then the tolerance, acceptance, pride and sympathy. So this is the most accepted model till now. First role of mental health expert is mainly the confidentiality has to be maintained. Then also to prevent the psychological complication, because in India you never know if a person comes out, maybe it's from some caste or something, and suddenly a backlash happens and lot of like दंगे हो गए इस बात पर कि ऐसा क्यों कर दिया, and so there is a lot of problems. So we have to be careful about that also as culturally acceptable things. So factors to consider during the history taking is for when was the first time you noticed that you have sexual attraction, and how did you feel about it? Did you feel that was a mistake or were you comfortable with it? Was it just a one night stand? Was it anonymous or was it under the influence of alcohol? And how did you feel? And did you accept it later on? So these are the things, and then how stigma is there. We have to tell them to remove the stigma. And maybe for some time, and in India, not only in India, all over the world, for males, this homosexual tendencies, that is at times is a part of a normal life. Like once in a lifetime or twice in a lifetime, there is incidents. The studies have also shown that. Like I actually, in my presentations, I don't go much into the research. So what is the reaction of Indian parents? Like, oh ho, ki ho gaya, ye kya ho gaya, ya, hai main to mar jaunga, mere bacche ne aisa kar diya. This is the reaction. So this is the tree. Is basically the challenges faced. So fear of rejection, foundations of identity, sex, gender, roots are there, and what seed was there, you never know. And then acknowledge, cultivate, connect, embrace and practice. Advocacy and empowerment. So if my son, some parents come to me and ask, if my son comes out as a gay, what should I do? It's like a rainbow. Everybody enjoys the rainbow. I like normal likes to enjoy the different colors. Then why can't we enjoy the different colors of human sexuality, of the human mind, or human relation? So just accept it as a rainbow or the colors of the normal light. Respect his choices, accept him or her who they are, inquire with empathy and judgment, nurture the self-expression, be educated, educate yourself first of all, and be aware, and offer unconditional love to your anyways Everybody knows parents love their children unconditionally. So why not to offer the unconditional love even if they come out of the gay or lesbian? And welcome them with open arms. Just love them. Then someone needs help, approaches you, help them fight stigma by not judging, assurance and support. But remember that they are just different. Don't just listen. Inspire them and trust them and assure that there is no stigma. Foster the positive approach towards the life. Focus on the small steps and forward them to the helpline group. Then you can add them to the WhatsApp group, make them meet the communities and encourage towards self-care, meditation, exercise, yoga, journaling, relaxation. Then respect their boundaries and their space, how they want to come out. You cannot force them. He has come, stepped into your clinic and came out. We can't force him. आज जाकर अपने घर वालों को बता दो. No. Respect their space and the boundaries and their speed. Educate them about the mental health. Never, but if there is any suicidal risk, as always, that is not to be kept a secret. So try to be professional and be different. So what is mental fit? Everyone has a right to be mentally fit, so just teach them also how to manage the stress and anxiety, and teach them the exercises to enhance their mood and overall well-being, nurture the positive relationships, treat mental health conditions effectively. Because the mental health condition morbidity is more only because of the stigma and discrimination, but there is no genetic cause of having them more morbidity. Even the substance which will fall into, maybe the depression is the reason. I have got many clients, they were abandoned by the family members. And like for 6 months, 8 months they were abandoned and family was not talking to them. And they came with the complaint of only anxiety and depression. After 2-3 sessions, when I asked, then they told and they came up to the parents. After a few months, parents called me. We are proud of our children. They took them back to the family. So the post-traumatic stress disorder they go through lot of challenges you can't even imagine. How can you imagine being thrown out of your house just because of your identity, you love a boy? So, and in such a modern world, we are reaching the United Nations SDG 2030 and talking about SDG 5 gender equality, and now also we are not accepting that. So we should do that. So there are I got into this only because there were 2-3 clients and family members actually called me up no, we are happy with our children, they are doing very good and we are proud of them. But still the acceptance is not at that level they allow them to stay in India. So we have to make that acceptance at that level. और कुछ तो लोग कहेंगे लोगों का काम है कहना, दुनिया का सबसे बड़ा रोग क्या कहेंगे लोग, ये तो सोचना ही नहीं चाहिए सबसे पहले. And psychiatrists should be aware, compassionate, tolerant, or solidarity should be there. Advisory points: create a safe space, avoid pathologizing, and recognize intersectionality, support coming out and identity exploration, and address the trauma and minorities face. So these all areas have been explained very well by Dr. Bhavuk Garg. And DEI, we should lead, we should learn first, educate ourselves, advocate, and open the door for everyone to be and accept them how they are. Then only society can change. Psychiatrists should lead by this. And so this is like mental fit, arrange to manage their stress and anxiety, enhance their mood, nurture positive relationships. So because it's almost for everyone to do that. But the only thing, at times, lived experiences definitely improve and definitely encourage and help people break the silence. Even I myself share my story to help women break the silence and to get the courage. So, and yes, whenever I talk about LGBT community, I have been asked, are you a lesbian? So I tell them, no. I am just a crazy person with the thought that everyone should have equal rights. I am just a gay. I am not a lesbian or a gay. I am crazy that to believe that everyone has equal rights. So the power to transform the start with understanding and embracing the diversity, every act of acceptance moves us towards a more compassionate future. So as a psychiatrist, I would like to tell, you should all be compassionate and bring the change. We all can lead and be the change, support and help. Thank you.
Can we call upon our speakers, Mona, then we will start the next session.
I would request the chairperson to felicitate the remaining speakers, Ms. Meena, Dr. Bhavuk Garg sir, Dr. Ananda Sindhana ma'am. Now I would like to request Dr. Mahatma ma'am to felicitate Dr. DTE sir. I'd like to request Dr. Gandhi sir to felicitate Dr. Akhilesh Sharma sir and Dr. Ajmer sir to felicitate Dr. Govind sir.
Today afternoon, in fact, we had the preliminary round, and we have unprecedented participation in that from all the colleges across the state. And in fact, we had to involve the participants in second round because they somehow skipped the first round because they had gone somewhere or they were not allowed to come before they finished their OPDs. So altogether we had more than almost 25 participants. And we had to choose 9 participants out of 45. So it was a very tough competition, and you'll be surprised to know that on one point we had 8 participants among the other types. So we had to call them again and we had to re-examine them and then we had to choose, It was a quite tough job, but very tough competition as well, and I'm really happy to share that all of them have done so well in preliminary round. But then we have to finally choose only 9 participants. Dr. Kanchan? Okay, no problem. Then do we have Dr. Sonu? Dr. Sonu, please come and join the meeting. And Dr. Meena. Dr. Meena Sharma. So you come to that. So this is team A, right? We have to face the questions. Why are you shining? Now the team B, Manmohan. Then Dr. Shikha Chaudhary. Dr. Shikha Chaudhary. She was loitering around until now. Where she gone now? Dr. Shikha Chaudhary is not there. Anyways, Then do we have Dr. Himanshu? Dr. Himanshu? You are Dr. Himanshu? Dr. Himanshu, we don't have. Dr. Akanksha Sen. Do we have Dr. Akanksha? Deepa. Dr. Deepa. And then Dr. Shefali. Dr. Shefali Bhagat. Is she there? Dr. Ishan Kumar. Dr. Ishan, come here. Then Dr. Meena, Team C. Dr. Tarun Jodh and Dr. Rohan. All right. So we have three teams with us. You have A, you have B, and you have C. Right. So let me briefly apprise you about the rules. We are going to have 4 rounds. Okay. Round 1 to 15, 2 and 3 that will be disputed.
और वो क्वेश्चन भी पे डलाना है.
There is no passing of the question. This round carries each question carries 5 marks. No negative marking, but there will be no passing of the question. Each team will be given 2 such questions on their screen. They have to answer in 40 seconds. All right. Then we'll have round 2 that will consist of 1 question that will be a kind of case units. That will, there again will not be any passing of the question. The correct answer will carry 5 marks. That is round 2. In round 3, again we'll have 2 questions which are displayed on the screen. But in this round, there will be passing of the question if it is not answered correctly or if you want to pass it on to the next team. And to select the team, I had categorically told them that they are supposed to be there. Who are they? कौन आए? Dr. Shikha, for a moment, तीनों ही आ गए. So I take then 4 of them in each team because now I cannot disregard those who have already been called upon the dice, right? So you please come to this side, Dr. Shikha. You come to this side. Take care of it. This is unprecedented situation and we are going to accommodate each one of them because we have already called them, so we cannot sorry. Okay. Third round, you can let the question go to the next team if you do not want to answer it. But again, there is no negative answer. Fourth round, third round is chosen by lottery.
जैसे ही फर्स्ट राउंड में क्वेश्चन बोले हमें 40 सेकंड्स का टाइम लगाने में
पर मैं उनको बोल
And it is your applicant that how many answers the questions you answer correctly, okay? And again there is no negative marking. So shall we begin with the so we shall go team A first. Team A, are you ready? All the 3 teams. So we shall display the question here on your screen and you have to answer soon after you look at it, right? Yeah, you can. Which among the following is not atypical bipolar symptom? Euphoric, correct answer. Give them a round of applause, they have answered. Now team B, can you question? What is the main focus of each stage in Erickson's theory of development?
Strong sense of self.
Sorry, it is developing psychological qualities. This is answer is B. Now team C. Your question is here. Which among the following is non-paraphilic compulsive sexual behavior? C, correct answer. Give them a big round of applause, please. Now team A is again a question. Which among the impulsive control disorder is included in ICD killer? B, correct answer. Team B, here's the question. Which among the following is considered a good prognostic factor in OCD?
B, only obsessions.
Correct answer. You should be clapping for that. They have to. So you see, here's your last question. What is the main symptom of GAD?
C, worry.
Sorry?
Worry.
Correct answer. We are lucky to have this simple question, but we can't help it. Thank you so much. We are thus have completed the first round. And can you tell me the score of the first round of each team? Okay.
Team A 10, Team B 5.
Give them a round of applause here. Okay, 10, 5 and 10. Alright. So now we move on to this next round, that is the base unit round. Again, you will be given 45 seconds and there's only one question in this round and the correct answer will carry 5 marks. Okay. So here's the question for team 1, team A. So चलाओ भाई. This is the question. Is the correct answer. So, JP, here's your question.
D, increased protein binding fraction.
Or it is a reduced proportion of body fat. Team C. Here's your question.
C. REM.
Correct answer. Wonderful. So now we have completed round 2. Dr. Sunil, can you let the participant know their score after round 2?
After 2 rounds, DA on 15, D on 5, and C on 15.
Please give them a big round of applause. They have done well until now. So here, now we're going to have round 3rd, wherein we shall start questioning by this lottery system. The team chooses A. We shall start from there. So can you slip? आपकी तरफ से मैं ले रहा हूँ B 3 you 1 okay so we will start from there only. In this round we shall have 2 questions again on your screen, no negative marking, or obviously you have to answer it, and if it goes correct it is fine. If it goes wrong, then again we will not pass it on, because if you keep passing on, then you will have only one option left. If you leave it to the next team, then only we will, right? But nobody will leave. So we are putting up the questions on your screen now. Answer will go to the next team. Sorry? Correct answer. If you don't answer correctly, it will go to the next team. I had spoken it earlier. So for team B, the question is here. Which of the following is not a number given by Melanie Daisy?
You are blocking the visual. Sorry? You are blocking the visual picture over there.
B. Reaction formation.
Correct answer. Give them a round of applause. So team C, your question is there. Which of the following document is based in Margaret Mallar's essay? Sorry? B is the correct answer. Holistic list. This again your question number 2 for team A. Secure base is the correct answer. So team B, here is the question.
C. Unconditional stimulus.
Sorry?
C.
No, it's wrong answer. B is the correct answer. So this is the question, the last question for team C.
C. Classical chemistry.
Sorry?
C. Classical chemistry.
No, sorry, this is negative reinforcement. Thank you so much. With this, we conclude round 3. Dr. Sunil, can you tell the score of each team?
Team A 30, Team B 10, Team C 20.
These are the numbers. So we all still have a chance to recover. Now we are going to have the rapid fire round, where we will be asking each team 5 questions and we will have 2 minutes. Now it is up to you how aptly to answer those questions, right? After 2 minutes, we will stop asking. So now I start your time. Is it fine? Shall I start? Is it 2 minutes? Okay. Question 1. Which dopamine pathway is implicated in positive symptoms of schizophrenia? Correct. I believe that a familiar person has been replaced by an imposter called what? Sorry? Kepler. Correct answer. Which EEG finding is seen in hepatic encephalopathy? EEG finding is seen in hepatic encephalopathy. Sorry, try to be clear. What is the most common side effect of clozapine after sedation? Correct answer, hypertension. What is the main mechanism of action of lamentine in Alzheimer's disease? NMDA antagonist. Correct answer. So they have completed their rapid fire round. I am going to see B. I am going to take 5 questions and you have to answer in 2 minutes. Shall we start? Right. What is the term for repeating the same response to different patients? Correct answer, persuasion. Which personality disorder is most likely to use misleading as a defense mechanism? Borderline. Correct answer. Which antipsychotic is least likely to cause extrapyramidal side effects? Clozapine is correct answer. Which SSRI has the longest half-life? Fluoxetine. Correct answer. Which cognitive domain is most affected first in Alzheimer's? Which one? Correct answer. Now go to team C. Shall I start? Which enzyme metabolizes serotonin into 5-HIAA? Which enzyme metabolizes serotonin into 5-HIAA? No, correct answer. Which antidepressant is avoided in eating disorder due to seizure risk? Ibuprofen, correct answer. What is the antidote for serotonin syndrome?
get back to the question?
Sorry?
Can we get back to the question after answering that?
What is the antidote for symptom? Next question, okay. What is the mechanism of action for surfactant in treating insomnia? What is the mechanism of action for surfactant in treating insomnia? Correct answer. For example, receptor antagonist. Which neurodevelopmental stage, which neurodevelopmental gene is associated with that symptom? Her last answer is correct and CP2, but they have not answered one question. It was psychoactive for your information. So thank you so much. Now we have completed all the 4 rounds, and I have one question for our audiences as well. Which area of the brain is primarily affected in course of psychosis? Mammillary body. Okay. What is the term for inability to recognize one's own illness? Sorry? What is it? What is the term for the abrupt switching from one topic to another without logical connection in manic speech? Sorry? Wonderful, great.
उनका एक मेंबर भी कम था runner up with point 24 team C.
Team C, great.
And winner for this evening is team A with 34 points.
You are really wonderful, great. Your aptness, your in-depth knowledge, response, everything was wonderful. And I will request each one of you to please come on the dais there to have a photograph with us. I will request Siddhana sir. Let me tell you one thing. I have conducted many such vigils. The one person which I have always seen sitting till the end of the feast is Dr. Siddhana. That shows really loves being here. So I will also request Siddhana sir to please come here, Dr. Tushar sir and Dr. Jitendra. Please come here to have a picture with our participants.